Good morning, all. Welcome you on the 9th edition of KOVAI Heart Rhythm Summit. My sincere thanks to all for being so early on a Sunday morning. Straight away, we'll go on with the sessions. The first session, the first talk will be by Dr. S. Balaji sir on role of implantable cardiac monitors after myocardial infarction. We all know it's a very important part of managing patients with ischemic heart disease, particularly after a post-MI situation. Let me invite the moderators for the session, Dr. Badri Narayanan, Dr. Vigneshwaran, Dr. Sivabal, Dr. Sujay Nikhil, Dr. Praveen Raja, Dr. Mohammad Ibrahim, Dr. Krishna Kumar, Dr. Devigan, and Dr. Prabhu Venkatesh sir. You will be moderating all 4 talks for the first session. After an initial talk of 20 minutes, we will have a discussion with panelists and with the audience for the 10 minutes. Thank you. Dr. Balai sir. Can you project the slides?
Good morning, everybody. I'm happy to be here today, and I thank Dr. Lawrence for giving me this opportunity. I'm also happy to see this Heart Rhythm Summit growing rapidly from year to year. Thank you, Dr. Lawrence. I'm going to be speaking on the role of implantable cardiac monitors after myocardial infarction. So we will look at briefly about myocardial infarction, management of myocardial infarction, evidence for the use of intracardiac monitor after myocardial infarction. So as we all know, myocardial infarction is a leading cause of death and morbidity, and patients following an MI are at increased risk of adverse clinical outcome, and the presence of arrhythmias further increases the risk. Now, implantable cardiac monitors can allow early documentation of arrhythmias, which may be asymptomatic in a lot of patients, which would otherwise go undetected. So post-MI patients may benefit from arrhythmia monitoring by intracardiac monitors. Basically, as we all know, atherosclerosis causes coronary artery disease, and coronary artery disease accounts for about 90% of all cases of acute MI. So there's a very high burden of ischemic heart disease. 126 million individuals were affected in 2017. Prevalence is higher in Western Europe, South Asia, and than the rest of the world. And 9 million people died from IHD in 2017, making it the leading cause of mortality worldwide. Now, we all know we can divide myocardial infarction into STEMI and non-STEMI. And STEMI is when there is a complete occlusion of the vessel and there's extensive heart muscle damage, and NSTEMI when there is absence of ST segment elevation but the enzymes are elevated, and both have elevation of cardiac enzymes. If we look at myocardial infarction, the majority of MI patients suffer from NSTEMI, approximately 60 to 70%, and in-hospital mortality is similar between STEMI and NSTEMI. 1-year mortality after hospital discharge is, however, higher from NSTEMI than from STEMI. And NSTEMI patients are typically more older and are more likely to have a history of several comorbidities. Now, if we look at the complications after MI, there's a high risk of death from complications after MI. If we look after a first MI, 23% of patients die before reaching the hospital. 13% die during hospital admission. After hospital discharge, the cardiovascular mortality is approximately 10% in the first year and 5% per year thereafter. And after 15 years, the cumulative cardiovascular mortality is 70%. We'll see the common complications after MI. It could be cardiogenic shock, arrhythmias, heart failure, cardiac tamponade, mitral regurgitation, embolism from LV thrombus, and pericarditis. And our focus today will be on detection of arrhythmias post-MI. So why do we have more arrhythmias post-MI? Both ventricular and atrial arrhythmias are common, not only early after MI, but also long-term after MI. Usually, tissue necrosis leads to myocardial scar development, and tissue necrosis occurs within 30 to 40 minutes of sustained ischemia. The scar develops from 2 weeks after MI, and its formation is complete after the second month. Scar tissue causes cardiac dysfunction. It reduces the ejection fraction and impairs electrical conductance, thereby forming a substrate for arrhythmias. So if you look at the risk marker, the left ventricular ejection fraction is considered the risk marker for life-threatening arrhythmias, and usually arrhythmias that occur after MI are associated with a low left ventricular ejection fraction. 15 to 20% of all MI patients have low LVEF less than 35, and when the EF is less than 35, these patients are usually a candidate for ICD implantation. If we look at the long term, a substantial portion of patients post-MI with depressed LVEF, but not less than 35, which is ICD indication, have long-term cardiac arrhythmias. We will look at the data shortly. So myocardial infarction is caused by ischemia. We have two types, STEMI and NSTEMI, and MI patients are at higher risk of arrhythmias and other complications. And if we look at the patient management, now we have clear guidelines for both STEMI management and NSTEMI management. And in addition to the usual medical treatment, today percutaneous coronary intervention has become the standard of care for acute MI. And also, although thrombolysis still plays a role when primary angioplasty is not possible. If we look at the differences in management between STEMI and non-STEMI, during hospitalization, we find that NSTEMI patients receive less cardiac medications and less PCI. The likelihood of receiving early medications was higher in patients with STEMI. 2/3 of MI patients underwent PCI during hospitalization. However, 71% of patients with STEMI had PCI. Only 51% of patients with NSTEMI had PCI. Bypass surgery was more frequent in NSTEMI patients than STEMI patients. Now, looking at the follow-up post-MI, similar guideline recommendations are there for STEMI and NSTEMI after hospital discharge. However, MI patients are usually seen by the primary care provider or cardiologist as per the local practice. Now, the post-MI follow-up in most patients is usually suboptimal. Patients had if you look at data from the Western world, patients had a mean number of 11 GP visits during the year. 41% of patients did not have a consultation with a cardiologist. 45% only went to a cardiac rehab center, and 23% had one hospital readmission for various reasons. So, although the guidelines for STEMI and NSTEMI recommend similar therapies and interventions, adherence to guideline recommended treatment is suboptimal in both categories, especially in NSTEMI, and there might be room for improvement in this population. Now, let us look at the role of intracardiac monitoring after myocardial infarction. So, before I go to the three studies which I would briefly discuss, Charisma, Smart MI and BioGuard MI, which give some guidelines on how to treat these patients post-MI. So what is a implantable cardiac monitor? Basically, you can make a small incision as an outpatient procedure, subcutaneously implant the monitor. It's a OP procedure, and the monitor can connect with the Bluetooth, and the heart rhythm can be monitored in post-MI patients. It's a very minimally invasive procedure. So is this useful? Is this recommended in patients with following a myocardial infarction to detect arrhythmias? So let us look at the data. The first study, as I said, is the Charisma study. This was an observational study. This was done to document the incidence and prognostic significance of arrhythmias using an intracardiac monitor in patients after MI with an ejection fraction less than 40%. So 297 patients were there in the study, LVF less than 40%. All patients were implanted with the ICM 11 days after MI. The mean follow-up duration was 2 years, and this was a Medtronic device. The endpoint was cardiac death and all-cause mortality. And if you look at this, 46% of patients had at least one arrhythmia documented during the 2 years of follow-up, which is a high number. and 86% of arrhythmias were asymptomatic. Now, what were the arrhythmias detected? Sinus bradycardia in 20%, sinus arrest in 16%, new onset AF, high degree AV block, non-sustained VT and sustained VT, and any arrhythmia, the incidence was, as I said, 46% in this group. So, cardiac arrhythmia which occurred 24 hours preceding death was noticed in a lot of these patients, and if we adjudicate the risk, high degree AV block was the one which had high mortality in these patients, followed by sustained ventricular tachycardia, which had a hazard ratio of 3.61. So this study showed that long-term cardiac arrhythmia incidence was high following myocardial infarction in patients with moderately reduced ejection fraction. Clinically significant arrhythmias were documented in a substantial proportion of patients, and these arrhythmias were predictive for outcome. So the question remained, will an early detection and consequent treatment of ICM improve long-term outcome in these patients? Now, let us look at the second study. This is a SMART MI study, again to show that telemedical monitoring with ICMs in patients with autonomic dysfunction after MI, whether it could improve the detection of arrhythmias and improve the prognosis. This study was a randomized study. The previous study was an observational study. This was a randomized study, 1:1, with intracardiac monitoring or conventional care. There were 400 patients. LVEF was 36 to 50%, because the patients below 35% would be a candidate for implantable defibrillator. So this was 36 to 50%, which is only moderate LV dysfunction. Median follow-up was again 21 months, and again a Medtronic device. And the endpoint was time to detection of serious arrhythmias. And again in this study, serious arrhythmic events were detected in 60 patients, which is 30% of the population of the ICM group, but in only 6% of the patients who did not have a ICM. So significantly more diagnostic and therapeutic interventions were done in the patients with ICM, including implantation of defibrillators, pacemaker implantations, EP studies, ablations, and starting of anticoagulation due to atrial fibrillation. So detection of serious arrhythmias in this study significantly predicted subsequent major adverse events and helped to alter the treatment in a significant proportion of patients. However, there was no difference in all-cause mortality or major adverse cardiac events between the two groups, because the study was not powered for the same, because there were only 400 patients. So the conclusion of the SMART MI study, this was the first randomized trial to report on long-term arrhythmias recorded by ICM in patients with moderate LV dysfunction. And telemonitoring was highly effective in early detection of subclinical arrhythmias, which were prognostically significant. The study was not powered to show difference, as I mentioned earlier. So the question remains, will an early detection and subcutaneous and consequent treatment improve long-term outcome in these patients? So I'll briefly discuss the last study. This was the BioGuard MI study. This was done to investigate whether early diagnosis of cardiac arrhythmias using a biomonitor with remote monitoring and subsequent treatment of the patients, would it decrease the risk to experience a MACE. The study was done in post-MI patients with high risk, and again LVEF more than 35%, so moderate LV dysfunction. So this was a randomized study, 1:1 with ICM with remote monitoring or standard conventional care. There were 800 patients in this study, patients after acute or chronic MI with LVF more than 35% and a high risk as defined by the CHAD-VASc score. So here it was a Biotronic device with home monitoring, and the primary endpoint was time to major adverse cardiac event. So what is this? In addition to ejection fraction, the BioGuard risk marker was used. So the other risk factors were noted, which was patients with CHAD-VASc score, which takes into account heart failure, hypertension, age, diabetes, vascular disease, etc. And the patients were randomized if the EF was more than 35 and CHAD-VASc score more than 4 in men or 5 in women. So the patients were followed up by the general practitioner or cardiologist. Patient visit at the site only after relevant arrhythmias were detected by monitor, and patients were called after 6 months. This was the first trial to investigate whether early treatment after ICM documented arrhythmias in high-risk post-MI patients improves outcome. There were 398 patients in the ICM group and 392 patients in the standard group, and arrhythmias were reported by telemonitoring, and events were collected by phone. And these were the changes which were done to treatment based on the ICM monitoring. Oral anticoagulation had to be started in almost 40% of patients due to AF. Pacemaker implantation happened in 15 to 20% of patients. Beta blockers were decreased or increased in a significant number of patients. ICD was implanted in about 5% of patients, and a small group had ablation also. So if we look at the primary endpoint, among the 800, a total of 218 patients experienced a primary endpoint, but however, there was no significant difference in primary endpoints between the ICM arm and the control arm. However, if you split it into STEMI and non-STEMI, the STEMI group, there was no difference, but in the NSTEMI group who had an ICM, who were treated subsequently for arrhythmias, there was a 31% reduction in the events reported in the NSTEMI group. This was because there was a higher risk in the patients in the NSTEMI group, as we discussed in the initial slides. So, arrhythmia monitoring and high-risk post-MI patients in this study identified arrhythmias requiring treatment in 40% of patients within 2 years, compared to 6% in the control population. The study population did not have a statistically significant outcome between the two groups. However, in the subgroup of NSTEMI, primary endpoints were reduced by 31%. This is associated because there was a higher risk in the NSTEMI patients. So this trial was the first trial to investigate the impact of continuous monitoring with implantable cardiac monitors. This study may have the potential to expand the indication for ICM with home monitoring to post-MI patients. And in conclusion, post-MI patients, as we saw, have a high risk of significant arrhythmias. Cardiac arrhythmias in post-MI patients are a predictor for adverse outcomes. ICMs can be an effective tool for early detection, and especially as shown in the NSTEMI patients in this Biotronic group. So, ICM could be a device in select post-MI patients who have even a moderately reduced ejection fraction. It's a minimally invasive procedure. Of course, there's a cost involved. And in future, as we know, more and more of non-invasive monitoring can also be feasible in these patients. Thank you. Thank you for your attention.
Thank you, sir. It's a good elaborative talk on intracardiac monitoring post-MI patients. The low EF is the single most and the strongest predictor of sudden cardiac death and mortality and arrhythmias in patients with post-MI. So, the importance of ICM has been clearly told by the speaker. The floor is open for discussion.
Sir, you have said ICM in one study it is implanted on 11th day. Any time duration, sir, when to implant, and what is the prerequisites for implantation? One thing, sir. Second thing, up to 11 days, which tool is used for monitoring the arrhythmias? Actually, during our study period, we did a signal average ECG. So daily we will do signal average DCG, and we will see any two abnormal values, and we correlate with the arrhythmias. So whenever we see signal average DCG abnormality after MI, we used to give a beta blocker or antiarrhythmics. Just highlight about that, sir.
In the first study, it was a Charisma study, it was implanted after 11 days. Of course, the initial few days, patients are going to be in hospital where they may be monitored. So no specific cutoff. These are all small studies, as I said, 200, 300, 800 patients. So we don't have a very big data, but that is where it stands.
Regarding signal average DCG, sir.
Yes, initially that was what was used in the initial days. I think there was a lot of data published also. So yes.
So before implantation, we can use signal average DCG.
Yes. But this is more for long term, like up to 2 years, because signal average ECG all is in the initial period, yes, but this is more for long term. Again, it's not going to be practical to implant in all post-MI patients, again, but we have to take a call.
I have a comment to make. It is just like justice, treatment delayed is treatment denied in myocardial infarction. Is there any simple strategy to reduce mortality in end-STEMI patients, just like just moving away from the nomenclature of STEMI, end-STEMI to occlusion myocardial infarction, STEMI plus or STEMI minus? Because often or many times we see ECGs may not be able to, there may not be ST elevation, but still there may be underlying occlusion, like posterior wall MI, some STEMI equivalents, and even when there is occlusion is the pathology, it has to be managed like both STEMI and end-STEMI. Just like so the naming it end-STEMI makes both the patient and treating physician and interventionist like less aggressively, and it may result in more mortality. So is it time to move away from the paradigm of end-STEMI, STEMI to occlusion myocardial infarction?
It's a very good point, yes. Especially as we all know, the STEMI patients, we get very early treatment and get good treatment. That is the fact in most of the places. However, practically, the end-STEMI patients, there is a delay in treatment in a lot of centers. And patient acceptance also, there is a delay in end-STEMI patients because they are not as ready as during a STEMI to accept an angiogram, to accept a procedure. So it's definitely worthwhile, as we know that the risk from end-STEMI is more. The patients with end-STEMI should be treated as aggressively as a STEMI, if not more aggressively.
Sir, one more question, sir. What is the role of smartwatch comparison between smartwatch and the implantable cardiac devices?
See, it's again, it's practical, yes, as I told in the last line of my talk. Unimplantable, if you can have something which you can wear, it's going to be more acceptable to the patient. Yes, it will come, and now we have patches for 3 days, 7 days. So the same can be extended with multiple patches if the cost is feasible, yes. Yes, see, we have a lot of patients coming now saying, I have a tachycardia, I have a heart rate of 120, 130. Yes, it is useful for detecting arrhythmias. Only point is some patients take it to the extreme and become over anxious and keep watching their...
Sir, are there any data or ongoing trial wherein there is data for extended monitoring beyond 2 years? Or in other words, is there a point wherein we can decide that the monitoring can be over and it can be
See, to my knowledge, no, these studies are all for 2 years, but I believe the battery of these ICMs last for 4 to 5 years. That is the usual thing. So it can be, once you put an ICM, it can be used for 4 to 5 years.
Sir, in the first study, what you have seen is 30% of the arrhythmias were only atrial and less than 5% were only ventricular.
Ventricular, yes.
Do you have any cutoff limits by watching the LA size to add an anticoagulant to the therapy? First one thing.
Not in this study, no.
Nothing is there. Do you prefer
But all
adding
these
an
patients
anticoagulant
are
to the
post-MI patients. Their atrial size is likely to be normal. These are all immediate post-MI patients. So I don't think atrial size was a problem here at all.
Second thing is, do you prefer taking a CMR before or a viability study before going for a ICM monitoring?
See, I think this is a very important topic. I think you should see this topic more like what is going to give data for the future management of cardiac arrhythmias. We all know post-MI, if you are not revascularizing, maybe initial 6 weeks, if you are revascularizing 3 months, 6 months, it's a period when you are going to look at ejection fraction and think about devices. But the problem is that you have a group of patients who are unprotected during this period. So you have done a primary angioplasty, maybe a delayed angioplasty for an LAD, and you've got a big scar. Around EF is still 30%. This patient, as per guidelines, you will not reassess him for implantation of devices for the next 3 to 6 months, at least. So you will do at 3 months echo and see if there is an improvement, or you will not suggest them anything. And we know that delayed interventions, you are not going to see a big improvement. Early days, if you see in outside India, there are wearable ICDs available. So they keep them protected. These kind of patients, they can give them a wearable ICDs, which can be just over the body. So you don't have to implant. The patient can have an event which can be cardioverted by the device. But in India, it's not available, and it is a very costly device. So now we have to know what exactly happens during that period. I think these kind of studies will give us an idea about which patient to implant or which patient to intervene, because this is just a monitoring device. If a patient develops a VT also, it's going to be just monitored. So we will know that there are group of patients whom we have to be a little more aggressive. We know the primary prevention of VT comes very late. Whereas secondary prevention, if you have a patient with a MI at a 48 hours develops a ventricular tachycardia, you are fine. You will put an ICD and keep the patient protected. If the patient is going to develop after 10 days, 15 days, I think there is an excellent paper from CARE group by Dr. Haigiri Rao on sudden cardiac death. What they did was, after an MI, after a PCI, after a CABG, they followed these patients over a period of 1 year. All these patients are followed over the phone. If they are not able to catch them, the physician assistant went to the home and inquired what happened to the patient. The results were very shocking. Even on a patient who had a timely intervention, maybe a delayed intervention, CABG, the incidence of sudden cardiac death in initial 6 weeks was pretty high. So the sudden cardiac death risk is very high during the early period of MI. Unfortunately, what happens now, until unless the people whom you revascularize is your relative, you will not know the outcome. A lot of times these patients don't come to your OPD. You think they are doing well or following with some other person, but they might have lost the patient. I think every one of us have an experience where you will get a call from your close relative saying that the angioplasty which you done 2 weeks back, patient had a death in the sleep and died. So I think this is a kind of a study. That's the reason I wanted this study, this topic to be on, because we have to be little more aware. At least, I think, to start with usage of beta blockers. Maybe in eligible patients, low dose antiarrhythmics. Amiodarone in a short term is a very safe drug, and we have safer drugs like Mixiltin now available very easily in India. So a patient who are at risk, you see a patient who has a very bad LV, you revascularized very late, you know very well that this LV is not going to improve, at least closely monitor these patients. As Sir was saying that you are going to get a lot of wearable monitors in the future. I think Apple Watch is pretty good. I have picked up good number of AFibs by an Apple Watch. And these monitors which are available right now people are trying to extend it up to a month. So if in a post-MI patient, you are able to monitor for a month, nothing like that. So if you are able to cover that area of uncertainty with these monitors, it will give you a much better idea about what exactly happens during this time. See, as a interventionist, we all know we have become very aggressive now. Ourselves and our patients and the referral physician all have become very conscious about primary PCA. Now it's very difficult to run a cath lab without a primary PCA. Patient comes in and asks for a primary PCA. So the primary PCA numbers have increased until unless you are going to intervene very early. You are going in and doing an angioplasty pretty early. There is a possibility that you may miss good number of patients who may end up with a LV dysfunction and a scar. These patients are at a risk of arrhythmia very early. Right now, there is no recommendation available for this period. I think studies like this and more studies to follow and more studies with wearable devices will give us a lot of idea about what happens during this period and what we have to exactly do. Do we have to implant an ICD, or do we have to keep maybe a good dose of antiarrhythmics on? These all information we may get in the future, but I think this is the one which can give us little maybe a trailer of what is going to come in the future.
So is there any questions? So take home message is, in post-MI patients with a scar burden and LV dysfunction, they are prone to get ventricular arrhythmia and sudden cardiac death, and NSTEMI should be treated aggressively as STEMI. If no other questions, we can conclude the session.
Thank you, sir. Let me invite Dr. Krishna Kumar sir to felicitate Dr. Balaji sir. So we will move on to the next session. I think next session is a very interesting topic. I think in this meeting for a long time we have a tradition of introducing a newer therapies to general physicians and the cardiologists, and we are going to talk about renal nerve denervation, which is coming up. We know for a long time the renal nerve denervation talk was there for the last 1 decade, I would say. We were doing renal nerve denervation in the early days with our regular EP catheters. Then we had dedicated catheters which came, and the data was not very encouraging. Now there is a new evidence emerging, and a lot of evidence is coming up for a patients who have a resistant hypertension. There are going to be interventional options available. Let me invite Dr. Arun Gopi to give a talk on renal denervation. It is very apt to invite Dr. Arun to give this talk because I think he has one of the largest experience in this therapy. Not only in this therapy, Arun is a pioneer in most of the emerging therapies. Whenever everything is launched, Arun may be the first person in South India to do most of the newer therapies. So let me invite Arun to give a talk on renal nerve denervation.
Yeah. Respected Chair, colleagues, warm good morning. At the outset, it's actually heartening always to come back to KOVAI Heart Rhythm Meet because me and Lawrence trained at almost similar time. I came after 6 months after him. So it's always nostalgic to catch up with him again. So to set the ball rolling, so today we talk about, it's not about anything new, it's about a therapy which was there for a decade now, but it has found its way back and how it has established in this arena of resistant hypertension, which is being aggressively treated with drugs, but neglected on the intervention side, I would say, and how it has found, it would find a place in your clinical practice would be the gist of my talk in the next 20 minutes or so. So let's start off the scenario with a case which we dealt with about a year back. A 70-year-old essential hypertension for the last 10 years. These are scenarios which are going to echo in your practice day in and out. 70 years, hypertension for last 10 years. No diabetes, minor CAD, one history of transient neurovascular ischemia, home and office blood pressure clearly in the range of 170/100. He's a teacher, so he monitors his home blood pressure very closely. His daughter is also an IT professional, so they are well into how home monitoring of blood pressure needs to be done. And the renal functions are normal. He himself gets evaluated by... I think the slides are not moving up there. It's moving here. No, this is not the slide. No, it's already third, fourth slide now. First slide. Next. Don't need to play from my laptop. Yeah. So, no, it's actually lower something, so that's it. Okay, so the scenario which I was talking to is 70-year-old, essential hypertension for last 10 years, no diabetes, minor coronary artery disease, one history of neurovascular ischemia. The office and home blood pressure is clearly in the range of 170/100. Renal functions normal. Secondary cause of hypertension extensively evaluated by the treating physician, ruled out. Started on each of these class of drugs, up titrated gradually. So when he came to us, he was already having a blood pressure, as I said, of 170/100. Progressively started on telmisartan 80 mg once daily. He was on telmisartan 80 mg once daily, metoprolol 100 mg once daily, chlorthalidone 6.25 once daily, prazosin 5 mg twice daily, cilidipine 10 mg once daily. So all these drugs he has been on for the last 6 months now. The treating physician initially started on adding aldactone. He couldn't tolerate it. Started having clonidine. Again, had central side effects. Could not take it. The drug compliance were more or less ensured, but he still continued to have this kind of blood pressure reading. So the monitor that you see on the right side is actually his invasive central aortic pressure. When we took him for a renal angiogram, it was 200/100. That was his central aortic pressure. So what we are dealing of this phenotype is a hypertension that is non-responsive to the antihypertensive drugs that are on. Earlier classified as resistant hypertension, which means an uncontrolled hypertension despite being on 3 or more medications, essentially one of which should be a diuretic. There's more or less a new definition which we bring in for this, which is called refractory hypertension, in which the patient is on at least 5 different classes of antihypertensive drugs for at least 3 months duration and still continues to have uncontrolled blood pressure. So he clearly falls into refractory hypertension. And how would you evaluate them? So we should again, as you deal with any of the cases at first, you should first confirm, or this is our algorithm for managing patients with refractory hypertension. First confirm that the blood pressure readings that you are getting is correct. Do with a home blood pressure monitoring or an ambulatory blood pressure monitoring. Ensure that accurate blood pressure readings are there. Again, to exclude white coat hypertension and a pseudo hypertension that we would say. Then ensure that all the four Ds are there, all drugs in the correct dose for the at least minimum duration of 3 months, essentially one of which should be a diuretic, is on board. Adherence to the medications need to be again re-emphasized and reconfirmed that the patient is really adherent to medications, again to exclude pseudo resistance. The secondary cause of hypertension, which I'm pretty sure most of this August audience would be knowing, catering to the particular age, we need to evaluate for all the secondary cause of hypertension, and that was done in this cases as well, including obstructive sleep apnea, which is sometimes a missed entity and a missed cause for essentially uncontrolled hypertension being labeled as refractory reactive hypertension. Once you give CPAP for these patients, majority of these patients have their blood pressure under control. So everything was evaluated in this guy, but yeah, so he's still controlled uncontrolled hypertension. This is echocardiogram showing significant left ventricular hypertrophy, and this is his renal angiogram showing no significant renal artery stenosis. So you have a refractory hypertension with target organ damage, no secondary causes found out. In fact, we would call it refractory hypertension, drug intolerant. Now what next to do? And this is what embarked us on this journey on renal denervation. Why we are interested in this, as this audience would know, that uncontrolled hypertension definitely has adverse impacts on cardiovascular health, mortality. The higher the blood pressure, the higher the event rates. Cardiovascular mortality clearly becomes double with each 20 about 10 millimeter increase in blood pressure. The risk of stroke is almost 3 times the risk of stroke once the blood pressure climbs from 120 to 140. This is very common in Indian scenario. These are actually Indian-owned data, which says almost 54% of patients uncontrolled, and that has its own morbidity. I'm not going into the statistics. This is very well known to any of the physician audience, but unfortunate thing is non-adherence to antihypertensive therapy is very high, close to the tune of 41%. The population level, the real-world scenario of uncontrolled hypertension is actually 78%. And if you dive deep into the pathophysiology of refractory resistant hypertension, the most important central point is overactive sympathetic nervous system. It's the renal sympathetic overactivity or the overactive central sympathetic nervous system that is the culprit. It's majority neurogenic secondary hypertension. And that is well established on the preclinical and clinical research, which clearly shows this uncontrolled hypertension to be neurogenic, and more so in the refractory hypertension. So the proof of pudding is actually you find higher 24-hour urine metanephrine levels, higher daytime and nighttime heart rate levels, higher arterial stiffness levels, clearly correlating with increased sympathetic drive. And the guidelines have also embarked this, and if you look at the ESH 2023, in such a scenario, if the eGFR is more than 30, there is no second renal parenchymal disease, there is a role for renal denervation provided the eGFR is more than 40, and if the patient has refractory hypertension, this is what even the guidelines endorse, and that's what we embarked on. So this renal denervation that we say is nothing new. It's a percutaneous renal nerve radiofrequency ablation which disrupts the afferent and efferent neural communication between the kidney and brain. Multiple sham control trials have demonstrated the safety and efficacy of this therapy for sustained blood pressure reduction in uncontrolled hypertension. And where it acts is, as I said, it acts on counteracting the sympathetic overactivity that exists. Renal denervation attempts to disconnect the sympathetic ganglia with a device which leaves nothing left behind with the simplicity spiral RDN system that we have. And the way it is being done now has changed. That is the actual paradigm shift that has happened in this therapy. This was there for more than a decade now, but it went in disrepute with with some trials which actually found a negative result with this, but the way we have done this procedure has reinvented this procedure. Now the target, as we would say, is IVY, where we target both the main artery as well as the branch to have a sustained clinical effect, and that has translated reduced neuroepinephrine spillover, where we treat both the main artery as well as the branch artery effectively. The major paradigm shift in the way we do the procedure has happened because of a better understanding of the renal artery innervation. We clearly understand now, based on autopsy studies, as well as from the isotope data, that the nerves are actually closer to the distal part of the arteries rather than the ostium. So the distal nerves are closer to the arterial lumen, and the procedural anatomy has really translated to what the autopsy specimens show and where the nerves are clearly. So renal nerves are typically closer to the lumen of artery in the distal part of the main artery and its branches. And so when you are doing renal denervation, the gist is to treat distal main arteries, treat the proximal renal branches, and treat every accessory renal artery that is available. So the renal denervation, the way we do it now is to target the renal nerves, which typically would bypass the main renal artery and would converge on the branches. So if you look at this autopsy specimen, actually, which shows the renal nerves, you will find that 63% of kidneys had renal nerves which had joined distal to the main artery bifurcation, which we call as the late arriving nerves, and 30% of these patients had actually a accessory renal artery. So this is an accessory renal artery which is well innervated, which would have been missed in the earlier procedures because 30% have that, and if you don't target these arteries, your procedure is going to fail. And there is no much of nerves in the ostium or the proximal part of renal artery, which was the target of renal denervation procedures earlier. And if you look at the histology specimens, you clearly understand that, so this is the distal renal arteries, you have the renal nerves actually in the adipose tissue, this is the adipose tissue surrounding it, and the renal nerves are actually in the adipose tissue surrounding it, and you have other structures as well there. You have the veins there, you have the lymph nodes there, you have other collateral structures, but as you go distal, if you look at the histopathology, in the proximal areas you can see the lymph node, the ganglia, everything, renal nerves, renal veins, everything close to the renal artery, but as you go distal, it's only the adipose tissue which is near the renal artery, and so the more and more you distal you target, your collateral damage significantly goes down. You don't damage your lymph nodes or neural ganglia. Now, how you do it is with radiofrequency ablation. It's a well-known, it's a well-studied, proven modality of ablation, and the beauty of this is it's very selective and very effective. So radiofrequency ablation is quite safe, and the way in which we do it is called the Simplicity Spiral Renal Denervation New System, which actually has 3 important aspects. One is this newer catheter, which is a Simplicity Spiral catheter. It's a 4 French catheter. The next is the G3 generator. It's a fully AI-based generator, which has actually added the beauty of the procedure. And this helps us in doing an RDN more effectively. So, as I said, this is the Simplicity's 4 French Simplicity Spiral Multi-Electrode Radiofrequency Catheter, which rapid exchange, easy to use, goes over any 014 conventional angioplasty wires, can go through a 6 French guide catheter. It has 4 electrodes, which are the golden electrodes that we call. These are monopolar cylindrical 1.5 millimeter length electrodes, and it has a platinum iridium tip, which is radio opaque, which tells us where the tip of the catheter is. And once you put the catheter in the correct position, it's just connecting to the G3 generator, and it's like a plug and play. So this is the G3 generator, which is the most important factor which has changed in which the way we do the procedure, because it has added artificial intelligence into it. So here we are not looking at human error part of it. It's precisely controlled radiofrequency delivery, which looks at real-time responsive feedback algorithms. So every electrode, they take up temperature and impedance feedback. It looks at what feedback comes from the electrode, and based on that it adjusts what amount of RF is being delivered there. So earlier we didn't have any feedback. There's a lot of human intelligence brought in, but with AI-based G3 generator, it looks at the feedback. So you have 2 things being looked at. It looks at the temperature, looks at the impedance, and then delivers power. And all the 4 electrodes, you can individually activate each of these electrodes and deliver power. So it's actually a very sophisticated equipment which brings and ensures more safety to the procedure. And what it does is, as I said, this catheter is non-occlusive. It's a non-occlusive. This is a catheter inside the renal artery. It is non-occlusive. It's a helical catheter which ensures that each of the electrodes are in contact with different parts of the renal artery. It is not in one single circle, which should have issues of renal artery spasm or arterial injury later. The electrodes get in contact with different quadrants of the artery, and these ablate 4 quadrants simultaneously. You can see these are the golden electrodes ablating 4 quadrants at different lengths. And the beauty of this is the lesions are absolutely asymmetric, because you would deliver lesion here and the next lesion would be here at least about 5 millimeter behind. And when it delivers the lesion, it would actually deliver on the, it would typically deliver on the adipose tissue around the artery alone. As I said, the target now is to treat the proximal branches and the distal branches of the artery. And when you ablate this, as I said, the nerves are located in the perivascular fat tissue. RF energy, the beauty of it is preferentially heats the fat around the artery tissue, and thereby it specifically damages the nerves alone. There is no collateral damage. So what does the radiofrequency current do? So this is your renal artery with your golden electrode or spiral, simplicity spiral catheter. This is the golden electrode. So once you put the RF on, it starts delivering energy here. It heats up the adipose tissue, which has the neural ganglia or the neural tissue into it, and burns off the adipose tissue. It melts the fat, along with it takes off the renal nerves. It has nothing near it. The veins are away, the lymph nodes are away. It's very selective, and that is why collateral damage is almost minuscule. So it has very high specificity for renal nerves, and that adds on to the procedure and reduces the collateral damage with this. The next important aspect when you're doing this procedure, there is a linear correlation about how much of volume of ablation you do. So this is actually a model where they have put up the renal artery as well as the renal innervation along with it, and the volume of ablation that you would do. So the more you ablate, the more nerves you are taking care of, the better reduction in blood pressure you would have. So there is actually a learning curve also into this, because the better you do this procedure, you have better results. Now, although all this sounds physiologically very sound, does it have evidence? So it is not without evidence, because it was actually some of these trials which it put forth back. So now they have come back very slow. They have understood what it needs to be done, and they initially did about 4 sham controlled randomized control trial, and with real level evidence from off-med, on-med, the pivotal trial, and with the global simplicity registry, we have now evidence from more than 20,000 real world data as well, which has proven the concept of this therapy. In the off-med, it is actually head-on it without drugs, and you have actually a reduction of blood pressure. The amount of blood pressure reduction that you see with this therapy after the procedure would not sound very great. You would find a 9 mm drop in the systolic blood pressure, a 5 mm drop in the diastolic blood pressure, which might not sound attractive, but there are much more things that happen over the period of time. But because what trials have shown is the benefit of this blood pressure reduction is cumulative. So there is sustained reduction of blood pressure which happens even up to about 8 years. This is what studies have shown is up to 3 years and beyond that. And this is actually a follow-up data of almost 3,000 patients, follow-up of more than 5 years, where there's a sustained reduction in blood pressure, although the initial reduction would be about 5 mm, but at the end of 3 years or 5 years, you find a 25 mm reduction of blood pressure. And this reduction actually with the off-med medicine, actually you also find that it is effective even in patients who are not taking medicines, and there is progressive reduction even without medicine. Even if you don't add on medicine or reduce your medicines, there's progressive reduction over time. And this has been tested in variety of subgroups, because we understand that hypertension has significant comorbidities, and tested in patients who have diabetes, AF, CKD, provided the eGFR is more than 40, patients who are elderly, patients who have prior MI. So every kind of patient has been tested in this registry, and it is proven that it works across the spectrum. And the beauty of this therapy is compared to drugs. So if you give an antihypertensive drug, it has a peak effect, which will happen, say, about 6 to 8 hours later, and then there's an off effect. That's where the drug effect goes off and the efficacy goes off. But with renal denervation, one single time procedure, the benefit of this therapy is always on. There's a 24-hour blood pressure lowering, which is cumulative over years. So it's an always on effect compared to what the drug would provide you. And you would not embark on this unless you are concerned and very, very sure that it does not cause any collateral damage. So there were safety concerns that whether it would damage the renal artery, whether it cause contrast nephropathy, whether it would cause a de novo renal artery stenosis because of the arterial injury that you are creating, would it cause a eGFR loss? All has been well tested. So this is the adverse event data from the GSR and most of the trials. The adverse events are just 0.4%. which is just minuscule compared to any of the procedures that we do. And if you look at these complications, it is predominantly a vascular access issue complication, which is expected in any of the interventional procedures. Now regarding the efficacy and durability. So here we are ablating renal nerves, and the beauty of this is the renal nerves do not recover. Renal nerves don't regenerate, they don't recover. And that is why, if you look at this histology specimens, you have unrecoverable sympathetic nervous damage that happens after renal denervation. So there is permanent axonal damage. If you see them on follow-up after RDN, they don't get back connected. So there is a sustained reduction of renal nerve norepinephrine, and this happens not only at the site of damage. So when you're ablating, it is not only, there's a transient necrosis at site of damage, there's a fibrosis at site of lesion. There is also axonal loss distal to the site of lesion, which explains the cumulative improvement in blood pressure that happens over time. And the gist behind this is the renal nerves are not myelinated. So we use the benefit of unmyelinated renal nerves, damaging these nerves. In the absence of myelin, they are not going to get connected, they are not going to renervate, and they are not going to get back. That is why you have always an on effect. Because the distal axonal loss is there, you have cumulative benefits over time. And that is why if you look at all these trials, you find a cumulative reduction of blood pressure, not what you see on table. As years progress, with one therapy done today, you will have blood pressure reduction even at the end of 3 years, or even there's some data which says even up to 8 years. And there's a lot of battery of clinical studies which has been done. And over time, after the GSR has been published, these are publications in Lancet and all. The Offmet came in Lancet. And there's a lot of other studies in the pipeline. TC 2021, they had the US study and GSR defined. And there's a whole load of gamut of data which is going to come on this. It is not only RF catheter that you can use. There are different other modalities. You can use an ultrasound-based system. You can use an alcohol-based system. You can use any form of system that you want to use. The concept is to get these nerves well denervated, and that would give you sustained benefit over time. So let's get back to the index case that I described. So this patient, we took him to the lab. This was the first renal denervation in the whole of the country after the commercial launch of this catheter. So this is the G3 generator and RF and the spiral catheter. So what it requires is just one femoral arterial stick. We take it always with ultrasound guided and a micropuncture set, because these patients have uncontrolled hypertension. You don't want a vascular access complication. Just like your renal angioplasty or any of your angioplasty procedures, take in an RDC catheter or an IMA catheter, shoot your renal arteries, understand and rule out any significant renal vascular disease before you do the procedure, mark the renal parenchyma. This is what we are doing. We are marking the renal parenchyma because we don't want to get inside the parenchyma. This was a procedure, patient's central aortic pressure, which I said was about 200/99, and then you do just like an angioplasty. You have your 014 wire down. You can use any of the wires. Heparin is just like your angioplasty doses. You take your wire down the vessel. We would use a good support wire like a Grand Slam, or a BMW wire is good enough. And then you track this catheter. The beauty is it's beautifully trackable. It goes down well. And once you have taken the catheter in, you pull back the wire. So this is the catheter with the golden electrodes going in. Once you reach your target nerves, as you know, you need to go distal. You need to avoid the renal parenchyma. And you pull back the wire, it actually automatically starts forming this helix. So as I said, the beauty of helix is it ablates here, it ablates here, it ablates here. It is not in one circle. It is actually in different quadrants of the artery. And then this is the AI generator. As I said, it takes positive feedbacks. You have a temperature and impedance graphs which it look at. So white is the impedance and blue is the temperature. So it should have at least a 10 to 15% drop in impedance. So if you have a drop in impedance, it ensures good contact. The temperature should be between 55 to 60. The moment it goes above 70, it automatically shuts off. You have 4 electrodes. You can individually activate each of these electrodes and deliver, or you can deliver in all the 4 electrodes. So suppose if one of the electrode doesn't have contact, the machine, even if you don't want, it will automatically shut off and not deliver power there. So it is fully AI based and it ensures safety. So once you are done with the procedure, give again a shot to the renal artery, ensure that you are not caused any collateral damage. And then from the right side, you go to the left. You need to take care of all the branches. You need to stay away from bifurcations. You need to stay away from the ostium. You need to stay away from the renal parenchyma. So the major gist is to avoid parenchymal damage, avoid getting into the bifurcations, and avoid getting into the ostium. So get into the either of the renal arteries, ablate each of the renal nerves. You're not looking at an end point. It is about the volumetric damage that you're causing to the renal nerves, and that was what is going to translate to your blood pressure reduction. And this patient, on the table itself, had a significant reduction. We had about, so this was the RDN to the right renal artery. We gave about 16 lesions on the right side. Then we went on to the left side where we got about 9 lesions, so about 25 lesions were delivered in both the renal arteries. And this patient's blood pressure, which was, as I said, about 200/100 to start off with, on table itself there was a good amount of reduction. It came down to about 120/60. This is not the benefit of renal denervation on table. What you see on table is the benefit of sedation as well as the nitro you give into the renal arteries. But we generally would expect about 10 to 20 reduction of blood pressure. That's what we have seen in subsequent cases. And but as I said, the benefit of this therapy comes on follow-up. So this is the teacher, as I said, he maintains this notebook which he constantly brings on every follow-up. Even if we don't want, he is going to closely monitor what the procedure has done to him. And this was his initial graph of curves. He himself makes the curve. He brings it to us. So this is his curve. Where you had a blood pressure between close to 200 before the procedure, and the systolic blood pressure after procedures between 130 to 140. The diastolic pressure prior to the procedure was close to above 100, and it's about closing to about 80 after the procedure. So now we have slowly cut down on his drugs. So this is the proof of the concept. So you have this home blood pressure monitoring which clearly shows that his blood pressure is always between 100 to 140 systolic and 70 to 90 diastolic, and that has translated a good clinical benefit for him. He is quite asymptomatic now. He is doing good on follow-up. We have done some more cases after that. Some of the patients we have actually found a significant even hypotension on follow-up where we have to take off the drugs. Almost they have been off a single drug now from about 5 or 6 drugs to begin off with. But this actually acts very well in younger patients more than the elderly stiff renal arteries. So which are the patients who would typically be suited for renal denervation? Uncontrolled hypertension, borderline control with drugs, those patients who are unable to adhere to the drugs, those patients who have drug-induced side effects, those patients who are unwilling to adhere to the drugs, those patients who have preference for staying away from drugs, typically the younger patients, those patients who are drug intolerant, and those patients who have elevated cardiovascular risk, be it in the form of stroke, coronary artery disease, or AF. So that's why the European Society of Hypertension recommends RDN as a third pillar of uncontrolled hypertension, and the ESH 2023 gives it a class 2 recommendation for all those patients with refractory hypertension with the EGFR more than 40 who have been on these drugs and have been not compliant with these drugs, where we use it for resistant hypertension, the class 2 recommendation. The next year, the European Society of Cardiology, they have actually split out from the European Society of Hypertension. ESC 2024 gave one step ahead. They gave a class 2B recommendation for using renal denervation for refractory hypertension, and this has been echoed in every guideline that we have. Before I end, I will just conclude with this. The best guideline that we would see in our practice is that from the Thai Society, which says it has a class 1 recommendation. That means it should be used for patients who have refractory hypertension, that is, who have at least on 5 classes of drugs, despite maximally tolerated dose of drugs. It has a class 2A recommendation. That means it could be practiced for those patients with resistant hypertension who have established atherosclerotic cardiovascular disease or progressive target organ damage. It has a class 2B recommendation. That means it may be practiced for patients who have resistant hypertension under maximal tolerated drugs of dose of antihypertensives, or patients who have multi-drug intolerance or non-adherence. But the most important step for physician is routine use of renal denervation for blood pressure control is class 3. It should not be practiced. If a person can take drugs, he should be treated on drugs. If it's resistant or refractory or target organ damage, that's when you really look on this. And that's what all the societies are embarked on. So renal denervation is actually a complementary approach for difficult to treat hypertension. The most important thing is it gives a reduction of blood pressure. There is a sustained effect over a long period of time. It reduces the blood pressure variability, improves the nighttime blood pressure control, increases your time in therapeutic range. This is what we take out from the INR data. The time in therapeutic range of your blood pressure improves. It has no incremental non-adherence issue. It's a single time, one-time procedure which just requires one arterial stick, very safe. And the beauty compared to drug is it's always on. You have one short procedure, there is no peak and trough, it has a sustained effect, and there is cumulative effect over time. So ladies and gentlemen, to conclude, renal denervation is a promising novel therapy for refractory or resistant hypertension. Evidence-based it's actually an evidence-based complementary treatment option for so-called difficult to control hypertension, which actually fulfills an unmet need in the hypertension care and for those patients who want additional options beyond drugs. The Simplicity blood pressure procedure, what we call using this AA-based generator and the Simplicity spiral catheter, is very safe, effective, provides significantly always on blood pressure reduction, which is sustained over a period of time in the presence or absence of medications on follow-up. You are not going to see humongous drop in pressures as we see in our case, but you would average have a 90 to 40 blood pressure reduction at 6 months, and the effect is cumulative over more than 3 years. But the most important thing is there is a reduction of end organ damage, there's a reduction of the target organ damage that hypertension would cause. But it's a newer therapy, there are still a lot of gray zones, and we need further randomized control trials to make us more wiser on this therapy, which needs to be done on larger number of patients with longer follow-up to really make us understand what this therapy would do. So I would thank Lawrence for the opportunity, and I would be happy to take on any questions on this. Thank you.
Sir, nice elaborative talk on renal denervation. Sir, I have one question. What is the role of cryotherapy here, sir? Is it useful, or is there any comparison between radiofrequency ablation and cryotherapy?
Okay, so cryo has not been well tested in the renal arteries. I'll have one more talk on cryoablation after in the next session, where we have used it more for the AF ablation and all. But in the renal artery, it has not been well tested. There are ultrasound-based therapies. There are actually other alcohol-based therapies which have been tested. But none of these energy modalities have a head-to-head comparison. We first know that this therapy works. The modality of therapy, there are multiple systems that are available, and as time progresses, probably in years to time, you're going to get better systems coming in. But what is well shown is if you are denervating well, you will have sustained effect. Head-to-head, which therapy works better, there's no studies. RF is very safe and effective, less collateral damage. That is why it was a game ahead of all the other forms of therapy.
Okay, thank you.
Sir, it's an excellent talk on how to control resistant hypertension. Why CKD patients were excluded, sir? Because they are the one who are difficult to control, number one. Number two, by ablating the nerves, we are going to make the arteries stand still. Like we have arteriolar constriction, dilatation happening to regulate the GFR. Are there any concerns from nephrologist perspective?
Yeah. So, wonderful questions. So the first aspect is why CKD were excluded. See, when they took this trial, they wanted first the safety to be proven. That is why a eGFR cutoff of 40 was used. To be frank, there is a trial which is going on in CKD patients, and the benefit is actually much more than that you see in the normal renal function patients, because they have higher renal epinephrine spillover. And these are the patients you should be safely using, because you already have your kidneys lost, you have nothing to lose in there, you're not worried about parenchymal damage, and these patients are going to more definitely benefit. Lawrence would embark on, Narasimhan sir used to do with the conventional RF ablation catheter itself, renal denervation, and CKD patients were closely selected because they are the people where you have nothing to lose and you can easily do it. But at the moment, we don't have evidence with the new system to do in CKD patients. That is what Medtronic is going very safe and secure in this. They don't want to launch it like absorb stent, come and do it at all comers way and have a therapy getting a hit back. This therapy actually got a hit back about a decade back. So they are going very safe. They are not allowing us to go beyond what their IFU says. So we clearly have to stick to a eGFR more than 40 to enroll patients for renal denervation therapy. It is primarily for the safety concerns, primarily for lack of data, but probably if we talk about this therapy 2 years down the lane, we would be enrolling CKD patients as well in our practice to do this. Now, second concept is about what happens to the renal vasculature once we do this, what happens to the afferent and efferent arteriolar construction. They happen more on the microvascular system, and it has been well studied on 3-year, 8-year follow-up data that there is nothing much of parenchymal damage nor vascular change that happens in the renal arteries on follow-up. So that's why the safety is proven first, and it has been well tested by at least at 8-year follow-up data that there's nothing much happening in. I would say that you need to realize that sympathetic system is actually taking us on for a ride. It's actually the bad part of our nervous system, and parasympathetic nervous system is the more protective system in our nervous system. So even if you're hitting the sympathetic nervous system, you are definitely going to get benefited only. On the contrary, the cardioneural ablation which people are embarking on is again a questionable stuff.
Is it recommended in patients with renal artery stenosis, sir, like 50%, 70%?
So again, as per the IFU, if you have a stenosis, you need to avoid this. First of all, any form of renovascular hypertension, you need to treat the renovascular hypertension first. But post-renovascular stenting, you can do ablation. You should actually give an interval of 3 months to see the response of blood pressure. There is no point of ablating within the stent because the RF would not deliver through the stent. But if there's a lesion, you can still ablate. If the lesion is non-physiologic, you can do an FFR down the lesion, see the pressure drop across down the lesion. If the pressure drop is not more than 20, it is a physiologically non-significant lesion, then you can still do renal denervation. Only concept is you stay away at least 5 mm from the lesion. You don't ablate in the lesional site, but you stay away 5 mm away from the lesion.
Sir, in some patients, do you take a plasma renin activity or a urine metanephrine before going for the procedure to predict the success of the procedure?
If feasible, this would have been a beautiful concept because that is what they were done in the preclinical research. They looked at people who have higher renal vein epinephrine spillover, and these patients were enrolled. Even a urine metanephrine who were higher, these patients had better response because these are the typical neurogenic hypertension. So these are the way you can predict neurogenic hypertension. We would also do that, but at the moment we don't have a proper assay which is going to give you a reliable data, and there's no cutoff which has been set towards using that as a therapeutic target. So that's why we typically look at resistant refractory hypertension where we are against the wall. Predominantly, as I said, if you select younger patients, patients who have higher resting heart rate, people who have higher variability of blood pressure, these are the patients who have more so-called neurogenic hypertension. On the other hand, if you take an 80-year-old where their arteries are stiff, these patients don't respond well. They don't respond well. It's the neurogenic hypertension, younger patients, higher resting heart rates, higher heart rate variability, these patients would have higher benefit with renal denervation.
One third of the patient had an accessory renal artery.
Yes.
So what do all patients require ablating the accessory renal artery?
Yes.
Or there is a cutoff for
ablating? Beautiful question. So again, because of scarcity of time, I didn't embark on the procedural aspect. Any artery which is more than 3 millimeter needs to be ablated. That's what the guidelines say. Any artery between 3 to 8 mm, 8 mm you would only find if it's ectatic, but any artery which is more than 3 millimeter, any artery which on the parenchyma supplies more than 25% of the renal parenchyma needs to be ablated. So there is now a school of thought which says that you do a CT iotogram prior to the procedure to ensure that you have you are not missing out a renal artery. Accessory renal artery, because one of the key failures of the earlier procedure was they missed out the accessory renal artery altogether. If the accessory renal artery is more than 3 mm, supplies more than 25% of renal parenchyma, if you don't ablate it, you are not going to get sustained benefits because they have a lot of innervation. These accessory renal artery have a lot of innervation, and so we on the contrary would do a pigtail angiogram prior to a procedure to ensure that you are not missing out a renal artery, accessory renal artery. The other thing is when you do this renal angiogram itself, you can see how much of the parenchymal silhouette is being filled. So if your entire parenchymal silhouette is filled, means you are definitely not missing an accessory renal artery. But if you find one pole really missed on your parenchyma, you can get a nephrogram. You can get a nephrogram after your contrast injected. If at least one pole is not filled, aggressively search for an accessory renal artery.
Sir, is the catheter reusable?
At the moment, the Medtronic does not allow us to reuse, so we have not done that till now. But probably as the therapy comes out of board, we will probably be having this tried up. So there is, they say, a timer set on this. So once it comes out and gets in, your AI-based generator. See, one thing that most of the therapies, Lawrence would also embark on, when they're launching in our countries, what they do is they put a timer on it. They put up some safety mechanisms in which our people are not able to reuse it. But probably in point of time, even if there's a timer, we can club cases and do. But at the moment, we have not done that. But definitely, it might be reusable. So at the moment, the cost comes about 6 lakhs or so for the catheter and the system.
The renal nerves run over the adventitia, right?
Yes.
And we are from the endoluminal. And
yes.
you have to go the full thickness of the artery.
Yes.
And it works by creating fibrosis, though it is not, as you said, at different points, it's not circumferential. And what I'm trying to ask is, structural damage to the renal artery.
Yes. Important aspect which was the concern why the first it went into disrepute, because when we use our traditional RF catheter, or the initial catheter was what was there, we were not clear how much we were ablating. We were just causing endothelial damage, and we didn't know any absolute parameter by which we know whether it reaches the adventitia or not. So now, as I said, we have understood the renal nerves well. We actually go distal. So as you go distal, arteries are smaller. The renal vasculature, the media is thinner. The adventitia, the renal nerves are closer, and nerves are in the perivascular adipose tissue. They are innervated in the perivascular adipose tissue, where once the electrode touches the artery, you see a baseline impedance value. If there is a 15% drop of impedance, only then it means that you are going across the adventitia, and only then the AA-based generator is going to select that electrode. It is fully response feedback based. If there is a significant drop of impedance, only then that lesion is selected. Unless there is a 15% drop of impedance, rise of temperature, it won't select that area. So that ensures definite lesion. The next is about collateral damage. So that is the beauty of this catheter. That's why you use a spiral catheter. So it does not give all the 4 electrodes at one circle. It gives one here. The next is 5 millimeter proximal. and the next is again 5 millimeter proximal. So it gives in different quadrants. That is beauty enough because your nerves are going linear. You cut the nerve at 12 o'clock you cut a nerve, the next nerve is cut at 3 o'clock, about 5 millimeter away. So in the renal artery, if you see in one circle, there is only one lesion. The next lesion is at 5 millimeter proximal at one circle. So there is no endothelial damage happening. There is no de novo or new renal artery stenosis happening. So that is why this advent of this newer catheter system as well as this AA-based generator has made a change in the way the procedure is being done. It avoids totally a collateral damage. I think Lawrence, probably the crowd has followed and they are actually asking questions which we asked us before we start off this procedure. So probably.
Thank you, Arun, for a wonderful talk. Let me invite Dr. Chandrasekhar sir to felicitate Arun. Let's move on to the next talk. I think another important topic is coming up. I think we have a good general physician crowd. It should be very interesting. Let me invite Dr. Jayagopal sir to deliver his talk. It will be on STEMI management, learning from the master. I think Dr. Jayagopal sir is the opt person to talk on this. I think his energy and passion towards primary PCI is enormous. I should say that I think most of you would have seen that Chandramukhi movie, no? When Jyotika picks up that Golusa and all, you will see her eyes light up. I have seen like sir showing his angiograms to me when I go for EP cases. I could see the amount of passion which comes out when he talks about primaries. I think he's the best and opt person to talk on this topic. Let me invite Jayagopal sir to deliver his talk on STEMI management. Thank you.
Thank you, Lawrence, for the kind words. I really feel flattered. Anyway, it's actually a homecoming for me to be in Coimbatore because I was here working for about 10, 11 years in Covai as a visiting consultant long ago. So rightly said, well, there are two areas which are really passionate for me in my area of work. One has been STEMI because I've been close to about 30, 31 years in Palghat now, but then the journey started long back. I think probably my first exposure to cath lab was in 87. So, but those were the days when we were just routinely taking up patients for right heart catheters and so on and so forth. But then he said my passion is for primary PCA, which is undoubtedly true. But then unfortunately, for a physician audience, I think it will be really out of place. So I have really struggled to pick up some of my slides because I was given a very short notice of about 24 hours to produce this lecture. So any shortcomings on this, I request you to bear with me. So I was just looking back at my own data, the STEMI therapy. For example, when I graduated at a time when there was no reperfusion therapy, and the first intervention, to be honest, when I was a postgraduate student, what I performed was the IV metoprolol myocardial infarction. So any patient who came with an acute STEMI, that point of time, the job which was offered to the postgraduate student was to push in IV metoprolol, beta-log to be exact, 5 milligram every 5 minutes, keep on recording the blood pressure and the pulse rate. The moment the blood pressure comes down less than 100 or the pulse rate less than 60, you stop it. Load them with an oral. When we were surprised to see that this was really effective in terms of reduction of arrhythmia. There was no reperfusion, no streptokinase then. So it was just soon after that the ISIS-2, the International Infarct Survival Study, and the GIZI trials which came in, which showed that the use of aspirin and streptokinase reduced mortality by about 23%. And that's been a game changer in the treatment of STEMI, myocardial infarction. In fact, I had the honor of giving the first lytic therapy in 1989, streptokinase, to my assistant professor who was just 30 years old at that point of time. And he did very well. He walked home and then with a near normal left ventricular function. Of course, it was a small inferior valve myocardial infarction. But I think my confidence grew with the use of streptokinase after my stint in Jayadeva in the early 90s, where we used to lyse nearly about 20 myocardial infarctions in a day. And then we were also given the task of doing a pre-hospital thrombolysis. We talk about it this day, but this was practiced long back, even about 30 years ago. So I think I just want to convey the concept that time is muscle. So if you start looking at this picture, you understand that earlier you try to intervene or interfere, do your therapy, the better is the amount of myocardial salvage. Beyond that, for example, the point A to B, this is a fairly old slide. So you find that you try to do anything, they may not really be beneficial. From C to D, the shift in, if you are really able to do something very early enough, the effect is, so that's what is called the critical time dependent. And we all know that the right time for a right treatment for a STEMI or a myocardial infarction is early reperfusion. So it's clearly, undoubtedly, the most important thing that we need to have when somebody complains of chest pain is an EKG. There's no doubt that you cannot treat a patient with a myocardial infarction. In fact, in the early 90s, we always used to have a problem where sometimes the patient comes to you with a typical chest pain. You don't find any ST changes. And those were the days when we really started, because I had the good fortune of having an echo machine close to my consultation. So we could pick up regional wall motor abnormality, but then the days were very clear, we could not do any therapy based on an echo. But then now we know that if you want to diagnose a myocardial infarction, apart from an EKG, where you have an ST elevation myocardial infarction, diagnosis is straightforward. But the imaging also comes to a rescue, and the universal definition now also looks into as one of the imaging is also one of the things that you look into for a diagnosis. Now I think for a practicing physician, it's important that where you look into, for example, you have the ongoing occlusion where you have the ST elevation, the J point, more than 2 contiguous leads. It's very clear cut. But then what is often missed in a practice is a posterior void myocardial infarction. So in fact, I tell all my junior colleagues, when somebody comes with chest pain, I think you must be more focused of looking for ST elevation. For example, you might find some subtle changes in lead 1 and AVL when you have a high lateral infarct. But then the opposite of you might see the ST depression 2-3 AVF. So similarly, when you see, don't be focused, always thinking of an ST elevation. When you have something in V1 to V3, like an ST depression, this tells you that it's a true posterior infarct. And then the only way that you can possibly diagnose is basically looking at an ST elevation V7 to V9, which you hardly might do in your practice. But then the moment you see this, it's important that it's really looked into. Sometimes, the subtle changes. In fact, I had a recent patient who came in with a typical, he collapsed actually, came in the middle of the night, with all that he had was a rhythm, a junctional rhythm of heart rate of about 50 to 60, had hypotension. And the first ECG which was done outside showed a subtle ST elevation. But then this was, my colleague came in, took him for a primary angioplasty. Unfortunately, he could not hook the right with a lot of effort. The left was a dominant system. He left it at that. But this man went in for hypotension. He was on supports. Down the line, he was not feeling well. So when next 48 hours when I came later, I saw that his RI/RV was dilated. So this was actually missed right ventricular infarct. And then subsequently I took him again to the lab. It was a non-dominant right which was occluded, and they gave him all the problem, but they ended up in a significant right heart failure. So what I'm trying to tell you is that look at the right ventricular leads with the V3, V4 or sometimes you might find a subtle elevation in V1 alone, and that will tell you, because it might sometimes show you a junctional rhythm, bradycardia and all these things. Well, when you have a significant ST depression in many other leads, with more than 6 or 7 leads, sometimes you are actually looking at a left main, and this is also important to recognize. Let me take you further in the sense that once you have an ST elevation today, I told you that the way to go about is either a reperfusion. The most important, I think the most effective one is a primary PCA, which there's no doubt about it. But for a practicing physician, you may not have an access to a cath lab. So the other option becomes a fibrinolytic therapy. So I think, again, to re-emphasize, primary PCA is a standard of care. Today, I think if somebody can afford, if it's one of your relatives, I don't think one should hesitate and then do a lysis, even if your lytic therapy is available in the hospital. If you can take this patient to a cath lab which is nearby, that's a way to go about. So the ESC guidelines are very clear cut. The invasive management, you have an ST elevation, primary PCI, and the aim will be to have a wire crossing. Today, you don't talk about a balloon. The wire, if you cross it itself, you restart the reperfusion, and this should be within about 60 minutes. So in a non-PCA center, suppose you're practicing elsewhere and you have a patient who is there, the next question is, can you take this patient to a place where there a PCA is possible? If that is there, well, the aim is to get the wire crossing within 90 minutes. But then if you're not able to do it in 120 minutes, then it becomes a reasonable alternative to have a lytic therapy, which is probably what I'm going to focus a little more, because that is where the physician's role really comes into effect. But then in a country like India, we talk about the primary PCI, most of the cardiac symptoms are often attributed to and the patient himself is a becomes a treating doctor. He starts taking the hygiene. Well, then the problem is that, even in the metros where you have so many centers, unfortunately, this is a kind of traffic where even reaching a primary PCA becomes a real problem. So I think that really calls for the therapy of a fibrinolytic therapy. Now, way back, I was probably the first registry that I took part was the CREATE registry. Dr. Salim Yusuf really introduced all of us, particularly people from Kerala, into this. And then we were shocked at that point of time to find out that the onset of symptoms to admission hospital was close to about 300 minutes. This is even quoted today. Unfortunately, this is the data in 2008. In fact, we have gone for really far ahead than this. And then if you were to compare with what is available in the Western literature, it's markedly 2 times more than what is happening there. And not only that, if you start looking at the practice of the therapy, I mean, we should say that we talk about primary PCA, but then look at what the Western data is, 40% versus 28%. But then in a country like India, it was just 8%. This is close to about 16 years back. So we came out, in fact, I was one of the authors for this paper. Cardiology Society looked at it in 2017, and we actually wanted to devise something for our own country, where the non-PCA center was what we were really looking at. For example, you have all the basic initial, dual platelet loading and all that. And then if they decide on a reperfusion therapy, if the transfer for a thrombolysis, if it's less than you would immediately do a thrombolysis if your PCA center is not accessible. And then once you do a thrombolysis, that is where I'm going to stress a little more. And if the time, patient consent, hemodynamic stability, all these things have to be taken into account. And then if there is a PCA capable center within less than 24 hours, 12 hours, I think if PCA, if in a STEMI, if you can do a PCA, that's a way to go about. If it is not so, you would thrombolyze. But then even if you do a thrombolysis, successful thrombolysis, the stress is on an early angiogram. And the recommendation was to get a follow-up angiogram within about 3 to 24 hours. Now, that is what has been done. In fact, when we looked into our own country, what was probably more effective or more easily accessible was streptokinase. But then today we are fairly clear. I'll come to it a little later on. If you have access to an agent which is a fibrin-specific agent like tenecteplase, that would be the preferred option if you're thinking of a therapy. I think it's important when you have patients coming with this kind of an EKG. I think if you can send them to a cath lab, I think that's the way to go about, because these are patients who have a very proximal left anterior descending artery, and we typically call this as a widowmaker's artery. So if you don't really intervene and get a reperfusion, you are going to be in trouble. So this is the kind of a patient. In fact, this patient was an 80-year-old gentleman who came in. Before I could take him to the lab, he had a cardiac arrest. We would have, given him, did CPR, multiple episodes of ventricular tachycardia. Well, this patient was salvaged because of a timely intervention. But then also, in case you don't have an access to a cath lab, you should not hesitate to offer a lytic therapy. And what could be the lytic therapy? So if primary PCA cannot be offered in a timely manner, which is what happens in most of the patients, fibrinolytic therapy, it prevents 30 early deaths per about 1,000 patients within 6 hours of symptom onset. And it is recommended within about 12 hours of symptom onset if primary PCA. There is also a disadvantage. If you offer a primary fibrinolysis to a patient who comes late, theoretically there is a high chance of a ventricular septal rupture. In fact, these days we hardly ever see any ventricular septal ruptures because most of our patients are reperfused by a primary PCA these days. And it should be performed within 120, if primary PCA cannot be performed within 120 minutes, they should be offered the lytic therapy. I think I was also mentioning to you about pre-hospital lysis, which is not something new. We used to practice this about 30 years ago. And in fact, today I think Dr. Thomas Alexander from KMCH has done a wonderful job where I think he has shown the entire world that in the STEMI India program has really taken it to the next level. The aim is to administer fibrinolysis bolus within 10 minutes, and that's what the ESC recommendation is. And of course, the drug would be, why is it important? Because there's elegant data to show you that pre-hospital thrombolysis can sometimes even abort an MI. For example, you look at the pre-hospital thrombolysis, the abortion of MI is about 17% compared to about 4.5%. And if you have an aborted MI, the mortality rate is just 2%, which is what you see today in a primary PCA program. Whereas the other one, it's about 11.6%. So I think the moment if you are able to, if you have the kind of support like a good ambulance where the EKG can be transferred to consultant, this is again another concept. So Recommendation for fibrinolytic therapeutic therapy is reperfusion. It's recommended to initiate this as soon as possible. And if you can administer this, the target time, the aim for target is less than 10 minutes. And a fibrin-specific agent, though these are recommended, tenecteplase, alteplase, and retiplase, I think tenecteplase today would score above that because the ease of administering this within a 5-second bolus. And if you have a patient above the age of 75 years, a half dose of tenecteplase is also accepted. Of course, goes without saying an aspirin and clopidogrel could be the adjunctive therapy then. But I think the problem is that in a country like India, this is not freely available, particularly in the government setup. And in fact, there is nothing wrong with streptokinase. In fact, I would like to share the enormous experience I had during my DM days with the use of streptokinase. The failure rate is fairly high. It's about 55%, but something is really better than nothing. And in fact, the arterial patency, if you look at 90 minutes, which is what you talk about, the reperfusion is close to about 90%. But then the problem is that half of them don't achieve the successful lysis. But this is a new data which has come in recently, 2024, in fact, the TCT. In fact, in STEMI also, what is seen is that if you want to take a patient to the cath lab, and if you have some time delay, even giving a shot of heparin outside, in fact, they have found that the moment these patients on heparin reach the cath lab, the arterial patency, TIMI flow is much better. So it's something which you can take in the context also of a patient in your practice. Also, heparin also as an adjunctive therapy has a role. But then the problem with streptokinase is, we all talk about the reactions, allergic. I don't think you should really worry about it. A shot of steroid sometimes helps. But then the problem is that it's not fibrin specific. And not only that, streptokinase is a first generation lytic agent. It acts by complexing the plasminogen, and it's not fibrin specific. Because of that, there is a depletion of plasminogen known as a plasminogen steal, which will limit the fibrinolytic action, accounting partly for the thrombolysis failure. So this is one of the major disadvantages, but the advantage is that it's really cheap and it's available all over the country. So when you have a patient with a STEMI, it's also a strategic clone. The bolus of fibrinolytic therapy, it's important that this has to be administered, and that should be administered within about 10 minutes. And once it is administered, don't stop with this. The message is that even if you have a successful lysis, don't sit on this patient, because it's important that these patients are followed up within the next 24 hours for a timely angiogram to see whether the reperfusion is achieved, whether you need to do anything for this patient further on. So the longer administration time may significantly delay the reperfusion assessment and the transfer to a PCI capable hospital. So the problem is that many people, because I see a lot of WhatsApp, where a lot of ECGs are shared, people are fond of retiplase. There is nothing wrong with that, but then the problem is that the fibrin specificity is good, the weight adjusted dosage is not required, but then the mortality may be the same, but then the problem is the time taken for this. If you compare with the tenecteplase, you find that the time that is required, it has to be given as a 2 boluses, and then the mortality, when you compare tenecteplase with retiplase, definitely tenecteplase is an advantage. And suitable for a door-to-needle time of less than 30 minutes. That's the advantage. So in fact, today, in the back of my mind, I have no doubt one of my relatives has a myocardial infarction far away from where you are practicing, and then he doesn't have access to a cath lab, and if definitely he needs a medication, I would prefer a tenecteplase, because this is a safe drug which can be given as a bolus within about 5 seconds. So that's why the ESA recommendation also today, if you look at tenecteplase, it's a bolus over 5 seconds, and that really scores over a 2 bolus 30 minutes apart to complete the administration. So the hassle of giving this retiplase does not really happen with the tenecteplase. So that, I think, would be the recommendation today. In fact, when you use a tenecteplase, the only thing that a physician should remember, in fact, I've seen people not just following up with anything else, but it's important that when you have a tenecteplase, you also have heparin as on board. Heparin has to be weight adjusted and given 60 international units, a maximum of 4,000. And then if it's possible, you need to continue this infusion for about 24 hours. Well, enoxaparin is again another choice where you can give an IV bolus followed by a subcutaneous. But then most of the centers, I think the cheaper drug would be unfractionated heparin, which could be used for patients. Only for patients with streptokinase. In fact, a trend amongst physicians is to give fondaparinux. But then this is not really recommended when you're thinking of taking these patients to cath lab. When this got introduced long back, we in fact found that there were a lot of catheter thrombus, and even in the sheath. So in patients who are treated with streptokinase, this is a recommended IV bolus of fondaparinux, followed by a subQ 24 hours, could be considered. But then the way to go about, I think in most of the centers, would be the preferential use of heparin. Again, I just wanted to re-emphasize the point that when you're thinking of pharmacy invasive, you need to follow up these patients it just widens the window for a PCA. That is what it is just a buying some time. You need to send these patients for a follow-up angiogram and a procedure later on if it is required. So this primary PCA cannot be offered in a timely manner, and the way to go about is definitely a primary PCA, because we have abundant data from the STREAM trial which has shown that all-cause mortality is almost comparable to pharmacoinvasive, is comparable to a primary PCA. And the data, it's not just 1 year where it's almost equivalent, but even now we have the follow-up data even up to 5 years. But then the only problem with the STREAM one was a little excess bleed. In fact, some of the physicians are scared to administer this in an elderly patient. And the recommendation today, because the STREAM 2 data also has proven that you could use half the dose of tenecteplase in an elderly gentleman to get the desired benefit. That was which came out from the half-dose TNK in the elderly, the STREAM 2, which clearly showed us this. And this was fairly large number of patients. Average age was 70 years. And then the primary PCA, the mortality when they compared was about, the outcome was about 13.1 at the end of 30 days, 13.3%, whereas the pharmacoinvasive was almost similar in these patients. So the secondary outcomes also fairly comparable. And today I think the data is fairly clear that pharmacoinvasive therapy with half-dose TNK is safe in an elderly patient. That's the way to go about. And in fact, we have a large meta-analysis again which tells you the same thing, and I don't really want to go into it. But then there are a group of patients who come late, for example, 24 hours. You might take them up for a percutaneous intervention. And there was this group of about 1,000 patients studied with primary PCA and have got pharmacoinvasive. And again, this one group which showed that patients who underwent a late primary PCA had higher mortality, less than those undergoing a pharmacoinvasive. So I think there is something which really tells us that a pharmacoinvasive is an option. And this actually would be helpful to the practicing physician. So the recommendation is, again, to re-emphasize, transfer to PCA center, and then that should be done. And angiography is recommended between 2 and 24 hours, and that's a recommendation today from the ESA guidelines 2023. So I just want to tell you that my belief in this lytic therapy, it's not just, in fact, when I look at my own practice where I do about 40, 50 primaries in a month, the number of patients who are really given an IV lytic therapy maybe 1 or 2. But then there is another group of patients where I know I have a different therapy, but this is one group where I would, even in my busy practice of a primary angioplasty, I would still use a IV lytic therapy. For example, this is a 33-year-old gentleman, 1 hour duration, typically came to my hospital, ST elevation, myocardial infarction, and he was actually being taken up for a primary PCI. This suddenly, by the time he was prepared, he started developing ventricular arrhythmias. And look at the EKGs at this point, multiple shocks. And then, by then, we hardly ever use lignocaine these days in our unit. Plan for a primary PCI, recurrent VTVF, must have had about 9 times. Cardioversion, CPR, intubated, ventilated, shocked 10 to 12 times, revived. No, in fact, the medical officer gave lidocaine, no response. And the pulse rate was at that point at 150. I'm a firm believer in metoprolol. Maybe my experience as I told you, as a postgraduate way back, helped me. I still use metoprolol quite, very high in my cath lab as well as my ICU. 5 milligram, 5 minutes, everything stopped, no time to shift to the cath lab. And this is a time when I wouldn't waste time to take him to the cath lab, because an unstable patient, he was given tenecteplase. And that's what happened soon. Within about half an hour, things started settling down. The ECGs have settled down. And this patient, when you took him to the cath lab, there's hardly anything. Completely young guy. So young guys generally have more of a clot. And this is one area where you will not have a second thought about reperfusion therapy. And that is his follow-up echo. In fact, this is not working. He is doing well, normal LV function. And in fact, the proof of the pudding is you have all this data from all over the world. The pharmacoinvasive therapy is actually a step to improve the answer to improving ST elevation. In fact, I am part of the ACC global team, the GATI Global Heart Attack Treatment Initiative. I'm actually going to take as a chair, the global chair for this. And we have been doing this in 22 countries now. This philosophy is just what we are trying to spread to the rest of the world as well. But then I told you, there is one step further which I've been following with the lytic therapy. This is a guy taken up for a primary angioplasty, infraposterior MI. You can see the left main hardly visible there. The circumflex is not at all visible. 3 hours duration. And then we actually follow this intracoronary tenecteplase. Taken from, heparin is already on board when the patient is taken for an angio. Tenecteplase half, total dose is calculated just like what you do for the IV. 1/5 intracoronary, check angio later, and then that's what happens at the end of 4 hours. So we actually have published our own data. In fact, during COVID times, we had a lot of patients coming like this, extensive anterior wall MI, LV dysfunction, right is fine, left huge thrombus, the LED is not visible at all. Intracoronary lytics is that what we use there. And in fact, you can see the flow even within 5 minutes of the administration of intracoronary lytics. And that's what happened 4 hours later. Absolutely doing well. Well, this guy had actually a hyperhomocystinemia with a COVID positive, the antibody as well. So there are patients who have multiple problems like this. So this is what we do. But I think it's also important, STEMI is not just about acute care. You need to follow up, and the more important thing is you need to follow up them with an echo. And if you find that they have LV dysfunction, I think RAS inhibition with angiotensin converting enzyme is a way to go about. So this is also very important. This is a class 1A indication. And also, one would also look at a pre-discharge echo. It's very important. Imaging is important. In fact, some of the centers today, they also resort to a cardiac magnetic resonance imaging because there are a lot of newer things which are coming up with an MRI. And of course, the anti-inflammatory drugs, colchicine was recommended once upon a time. It's gone into disfavor. But then the question asked is, if ACE inhibitors are working, why not ARNI? In fact, the only trial that has tried to answer this question is a Paradise-M. There are a lot of controversies because this is done into COVID times. It did not have the sacubitril valsartan was compared to ramipril, did not have a desired benefit. Today, this is not recommended. The way to go about today is still an ACE inhibitor post-myocardial infarction. Now, the question about, I've been talking about IV beta blocker in a big way, but then the follow-up beta blocker, well, in a normal LV function, this is really debatable. I mean, the earlier guidelines said we could give up to 3 years, but then beta blocker use after myocardial infarction, this is one of the recent publications which has shown that one group where they interrupted did not make much of a difference. So somebody has a normal LV function, perhaps it's not important to have a beta blocker. This is just again a data which has come within a month's time. And the more important thing, I think what we should try to understand in our country is the dyslipidemia. We don't have the kind of cholesterol that you see in the Western countries. More often, it's actually a high triglyceride, low LDL, low HDL. So of course, we are very, very aggressive in terms of statin use. But then something which we recommend to take care of the lipids, the dyslipidemia, the triglyceride part is an addition of ezetimibe. So that's what we would recommend, and this is the algorithm where I am also one of the authors we developed this consensus statement for the Indian guidelines for dyslipidemia, which is something where we try to say that you use high-dose statin along with an ezetimibe in this context. Colchicine, I said, well, a lot of earlier trials showed positive, but then the recent clear synergy trial has come. The mean age was this. In all patients, if you try to use, it is not effective. You look at the MACE, it's hardly any different, though the high sensitive CRP came down in this. So routine colchicine in STEMI is not useful, and this is again one of the newer publications. Finally, question is about, apart from beta blocker, is in MRI. In LV dysfunction, well, this is the way to go about. But if you use a routine spinal or acute myocardial infarction, the same group of others, again, which is recently published in NEJM, says it's not really of much use. So we actually looked into our study. This was one of prospective studies when Kupaswamy Naidu was also one of the participating centers. We did this in South India. Actually, this was in ACC. We found that in a country like India, we use statin and aspirin, 98.5%. Clopidogrel is only about 77%. Ticagrelor is, though it's available cheaper when drugs are available, it's still underutilized. Beta blocker, it's about 76%, 72%. RAS inhibitor, 70%. I think what is important is this thing has gone, we are really improved a long way. Mortality is about 3.2%. Our primary angioplasty rates are definitely about 40-50% today. And the length of hospital stay average is about 3.2 days in STEMI. So we've been part of a lot of quality control programs right from Kerala, the ACS registry. We looked into quality control program, the ACS Quick. And again, we also had one more registry which was published from Kerala. This looked only at the primary angioplasty. I think we are really doing a lot of work, and I'm happy to share that I'm really by part of this GATI trial, which is done in about 20 countries. We are trying to, not just in India, but all over and Coimbatore is incidentally, the Coimbatore Medical College is actually part of this, the GATI program, and really proud of this achievement. So I think the take-home message is ECG is a key to diagnosis of STEMI. Biomarkers like the troponin and imaging, these are definitely useful, it's vital. Timely reperfusion is a strategy that you need to employ. PAMI is ideal, primary angioplasty, but then pharmacoinvasive is equally effective. And the only important thing is, even if you do a pharmacoinvasive, even if you find the desired results, timely transfer for a follow-up angiogram within 24 hours is the way to go about. Never forget about adjunctive therapy like heparin or enoxaparin, and the DAPT for a year, and of course beta blockers, ACE with MRI, in LV dysfunction. That's a guideline-directed therapy which you need to use in STEMI. Thank you all for the kind attention.
Thank you, sir. That was an excellent talk highlighting the management of ST elevation MI and wise usage of lytics outside and inside the cath lab. You have shown an excellent case of left main as well as carinal thrombus. So, do you still lyse if there is an ostial LED thrombus which might prolapse into circ if you think before attempting to open up the vessel? Do you lyse the patient or how will you go about it?
Yeah, this thing is very clear cut. If you think it's mostly a thrombus, so I think the clinical history is very important. The first thing that you need to understand, what is this percentage? Is it within 1 hour or 2 hours or 3 hours? I'm fairly clear in my mind that if they're coming very early and it's a young patient, 30 years, to my mind it's only thrombus at that point of time. In that context, I might use an intracoronary lytic. But then if I use a tenecteplase I always make sure that I take a check shot 5 minutes later. You will see the results in front of your eyes. So that is sort of encouraging. But then sometimes, in fact, I had a patient, to answer your question, young guy, 39 years, no risk factors, except for a bit of dyslipidemia, but a fitness freak. He had vague discomfort. He said he was doing his regular exercise, getting some discomfort, had a checkup from one of the premier hospitals in Coimbatore, absolutely negative stress test. And then they said, let's go for an angio. He had an angio also. And he had mild plaquing of the proximal LAD. And then, unfortunately, but he was very symptomatic. He said, I don't exercise, I don't feel well. He was not offered any therapy. He said, everything is fine, went home. He came with a massive MI, infarct. And then I was surprised. I expected only a thrombus in this point of this. But then there was a significant lesion also. Of course, I did not have the previous angiogram. So, in fact, I did stenting in this. But then, when you have a young patient, when you are fairly sure, like the COVID times, I would only resort to an intracoronary tenecteplase. But then, always a follow-up angio, 4 hours later is always done. And the other thing is that, even if you have a lesion, once the thrombus goes up, it becomes a very easy angioplasty, and you don't have the slow flow or any of the problems that you see with a primary angioplasty. But only thing is, message is, I will never use a thrombectomy catheter in an ostial LED. You will probably pull it back all the way to the left main or back even into the circulation.
Sir, I am a physician. I practice in a small town which is nearly minimum 60 minutes away from any cath center. So my passion is emergency medicine, particularly reperfusion in STEMI. So I thank you for insisting upon 3 points like pre-hospital thrombolysis. But what it means for a physician like me, where we don't have any, what it means to me, like in the absence of myself in the hospital, is it okay for me to lyse the patient with the help of physician assistant or duty doctors, which I do sometimes? One. At the second is the half-dose thrombolysis. Really, I am very thankful because half-dose works. I often use retiplase, which I see even after the first dose, within 10-15 minutes, even before the second bolus, the ECG changes, the changes of recanalization as well as the pain subsidization happens. So even in young patients also, half dose works, and so this half dose in a high risk patient where the bleeding risk is high, it is highly preferable. And regarding this, I was asked once why I am going back to my hometown after my MD without pursuing any super special. I told in corporate hospitals, patient get angioplasty primary PCI. In cities, patient get thrombolysis. In small town like us, we get only antihypertensive and antacids. I would like to change the antacids and antacids into thrombolysis. So my request to all the fellow physicians, act fast, act stronger. Use the best medicine available in your hand, fibrin specific agent, let it be tenecteplase or retiplase. Thank you.
Yeah, first and foremost, let me congratulate you for having that initiative and the right bold decision to go to the periphery. In fact, that is the need of the hour. In fact, all of us, even cardiologists. So, but then your point is well taken. But I'll tell you, I am not a corporate hospital. It's a small one-man managed hospital. But then the point is, if you're able to deliver care, you can deliver care anywhere. It's just that you must have the mindset. But then if you're doing a primary angioplasty, you have to be committed. So, there's no point saying that I'll not see a patient that if you don't do a primary angioplasty in the middle of the night, doesn't work. So the second important thing is, see, it's also important to understand if you are in practice, we should be following guideline and whatever has been the data driven. There should be some scientific backing. The only scientific backing for a half-dose lytic therapy is the STREAM trial data, where tenecteplase is the only drug which has been tried. Giving half the dose of for example, if the patient, unfortunately, before reaching some other place, if you're shifting the patient dies, somebody can go after you. Legally, you may not be safe to follow. And why are you giving a reperfusion? Because reperfusion is the only way that will salvage a patient's problem. And that has been in a timely manner. That is why I'm not trying to promote a product here, but then the advantage of tenecteplase, even in the cath lab, I sometimes use intracoronary streptokinase. It's cheap, it is effective. But then, if given a choice, because tenecteplase is quick acting, and if all that you need is 5 seconds, why do you want to infusion go on? Why do you want to give a second dose? Even this 30 minutes, if it were your father or mother, you would like to have the desired results within 5 minutes. So I think from that perspective, ideal drug today is tenecteplase. There's no doubt about it. I'm sure the other drug also works. And anecdotal reports, half the dosage of medications might work, but that's not a recommendation for a take-home message for somebody in the periphery to use half dose. I think we should go by whatever. It's just like a NOAC, 20 milligram for atrial fibrillation or 15 milligram. You cannot go to 10 and 5. And underdosing is also known to have a significant issue. Also, let me tell you, when we started the primary angioplasty program in Kerala, today, any center in Kerala, it's not just our center, even if there's a cath lab available within 30 minutes everywhere. I'm sure it must be the same in Tamil Nadu also. So I think it's possible to offer primary angioplasty. If somebody cannot offer, and you sincerely believe that this takes more than 120, then that's the way to you to do a pharmacoinvasive. More importantly, even if it's a pharmacoinvasive, make sure that you have a follow-up angiogram.
What is the intracoronary dose of tenecteplase?
Well, it is basically what you calculate based on one important thing, which in fact in the paper that we published also, it's important to understand that the lytics should remain in the system. So even if you're administering intracoronary lytics, the full dose has to reach the circulation somewhere. So the intracoronary is, you calculate 0.5 mg per kg. For example, somebody is 60 kg is 30. 1/5 is given intracoronary as the first shot. And then you take a 5 minutes later angiogram to see what is happening. If you still feel there's a significant thrombus, push another 1/5. But the remaining 3/5 has to be given intravenous. You need this to be in the system. It almost works like, but then the only thing is that you're sure of what you're doing here. If you look at the history of lytic therapy also, 1984 streptokinase was given intra-arterial. First, they found it effective, then later on, the problem of taking everyone to the cath lab and so many number of MIs, intravenous works the same way. So that's how the whole system shifted to intravenous lytic therapy. So I think intracoronary 2 doses maximum, but then remaining has to be given, followed up with heparin. So why do you prefer ezetimibe instead of fenofibrate? Yeah, so that's a very good question. Now the only thing that we have found out is that when you have an elevated triglyceride, the intermediate laminin, it actually converts into the high triglycerides actually starts getting converted into the intermediate dense lipoproteins or the IDL, and this actually becomes a atherogenic LDL sort of a thing. The only drug which has really shown an efficacy in this is ezetimibe. Now, fenofibrate, for all you know, it brings down the triglycerides, but there is no outcome data. Even in the kind of trials that has been done in diabetic patients, the field trial and so on and so forth, there's no outcome benefit. Whereas ezetimibe is one drug which has got an outcome benefit. And why it is effective is because it has an effect on this intermediate density lipoproteins, ideal. That's what I showed here. In STEMI, in chronic situation it's effective. But when these are all patients who had a high sensitivity CRP. But then the caveat is, this is a drug which cannot be used when you have a renal dysfunction. In colchicine, somebody has an elevated renal parameters, it's better to avoid this drug. But so the hypothesis was that if there is it should be effective in all MIs, but in all MIs, in all comers, it's not effective. That is the message. So it is not recommended for all patients. Well, it all depends on you routinely have to. I have been doing high sensitive CRP. One trend which I have been seeing over the last few months, high sensitive CRPs are very high in young individuals. So if you find some inflammatory marker like that, it may be effective. In fact, I am part of a global trial now where we use monoclonal antibody as an adjunctive to reperfusion, only in patients who have undergone angioplasties. This is called the Artemis trial, where we use a monoclonal antibody. And these are basically patients who have high CRP. And that inflammation cascade is being addressed. But we are not too sure. I think too early days. We still have to wait for the results to come after 2 to 3 years.
Sir, age more than 75, you said half-dose lytic with tenecteplase.
Yes.
Likewise, for the other thrombolytic agent, do we
That's
have
what I'm saying. We don't have data. And unfortunately, the follow-up studies are not too good.
Sir, one more question. To the, you have a vast experience, like starting an IV metoprolol to going to lysing your assistant professor and coming for a stenting. And what is your experience with intracoronary tirofiban and intravenous tirofiban going for a primary PC?
Yeah, very good question. I still use a lot of intracoronary tirofiban. I mean, for example, somebody comes to me after 6 hours, I will not touch a lytic therapy until it's a salvage, for example. But my preference is somebody comes late and then, let's say, even say 24 hours, you find a lot of muck. That's the time when I use all these gadgets, the thrombectomy, you try to physically remove it. There it works. Tirofiban, again, it's a mild thrombus, it's more of a habit than anything else, but it works in small thrombus when you have stented and you find a slow flow. That is the time when I use a lot of intracoronary. The follow-up we used to use, in fact, when 97, I still remember the day when my cousin had an angioplasty in KMCH, that the first time I used abciximab. But then the point is today, tirofiban is equally effective, it's supposed to be better than other drugs, but it's mostly intracoronary, 3 shots, maximum 15 ml. And I have a slightly different take on this though. It's actually the medical dose of tirofiban that we're using. And it's again 7,500 heparin that I routinely use in PAMI. And then if somebody has a huge thrombus burden, I keep it going for about 6 hours, not beyond that. I don't use it for 12 hours or 24 hours.
Do you use intravenous thrombolytics during CPS, sir? You had used it for one of your patients.
Well, what is the choice
during?
Yeah, so long as
the tenecteplase.
So yeah, that's a good question. So long as somebody,
during CPR.
That's what I'm saying. But this patient has had a VTVF. The massage is generally to when they have been just to get back the rhythm. This mostly VTVF 10 to 12 times. And then we have already done the echo mission is there's no pericardial. There's nothing else that you can do at that point to save him. Time is, by the time you shift him to the cath lab, he's all gone. So I think this works. I mean, once in a while, in fact, there was a lady 2 days back, couldn't do anything. By then, as you said, when you looked at it, they had a massive pericardial effusion. Then that's a no for a. But otherwise, it's fairly safe.
Sir, after a failed lysis, how early can the patient can be taken for a CAG? And is there any modification of the antithrombotics that we give during the CAG when the patient is immediately after failed lysis? Yeah,
so you need to understand the document, the heparin which has been given. So 90 minutes is a classical thing. If somebody has an ongoing chest pain, you don't have a 50% resolution of ECG change, you take them for all that you do is usual dose of heparin, but never combine tirofiban there. Say the half dose this thing, the ASCENT trial was a trial which looked into it, ASCENT 4. Never use half dose of this thing plus a tirofiban. In fact, this was very popular once upon a time. In fact, you have excessive bleeding. So I don't use tirofiban in that context. Just the usual heparin and then get away with it. Take them as early as possible because your lytics are not working.
Thank you, sir. Thank you for the wonderful presentation and discussion by the panel. Let me invite Dr. Jayagopal sir to felicitate our chairperson. Dr. Devigan sir, Dr. Vigneshwaran sir, Dr. Sivabal sir, Dr. Sujay, Dr. Praveen Raja sir and Dr. Muhammad Ibrahim sir. Let me also invite Dr. Siddharanathan sir, a senior physician, to felicitate our speaker, Dr. Jayagopal sir. Siddharanathan sir. So with this we'll close the session 1. Let us break for a few minutes for the inauguration of AF Clinic, and then we'd follow with our next session on EP. Thank you. Let me invite Dr. Sujay to take over the proceedings for the inauguration. Thank you.
KMCH Center of Excellence. I call upon the respected dignitaries on the stage. I call upon Dr. Arun N. Palaniswamy sir, our Executive Director, onto the stage. Dr. Murugan, our Medical Director. Dr. Natesha Pandian. Dr. Suresh Kumar. Dr. Jayagopal. And Dr. Arun Gopi onto the stage, please. I request Dr. Lawrence sir to give the introduction on the atrial fibrillation clinic.
Good morning all. I think thank you for the opportunity, and it was really nice to see on a Sunday morning a crowd of 130, 140 people attending an academic conference. In this occasion, we are also happy to launch what we feel is a future of managing atrial fibrillation. We want to have a AF clinic and atrial fibrillation center of excellence at KMCH. We thought this is a pretty important concept, considering AF being a disease which is primarily overlooked at multiple levels, and treatment has become very specific. We know how to manage atrial fibrillation now from medical point of view, which patient has to be given anticoagulation, and anticoagulation has to be monitored in most of these patients, and we also know now which of these patients has to be referred further for the management. In this background, I think AF clinic has a very important role. Every patient of atrial fibrillation need to be followed up very closely for the stage of atrial fibrillation they are in, and who will require an anticoagulation. And if this patient have been given anticoagulation, they have to be closely monitored from the AF clinic. So that's the reason we thought we'll launch this AF clinic, which we are planning to run every week on Fridays, and this will be manned by a cardiologist, electrophysiologist, along with a physician assistant, so that all these patients can be enrolled. Having an atrial fibrillation separately maintained gives us a big advantage of having a data which is lagging in most of our Indian population. With this background, let me invite all you to join for this AF clinic inauguration. Thank you.
I request our Executive Director, sir, Dr. Arun N. Palaniswamy, sir, and Dr. Murugan, our Medical Director, for the AF clinic plaque opening. I request all the dignitaries to please join. I request Dr. Suresh Kumar, sir, our cardiologist, to felicitate all the dignitaries. Dr. Suresh Kumar sir. To felicitate Dr. Arun N. Palaniswamy sir, our Executive Director. Dr. Suresh Kumar to felicitate Dr. Murugan, our Medical Director. Suresh Kumar sir, kindly felicitate Dr. Natasha Pandian. Suresh Kumar sir, kindly felicitate Dr. P. Jayagopal. Suresh Kumar sir, kindly felicitate Dr. Arun Gopi. I request Dr. Lawrence sir to felicitate Dr. Suresh Kumar. Next, we move on to the felicitation address. I call upon Dr. Natasha Pandian, Medical Director, Heart Valve Center, California, to deliver the address.
Thank you. Obviously, my congratulations goes to the whole Covai Medical Center team. And atrial fibrillation clinic might start with one afternoon or one day, but I will tell you, patients will keep on coming. And I tell some of the fellows who wants to go into EP, and I tell them, don't worry. All you need is one arrhythmia. This atrial fibrillation will keep you busy forever and also make you decent money. So go ahead, I used to tell them, because it has been there for so long, so many years. Because of my, I guess, seasoned, or being a senior cardiologist, I gone, seen, and taken care of patients with atrial fib, starting with quinidine, procainamide, and all that, and go on many stages. I worked with, I'm not a primary EP person, but I worked with them closely. And then there was a time, only way to treat is take the patient to a cath lab or EP lab, give a given drug, and see what happens. And then give another 1 or 2 days for washing it out, and then repeat that again. So one has gone through a lot of different stages. Now, of course, besides changes in the medical management, we have the ablations. And so I work with the EP guys closely. And then the appendage closure, because clots tend to form there. So a lot of things are happening, and of course we saw the guidelines. I will tell you, whatever guidelines you heard will be different 10 years from now. Okay, so don't think it's Bhagavad Gita or Tirukural or something. It'll always keep changing. I've been in guidelines, so I know how they are made. And second point, the guidelines is, most of them are published from Western population, and that doesn't necessarily apply to ethnic population in India or any other country. We got to keep that in mind. Things will keep changing, and whatever the guidelines, this, they say, will change. So they don't know. They will talk about guidelines, zillion slides and all that stuff. So worth making about. The final point I want to make is there's an entity called atrial cardiomyopathy. Okay. And now slowly people started talking about it, writing about it. It has always been there. It'll always be there. And one of the most common contributors is atrial fibrillation, recurrent, chronic, and so forth. It's complex, more complex than just an enlarged left atrium. But you will hear more and more about it. There is no specific treatment, but you treat the underlying disease. Earlier, you control the atrial fibrillation or correct the atrial fibrillation, the better. Otherwise, it goes in a circle. You know, atrial cardiomyopathy, atrial fibrillation, it goes on and on and on. So keep that in mind. And I'm going to stop here. I can talk a whole day on atrial fib or anything. And that's about it, I'll say for now, 3 minutes. I think it should be less than 3 minutes. Okay, thank you.
I call Dr. Suresh sir to give his felicitation address.
Good morning to everyone. In a Sunday morning with a full crowd in this residency hotel, I am very happy to see all of you. The management of atrial fibrillation will change a lot in coming years. So we need excellent data from Indian perspective. So Dr. Lawrence has taken a very big initiative under our chairman's visionary improvement in this, whatever the available latest equipments available for the AF care, we should provide to all the people at affordable cost. So our executive director has recommended, and we got a cryoablation machines. That's a wonderful tool for the early management of atrial fibrillation. Cryoablation is the way in near future. We need a definite data for this. So this AF clinic, one of unique in our country. This is, I think, this may be the first in Tamil Nadu or in South India. It's a wonderful concept. I wish all the success for AF clinic under the guidance of Dr. Lawrence. Thank you all.
I request Dr. Arun Gopi sir to give his message.
Respected dignitaries on and off dais, a warm good morning to all. So at this point, I really take this opportunity to congratulate my close friend and associate, Dr. Lawrence, for having taken this initiative. It's actually out of the box thinking to bring this AF specifics clinic, getting out Center of Excellence for AF at this 9th covai Heart Rhythm Society, because as an EP person myself, we realize that although AF is the most common sustained arrhythmia we see in clinical practice, contributing significantly to the morbidity and mortality of our patients, it is unfortunately very much neglected in our part of the world compared to what happens in the West. In West, you see a lot of these patients being well managed with ablation, LA appendage closures, and majority are, even if they have a failed procedure, undergoing redo procedures, thereby reducing the progression of the natural history of disease, and also even heart failure patients being aggressively managed with ablation. That actually goes a long way in reducing the morbidity and improving the quality of life. Unfortunately, in our part of the world, AF was treated medically for almost many decades. In fact, ablation took a backstage, and that actually has hit our patients as well, because most were treated like rheumatic AFs, that they had no treatment options. But this initiative, I really think it's for almost the first initiative in our whole of our country, because I've not heard of an AF specific clinic in the whole of our country. So having this AF clinic with a center dedicated towards achieving excellent care for AF patients would definitely go a long way in improving care, so that you filter out these patients out from your busy EP practice, give specific attention for these patients, because AF begets AF, and it's not a one-time treatment option like you manage your SVTs with an ablation, or you manage idiopathic VTs with an ablation, where with one shot ablation you are curing these patients, but AF you are not going to cure them unless you are hitting them very early on. So to pick these patients up early, manage them early, goes a long way in retarding even the natural history of these patients, and probably this clinic catered specifically towards atrial fibrillation alone will definitely do a lot good to people around. And I really congratulate Lawrence and give all the facilitation to him for taking up this novel initiative, and wishing him all the best.
I call upon Dr. Arun N. Palniswamy sir, our Executive Director, to deliver his presidential address.
Good morning, everyone. Happy to see everyone here on a Sunday morning. Now I realize I'm becoming very old now. Even though I think 15 years ago I was a young doctor, now I'm no longer. Because now I'm remembering to say things like, back in my day when I first started studying, it was like this. So I have to begin it. Back in my day when I first started studying, we had a very simple rule when it came to AFib. You want to cardiovert the young people, and then the older people you can rate control, and then you can anticoagulate. That was the basic thing. But what is young person anymore? We'd all had an expectation that a 60-year-old patient will only live till 70. Now our expectation is they all have to live till 90. So where is all this? Therefore, all my easy options. I used to be internal medicine. So my easy option is now with things like rate control with, say, if I can't use beta blocker, I can use amiodarone. Very easy to use. But now my patient's going to live for 30 years. So all these options are now going out the door because my patients are living longer. And my technology has now improved. The ablation technology, which we used about 15 years ago, is now improved now. You're now seeing things like enhanced ablation, the magnetic imaging so they can see better things. You can see they did cryo now. Next generation on the horizon, I think, is pulse field. That hasn't come to India yet. But slowly, we're heading in a direction where what we learned, as he said, what were the guidelines 15 years ago, may no longer apply in the future. So when we offer our patients, we have to offer them the best. We offer after them what we can do now. As I said, the chairman wishes he could be here, but he's still 86 and he's still going strong. So I said, you're going to go for another 10, 15 years. So all the medications have to be on that point. You can't just put people on amiodarone or some of the older medications. You have to offer them what could potentially be a long and healthy life. So with that in mind, we are going more into specialities, KMCH in general. One is to do AFib as an excellence. There's a whole lot of data that if we can do with rhythm and rate control and with ablation and cardiovert them back to normal rhythm, that we can maintain the normal cardiac architecture and they can live a longer life. Soon we'll go into other things and super specialities, like next role will also, as I said, pulse field, but you're going to go into things like genetics. So then we can identify earlier at-risk patients, and then we're going to treat them earlier. So 100% the guidelines are going to change, but with that, we also have to evolve ourselves, and I'm glad to be here on a Sunday morning. And another 10 years, I'll be here on another Sunday morning saying what the new stuff is. So thank you all for coming, and I hope you have a great time.
Thank you so much to all the dignitaries for a very successful inauguration of the AF Clinic. Now we move on to the next session.
Thank you all. Thank you all for being with the inauguration. Let us move on to the next session, which is going to be the, I think, primary focus of the meeting. We are going to have an EP masterclass session. To start with, let me invite Dr. Vidyagar to talk on management of supraventricular tachycardia, drugs and beyond. For this session, Dr. Sambasivam sir, Dr. Palanisamy sir, Dr. Mariappan sir, Dr. Suresh sir, and Dr. Pachepan sir, Dr. Prabhu Venkatesh sir, and Dr. Dileepan, please. Thank you, sir.
Good morning to all of you. I thank Dr. Lawrence for giving me an opportunity to present this topic here. You would have heard about AF, which is the growing topic, and most of the electrophysiology community is concentrating on radio frequency ablation and beyond towards AF. So I am dealing with non-AF related supraventricular arrhythmias. So even though it is there for a long time, you should not forget. It is still a bigger problem in our country. I will just, my topic is management of supraventricular tachycardia, drugs and beyond. Whatever latest available, I will be emphasizing on. But you should know that the last guidelines in SVT has come in 2019. Because most of the concentration is towards AF and people are updating AF every year, people, I think they have forgotten SVT. So last update is only in 2019, and the number of new drugs in the field of SVT management has almost stopped. One or two drugs available, but since catheter ablation has taken over most of the management of SVT, the technology in catheter ablation has gone into a great extent rather than the pharmacological management. So what is supraventricular tachycardia? Any tachycardia abnormal more than heart rate, more than 100 per minute, arising in a tissue above the his bundle is a supraventricular tachycardia. Even though atrial fibrillation is also arising above the his bundle, it is a different arrhythmia, and I am not going to deal with AF. SVT may present mostly as narrow QRS, can be presenting as wide QRS also. So what is narrow QRS and wide QRS? Narrow QRS means less than 120 milliseconds. See, the main emphasis of my topic is you have to identify what is the tachycardia. Just somebody is having narrow QRS doesn't mean it is only supraventricular. It can be anything. So what is the incidence? It is around 2.5 per 1,000 patient population. Most common is AVNRT. AVNRT is most common in females, whereas AVRT is common in males. AVRT more common in younger person, and as the age increases, the other supraventricular arrhythmias like atrial tachycardia, atrial flutter comes into importance. As the age increases, AVRT incidence is coming down, and AVNRT and atrial tachycardia increases. So what is the conventional classification of supraventricular tachycardia? Generally, any sinus tachycardia is a supraventricular tachycardia. If it is inappropriate or sinus node reentrant tachycardia, atrial tachycardia is either focal or multifocal or macro reentrant. Macro reentrant can be either CTI dependent, non-CTI dependent. These are all specific types of supraventricular tachyarrhythmias. Then AV junctional tachycardia and AV reentrant tachycardia. If you see AV reentrant tachycardia, even though the pathway is connecting between atrium and ventricle, it is conventionally classified as supraventricular arrhythmias. So whenever you approach supraventricular tachycardia, basic, whether it is narrow or wide. Narrow means less than 120, wide means more than 120 milliseconds. If it is regular or irregular, SVT is mostly atrial fibrillation, so it is separate. Now if it is regular, there are three common arrhythmias: AVNRT, AV reentrant tachycardia, and atrial tachycardia. If it is wide, most common cause of wide QRS tachycardia is ventricular tachycardia, but SVT with aberrancy or fixed bundle branch block can present as wide QRS tachycardia. So supraventricular not only present as narrow QRS, can present as wide QRS tachycardia. So, and you should always remember that in narrow QRS tachycardia, you can have specific types of idiopathic ventricular tachycardia, especially septal ventricular tachycardias, idiopathic left posterior fascicular tachycardia, which will mimic supraventricular arrhythmia and doesn't fit into any of the usual criteria which you use to differentiate between supraventricular and ventricular tachycardia. So here there are some specific features. Unless you know, you may miss and treat it as wrongly as supraventricular tachycardia. Also, you should know that supraventricular tachyarrhythmia with fixed bundle branch block or aberration or a manifest pre-excitation can present as wide QRS tachycardia. So, you know it is narrow QRS. Next step is whether you are able to visualize P waves. If it is P waves are visible, then are you seeing equal atrial and ventricular rate or atrial rate greater than ventricular rate? If atrial rate greater than ventricular rate, possibly atrial tachycardia or atrial flutter. If ventricular rate greater than atrial rate, most probably ventricular tachycardia. If both are similar, then try to identify P waves. If P waves are closer to the previous R wave, then it is short RP tachycardia. If it is not so, it is long RP tachycardia. So I'll just go through each of the tachycardias during my talk. Now since my presentation is on management, I will tell you how to manage a narrow QRS tachycardia in both acute as well as chronic setting. So somebody presenting with narrow QRS tachycardia, whether they are hemodynamically stable. If hemodynamically unstable, do not waste time in identifying what type of tachycardia. So directly go for cardioversion. But you should ensure that whether it is really hemodynamically stable. Sometimes patients can have borderline BP, normal LV function. Do not jump into cardioversion because you may rarely miss an arrhythmia which might require anticoagulation. So give him some fluid. If he is responding to the fluid challenge and hemodynamically stable, because then only you will be able to identify whether the tachycardia is a specific type. Because specific type, identifying the individual type of tachycardia is important because the management differs. So what are the available methods to delineate different tachycardia? So one is Valsalva maneuver, then carotid sinus massage. It is also a type of Valsalva. Then drugs like intravenous adenosine, intravenous calcium channel blockers, beta blockers, DC cardioversion, and finally catheter ablation. These are all time-tested therapies available. There is nothing new. I will be just adding upon some changes which have come to some, making some noise in this AF era in the last 2 to 3 years. Not widely available. Certain drugs are not even widely available. There is the guidelines emphasizes on acute management with drugs, and in case of recurrent tachyarrhythmia, most of the guidelines have gone for catheter ablation because the treatment should be permanent rather than temporary. So now I will be trying to explaining with some clinical scenarios. So this is the narrow QRS tachycardia. So whenever you see a narrow QRS tachycardia, first step is it narrow? Yes, it is narrow, less than 120 milliseconds. So next, identify the P waves. So can anyone tell where the P waves are? So I think this is the P wave. It is not a typical T wave. Some T wave rarely is biphasic. So usually this is T wave and P is buried inside QRS. So that is how this is a possible P wave. And this P wave is closer to this QRS or this QRS. So closer to the next QRS. So it should be a long RP tachycardia. So this is how you have to recognize a narrow QRS tachycardia. Now, the first step is to do a Valsalva maneuver. If patient is stable, not much symptomatic, you can either give adenosine or Valsalva maneuver with carotid sinus massage or typical standard Valsalva. So when you do a carotid sinus massage, usually carotid sinus massage should be given in one of the carotids. Don't give both the carotids. So these things you know. So the duration of carotid sinus massage should be around 5 seconds with adequate pressure. Don't just touch and say it is not working. So most of the times it fails only if the technique is not done properly. And it should be given with a nice pressure over the C4 vertebra at least for 5 seconds. So that by it takes at least 5 to 10 seconds for it to respond. You can repeat on both sides one by one. The take-home message is, younger patients it is okay. For older patients, more than 45 years, try to rule out local disease like carotid bruit. If somebody is having carotid bruit or history of any TAA, better avoid carotid sinus massage. So the response to carotid sinus massage is around 20 to 25%. So most of the times it is not done properly, and even if it is not done properly, the response rate is around 25%. So here the tachycardia gets terminated with a P wave. So whenever a tachycardia gets terminated with a P wave, it is usually a AV node dependent tachycardia. When it terminates with the QRS, it is a non-AV node dependent. Usually atrial tachycardia terminates with QRS. Here it terminates with a P wave. So this is one of the examples of AV node dependent tachycardia. Now here, this is also narrow QRS tachycardia. Didn't respond to CSM. Then we gave intravenous adenosine. If you see, tachycardia is terminated, but something is seen when you carefully look at the ECG. The number of P waves are more than the number of QRS, and the atrial rhythm, the atrial rate is almost just reduced less than the tachycardia. So that means there is an AV block, and the tachycardia is continuing, and slowly again it is. This is called cooling down and warming up period, and tachycardia terminates, and again it is restarting. So this is typical of atrial tachycardia. Atrial tachycardia, it responds to adenosine, but tachycardia doesn't terminate. Only AV block is terminated. If you had cardioverted this patient, we would have missed the diagnosis of atrial tachycardia. So go step by step. Even if it is hemodynamically unstable, make sure that it is real hemodynamic unstable. You can give fluid challenge, see how he is responding, then take time to go step by step, and our aim is to establish the diagnosis rather than to treat, because the diagnosis itself is treatment dependent. Now AV node dependent is AVNRT or AVRT. AV node independent or doesn't depend on the AV node is atrial flutter and atrial tachycardia. Rarely sinus node reentrant and inappropriate sinus tachycardias are some of the tachycardias which are diagnosed of exclusion. So what happens to adenosine? So you have seen adenosine, when you give adenosine, no change in rate is usually due to inadequate delivery or wrong delivery. So adenosine has a very short half-life, and you should always give immediately, within few seconds, and it is usually delivered in a large central vein, ideally antecubital vein. If somebody is having a central vein in the jugulars, you can directly give the adenosine dose, and the usual dose is 6 to 18 mg. You give in the you can start with 6 mg, not responding, you can go up to 18 mg. The effect of adenosine is very short, and within 9 to 10 seconds it goes off. So you can repeat multiple number of times. Only contraindication is acute severe bronchial asthma, or somebody is who has taken a lot of caffeine before coming to the emergency. Even now they have found that even in case of acute asthma, giving adenosine has not increased the worsening of asthma. So a lot of trials have come. So just because somebody is saying he is having asthma or history of COPD, you don't need to avoid IV adenosine. Second response is, if there is sudden termination, usually AV node dependent. So AV node dependent is AV NRT and AV RT. Very rarely atrial tachycardia also responds to IV adenosine. Now we have seen the previous example. Atrial rate is going on at the same rate, but AV block has happened. So that is diagnostic of atrial tachycardia. And rarely you have gradual slowing and reacceleration. most commonly in sinus tachycardia, some automatic focal atrial tachycardia, and narrow QRS ventricular tachycardia also will not respond to IV adenosine. So there are some atrial tachycardias which responds to adenosine if the mechanism of action is triggered activity. So atrial tachycardia can be focal. Focal, it can be either automatic or triggered. If it responds to adenosine, we can only rule out that it is not automatic atrial tachycardia. Both micro reentrant as well as macro reentrant and triggered activity induced atrial tachycardia responds to IV adenosine. So when you give IV adenosine, if it is atrial tachycardia and it responds, you can rule out automaticity of atrial tachycardia. So what are the drugs available? So as I told adenosine 6 to 18 mg. So you can increase the dose from 6 mg. Don't give directly 18 mg. So maximum dose is 18 mg. More than 18 mg, no effect. If it is not responding to adenosine, you can go for verapamil. Dose is 0.075 to 0.15. So maximum around 5 to 10 mg over 2 minutes. All these drugs should be given without mixing with the normal saline or other drugs. Direct stat over 2 minutes. Any delay in giving this drug will negate the effect of the drug. You can repeat it after 30 minutes, both verapamil, dilzem. Esmolol is another short-acting drug. Metoprolol is another drug which are available as IV. Another new drug is etripamil. This is a short-acting calcium channel blocker with a rapid onset of action. It is given intranasally. It is not available in our country. They have started using it in other countries, in Western countries, since 2022. There are some technical issues related to this drug and some medico-legal issues, like this is a self-administered drug. So patient should know that he is having SVT, and he should be advised by the doctor how to use this drug. So otherwise the drug cannot be used, because patient, if it is wrongly used, there is no benefit from this drug, so therapy itself is useless. And usually in acute setting, in somebody is having severe LV dysfunction, acute pulmonary edema, and if you are not sure of the diagnosis, if still you can have, as I told, narrow QRS VT can present as narrow QRS tachycardia. In such situation, these drugs should be avoided. So coming to individual arrhythmias, if the patient whom we saw treated with IV adenosine, it is a atrial tachycardia. So if it is hemodynamically unstable, cardioversion. If it is stable, diagnosed with IV adenosine, you can give either beta blocker or verapamil. Amiodarone has been pushed out of most of these guidelines. So avoid IV amiodarone in both acute as well as chronic setting, mainly because of toxicity. And in chronic therapy, catheter ablation has been given class 1 indication more than all these drugs. If patient is not willing for catheter ablation, you can continue these drugs. One episode of any SVT, at least continue the drug for 6 months to 1 year, because recurrence is an issue. And if there is a recurrence, it is not responding to any drug, catheter ablation is the only answer. So this is another type of SVT where you are not sure what tachycardia it is. So you give IV adenosine. So after some time, what happens is, so it is atrial flutter. If you would have cardioverted, we would have missed atrial flutter. See, there is sawtooth appearance of the P wave. This is typical of atrial flutter. If you would have cardioverted and successfully treated, we would have missed atrial flutter and patient would have gone home without anticoagulation. So atrial flutter, yes, if our aim is not like atrial fibrillation where possibility of rhythm control, rate control is there. Here, rhythm control is the initial strategy. There is no rate control in atrial flutter. So rhythm control, either give cardioversion or IV beta blocker, dilzem. Cardioversion, there are some school of thoughts where you can go for low energy, but usually go for high energy because first success is always the best method of treatment. There is an emphasis on newer drugs like IV ibutolide. IV amiodarone is considered as a class 2B level of evidence C because of toxicity as well as the complications from IV amiodarone like prolongation of QT, and in patients with already on multiple drugs, prolonged QT can induce unnecessary QTC induced prolongation induced arrhythmias. So IV ibutolide is a good drug. It is available as an IV formulation, safer drug. Only thing is be sure that there is no severe LV dysfunction and electrolyte imbalance. You can give it as 1 mg bolus over 10 minutes. You can repeat it more than one time. The conversion rate is more than that for amiodarone, and it is safer than amiodarone. Otherwise, you have to consider going for catheter ablation. In chronic atrial flutter, the role of drugs has been pushed down. The catheter ablation is considered as the class 1 drugs because most of them, when they are chronic, they either present as heart failure like tachycardiomyopathy. So in scenarios where patient develops tachycardiomyopathy, catheter ablation is always superior to drugs. Do not waste time in trying pharmacological management because catheter ablation is safe, effective, and reverses the LV dysfunction. Otherwise, when you miss this tachycardiomyopathy, patient might very rarely end up in assist devices and heart transplantation. So this is day-to-day narrow QRS tachycardia. When such tachycardia, you receive such patients in your clinic, there are some specific clues in this ECG. Like, see, you have a small hump in the QRS, and there is a small hump in this QRS. So this is pseudo R and pseudo S. This is a narrow QRS tachycardia with a pseudo R, pseudo S, and a pseudo R in AVR. This is specific for AVNRT. So when you have an AVNRT, again same, diagnose whether it is narrow QRS tachycardia, hemodynamic instability. If it is stable, go for vagal maneuvers. Usually vagal maneuver, most AVNRTs respond to vagal maneuvers. And even IV adenosine, around 70 to 80% response to AVNRT response to vagal maneuvers and IV adenosine. Now, this vagal maneuver has been modified multiple times. So normal standard Valsalva is very less effective. So they have modified it as modified Valsalva, where the patient is asked to breathe inside a syringe. This is a newer technique. The efficacy of Valsalva is increased from 10 to 50%. So in a remote area where you don't have adenosine, you can try this, where you blow a syringe for 15 seconds. This is how it is done. So 15 seconds in supine position, ask the patient to blow, then immediately you lie down the patient, then raise the leg. And again, after 30 seconds, come back to the same recumbent position. So what happens is Valsalva has 4 phases. Phase 0, phase 1, 2, 3, 4. First phase on increasing the, when there is forced exhalation in a closed syringe, the intrathoracic pressure increases and there is a bradycardia. It is a reactive to the increase in intrathoracic pressure. Now phase 2 generally causes reactive tachycardia, but immediately when you raise the leg, there is a gush of blood into the ventricles. So what happens is venous return increases, the reaction is bradycardia. So there are 2 steps of bradycardia which is making this modified technique superior to your standard Valsalva. So you can try this when you don't have adenosine, or you have time, you don't have time to treat the patient, or IV adenosine may take time to bring the adenosine to your clinic. Don't give IV Cardron in this setting. When somebody is coming with palpitation, stable, you have a lot of time to manage this patient. You can try this modified Valsalva technique. So another new drug is etripamil, not available in India. Maybe in future it can come. Only problem is self-administered. Why nasally? Because the nasal mucosa has highly vascularized. So it has some vessels directly connecting into the SVC. So when this drug is administered, it goes to the SVC, SVC drains into right atrium and goes to the AV, SA node and AV node. So it causes AV blocking effect and terminates the tachycardia. They say, especially in AV NRT, the success rate is around 95%. And if patient is educated well enough by the doctor, he can consider taking this drug wherever he wants if he is not willing for catheter ablation. So catheter ablation for AV NRT has become class 1. Only in acute setting you give drugs, chronic, no need for drugs, directly go for catheter ablation because the success rate is around 98% and complication rate is very less. So similarly, AVRT is also one of the types of SVTs where catheter ablation is given a class 1 indication. Amiodarone has been removed. Don't give amiodarone. This is a different type of tachycardia where the tachycardia is broad, irregular. It is a specific type of tachycardia where patient usually presents in with hypotension. And this is specific for a pre-excited AF. You see, there is some undulation in the antigrade forces of that R wave has some undulations. So this is typical of tachycardia going through a pathway, and this is called pre-excited AF. So in pre-excited AF, only treatment is don't wait, cardiovert, and post cardioversion you will be seeing a short RP, short PR interval with a delta wave. So this is typical of a WPW syndrome presenting as pre-excited AF. Now the treatment is catheter ablation. No amiodarone. Amiodarone was given in 2003 guidelines. Now it is removed because it has its own side effects. Like when you give IV amiodarone, the first effect of IV amiodarone is beta blocking effect. So beta blocking effect, what is the problem is it will block the AV node, and if there is a pathway, atrial fibrillation will become ventricular fibrillation and patient can have cardiac arrest. So that is why cardioversion is the treatment, and long-term treatment is catheter ablation. So the success of catheter ablation is most of them will have 95 to 97%. Recurrence, even though recurrence rate in atrial tachycardia is high, other tachycardia atrial recurrence is very less and complication is in single digit. Now another dilemma which we daily face is somebody presenting to you with this ECG. So young 24-year-old fellow, he wants to go for army. You see this ECG, he definitely wants, he is asymptomatic, he definitely wants clearance from you. You are not sure what to do. You cannot give clearance because they are always prone for arrhythmias like pre-excited AF, and pre-excited AF you won't know when it is coming. So such patients always should be risk stratified. Risk stratified, there are two types of risk stratification: non-invasive, invasive. Invasive is electrophysiology risk stratification, which is more specific. Non-invasive, in older persons you can consider non-invasive, like non-invasive exercise, like TMT. You can subject the patient to TMT, where if it is intermittent pre-excitation and during TMT there is disappearance of pre-excitation at even before the peak heart rate is achieved, that means he is having a lower risk. But you still cannot rule out he is having zero risk. So EP study for risk stratification is definitely must. It is class 1. If there are some high risk features, catheter ablation is advised at is class 1. So don't, because the risk of sudden cardiac arrest in a patient with the pre-excited AF is still 0.5 to 1%. So you cannot, that is only percentage. If still there is not 0%. So you have to do risk stratification and subject him for catheter ablation if it is high risk features. So Short note on sinus tachycardia, which is inappropriate. Most of the sinus tachycardia is reversible. If there are no other reversible causes, it is the inappropriate sinus tachycardia, which is usually a diagnosis of exclusion. Rule out all other causes. There are two types of inappropriate sinus tachycardia. If it is persistent, it is inappropriate. If it is paroxysmal, it is called sinus node reentrant tachycardia, where there is a role for catheter ablation. If it is inappropriate sinus tachycardia, physical measures like maintaining fluid status and changing lifestyle, this is enough because it is very benign. Rarely, if patient requires drug, you can consider ivabradine. Ivabradine is a funny current blocker. It acts on the SA node. Usually give ivabradine with a low dose of beta blocker. If you give beta blocker or calcium channel blocker alone, you might require higher dose, and that may cause a lot of symptoms like fatigability. So ivabradine with a low dose of beta blocker, if patient is very much symptomatic, you can consider this drug. Maybe a year or so, when you continue the drug, patient will slowly respond to it, and you can even stop the drug after a year. No role for any other drug in inappropriate sinus tachycardia. Whereas in sinus node reentrant tachycardia, if not responding to drugs, consider catheter ablation. There is another type of narrow QRS tachycardia which is regularly irregular, which is called multifocal atrial tachycardia. It is irregularly irregular. So most of the irregular multifocal atrial tachycardia occurs in patients with lung disease like chronic obstructive pulmonary disease or bronchial asthma, and it is precipitated by beta stimulants which is given for COPD. So try to reduce the bronchodilators. If not possible, you can give verapamil or diltiazem. Selective beta blocker can be given. If not responding to any of these drugs and patient develops tachycardia or heart failure, you can pace and ablate. That is, you can do AV nodal ablation and consider either his bundle pacing or left bundle pacing or CRT for such patients because they are prone for tachycardiomyopathy. A short note on supraventricular tachycardia and pregnancy. Avoid amiodarone. Amiodarone is not recommended in pregnant patients. Beta blockers are safe except atenolol. In most of the SVTs during pregnancy can be managed medically. Can avoid catheter ablation. If it is incessant and recurrent, consider catheter ablation if there is a possibility of fluoroless catheter ablation in your EP lab. There is an emphasis on recommendation for sports persons with SVT. Almost all SVTs can be treated by radiofrequency ablation. So there is all sports are advised. There is no restriction of sports activity. Generally, after ablation, 4 to 6 weeks of avoidance of sports is advised. And if these patients are not willing for ablation, you can ask them, teach them about pill in the pocket technique for SVTs, except pre-excitation. In pre-excitation, you have to do ablation. There is no other possibility for him to continue sports if he is having pre-excitation. So, what not to do? Generally, IV amiodarone, I have stressed upon multiple times, don't give IV amiodarone as a first line management. It is easier to manage, but it is a headache, and because of side effects and long-term management. There are some drugs like ibutylite, flecainide, propafenone. Even though they are not considered as a first-line drug, in drug-resistant and patient not willing for catheter ablation, you can try flecainide, propafenone. Only thing is, if patient is having severe LV dysfunction or structural heart disease, you cannot give these drugs. So, just a question, can you recognize the person? If you see from far, you will see this as a whole individual. But on analysis, there is only one small fellow sitting here. Similarly, when you see this, it is a narrow QRS tachycardia, but there are some specific features like RBBB, left axis deviation, deep S waves. Don't try to treat it as supraventricular tachycardia because it is an idiopathic left fascicular ventricular tachycardia for which cardio drugs is not the initial treatment. Only catheter ablation is the treatment of choice. So take home message, catheter ablation for most of the SVTs can be done with near zero risk. Fluoroless catheter ablation is available. So even in pregnancy you can suggest. Symptomatic tachycardias causing cardiomyopathy or severe heart failure, radiofrequency is the first choice of management. Fluoroless ablation can be done for pregnant patients. Beta blockers except atenolol are safe in SVTs. So analyze all the ECGs with narrow QRS tachycardia. Try to be consistent. Do not miss the diagnosis. Because when you refer to another physician or an EP, when we don't have the previous existing ECG, we should be missing most of the atrial flutter, atrial reentrant arrhythmias where anticoagulation may not be given. So you are missing some main therapy. So thank you.
Thank you, sir. It was a wonderful presentation on SVT management. I call upon Dr. Tirumurugan sir to felicitate Dr. Vidyakar sir. I call upon Dr. Dileepan sir to felicitate. Next, I call upon Dr. Lawrence Jayasuraj sir to present here rate and rhythm control for atrial fibrillation.
Good morning all. Thank you for being with us on this Sunday morning. My topic for discussion on today's will be on rate and rhythm control for atrial fibrillation, which is better. Primarily, I'm going to talk about is rhythm control strategy has taken over as a management of atrial fibrillation. Why we are worried about atrial fibrillation, why you want to bring sinus rhythm in most of the patients with atrial fibrillation. We all know consequences of atrial fibrillation. We have two-fold increase in death overall and around nine-fold increase in the risk of death within 4 months after the first AF diagnosis. Around 5 times increased risk of stroke, increased risk of heart failure and sudden cardiac death. We know the quality of life definitely comes down in any patient with atrial fibrillation because you lose atrial kick bringing cardiac output. We just heard from Dr. Vidyakar about supraventricular tachycardias. There is a simple difference between atrial fibrillation as an arrhythmia and other supraventricular tachycardias. AF is a progressive disease. If I'm going to treat a patient with AV nodal re-entry, maybe 10 to 15 years after the diagnosis because he has not been referred or he is not regularly follow it up, there is hardly any difference the way I'm going to ablate this arrhythmia. The success rates are nearly same even if I ablate now or after 10 years. But the problem with atrial fibrillation is a very progressive disease. That means if you have a patient with atrial fibrillation whom you have got it very early, he is going to have an extremely good success rate while comparing with a patient who has been referred late. The reason is this. The patients with atrial fibrillation, they all progress. When they are progressing, there is a structural damage happening inside the left atrium. We are going to see a atrial remodeling, atrial fibrosis, and some of these people can develop a significant atrial disease which may stop you from getting a good success rate. That's the reason you can see very clearly the ablation success rate significantly comes down as the atrial fibrillation progresses. The atrial fibrillation progresses from multiple ways. You could see the multiple loops in operation. You have an electrical loop which causes electrical changes in the left atrium, which makes left atrium more amenable to atrial fibrillation. Atrial fibrillation goes on from a proximal to persistent to permanent atrial fibrillation. You have triggers which are already there, maybe a risk factor trigger or a patient who have an electrical triggers coming from a pulmonary veins which can go on to progress and make the atrial fibrillation more and more persistent and permanent. You will have a lot of structural changes happening inside the heart. Not only that, you will have a lot of hemodynamic changes also happening. A patient with atrial fibrillation staying for a longer time will going to increase the left ventricular end-diastolic pressures. Patient is going to develop LV dysfunction, which is going to put a lot of stress on the left atrium, and the left atrium is ultimately going to dilate. So that's the reason atrial fibrillation has to be taken care in a very early stage to a rhythm control strategy. You will see atrial fibrillation, when you see a patient with atrial fibrillation, patient is throughout the history of atrial fibrillation, patient is going to have multiple episodes of triggers and insults during the course of this illness, which is going to make atrial fibrillation more and more progressive. This progression of atrial fibrillation is going to make your treatment process difficult. How atrial fibrillation progresses? You have a patient with atrial fibrillation, you are first diagnosed, patient presents with a paroxysmal episodes of atrial fibrillation. You will have atrial fibrillation which is less than 48 hours old and maybe less than 7 days old, which is very much amenable to most of the drugs available and most of the therapies available. From this, patient can go on to progress to a persistent atrial fibrillation, which can be a early or late persistent atrial fibrillation. Ultimately, patient will end up something called a permanent atrial fibrillation, where bringing back the sinus rhythm is not possible, even though if you want to try to achieve it. So if you look at progression of atrial fibrillation, you could see there are a lot of data available. Yes, a large review clearly says that patients with proximal atrial fibrillation, the progression has ranged from somewhere between 7.8 to 77%, averaging around 33%. That means atrial fibrillation which you are going to see as a proximal atrial fibrillation, out of that close to 1/3 to 1/2 would have reached a permanent atrial fibrillation by around 7 to 10 years time. We are already seen that what happens to atrial fibrillation when it progresses. So this is a large study which had close to around 2,600 patients. Around 30% were first detected and around 30% were proximal AF. If you look at the curve between paroxysmal and persistent non-proximal form of atrial fibrillation, you could see a significant cardiac mortality in patients who are non-proximal atrial fibrillation. The patients who ultimately end up with a non-proximal form of atrial fibrillation had a significantly higher mortality when you compare with the proximal atrial fibrillation. So here also you can see the Rocket AF, we all know, is a very large trial. We had around 15,000 patients recruited in this study. Patients with proximal atrial fibrillation had a significantly lower rate of all-cause mortality, stroke, and composite endpoint of stroke, systemic embolism, and death. You could see the curves here. They're significantly divergent. The patients who are in proximal atrial fibrillation, when you compare with persistent atrial fibrillation, had a significantly better survival. The mortality was much, much lesser when you are in a proximal atrial fibrillation group. This is another study where you could see around 3,000 plus patients who have been followed up in the community for 10 years. You could see a standardized mortality ratios when they compare with age adjusted. You could see that whenever the patient progresses from proximal to a permanent form, there is a significant increase in mortality and all the parameters associated with atrial fibrillation. So this is what exactly happens when you have a progression. Around 2.5 times more cardiovascular events, around 6.5 times more prevalence of stroke, around 2.5 times more prevalence of heart failure, around 1.5 times increased hospitalization, around 3 times more need of an electrical cardioversion, and decreased heart-related quality of life when a patient progresses from a proximal to permanent form of atrial fibrillations. So this is a big question which was answered long back in 2002 by the AFFIRMED study. I think most of the cardiologists and most of the physicians will remember this study for that result. When they compare rate control with rhythm control for managing atrial fibrillation, they could see both were doing extremely good. There was hardly any difference between the two. This is where we all started believing that rate control is as good as rhythm control. By rhythm control, we mean patient keeping in sinus rhythm. So is it really true what we are seeing in this graph? If you go inside further and see, if you see the presence of sinus rhythm was associated with around 50% low risk of death. Whenever you are able to keep the patient in sinus rhythm, the mortality rate was reduced by 50%. It's a very big number. The problem is the price you pay for this keeping the sinus rhythm is around 50%. The drugs which use antiarrhythmic agents to achieve sinus rhythm was associated with a 50% increase in mortality. So the problem was not with the rhythm control strategy, the problem was how you achieve rhythm control. So if you find a strategy by which you can achieve a rhythm control without increasing the mortality, you are going to achieve around 50% lower risk of death in patients with atrial fibrillation if you are going to keep them in sinus rhythm. So that's the reason, if you look at HRS 2017 guidelines, the class 1 level of, with evidence A for symptomatic proximal atrial fibrillation. If you have a patient who has a proximal atrial fibrillation, who is refractory, who has recurrence on drugs, or he is intolerant to at least one class 1 or class 3 antiarrhythmic drug, you can offer a atrial fibrillation ablation as a treatment. It's a class 1A indication, which is the highest recommendation you will get for any therapy. So our primary focus here, how we are going to stop progression of atrial fibrillation. Is there any safe way by which you can achieve stopping the progression of atrial fibrillation? So this is, if you look at, it's a worldwide study where they looked at around 2,100 patients with recent heart and atrial fibrillation. Close to 15% progressed to non-proximal form of atrial fibrillation. AF progression from proximal to persistent atrial fibrillation at 12 months was significantly lower when you use rhythm control as a strategy. The propensity score adjusted odds ratio for AF progression with rate and rhythm control strategy was 3.3. You can very clearly see when you are using a rhythm control strategy as a treatment for atrial fibrillation, you are able to stop AF progression more efficiently. So if you look at here, now we are moving from drugs to other forms of therapy. You can see, can you prevent atrial fibrillation progression by giving a non-pharmacological management of atrial fibrillation? You look at the patients with catheter ablation and patients with medical management. When they followed up, you could see a catheter ablation. Here is a cryoablation. Here is a radio frequency. They were able to achieve a much better success rate. It is in the 70s when you are using catheter ablation as a strategy for managing patients with atrial fibrillation and to keep them in sinus rhythm when you compare with antiarrhythmic therapy. So now we have two messages coming out clearly from these trials. One, when you are going to keep the patient in sinus rhythm, the data is good. You have a better results. You have a better reduction in mortality. And when you are going to use drugs for managing these patients to keep in sinus rhythm, you have a problem. When you use other strategies, non-pharmacological strategies like catheter ablation, either cryo or radio frequency ablation, you are able to achieve a better results with a lesser side effects. So if you look at this, you can very clearly see the radio frequency group does extremely well when you use as a strategy for keeping the patient in sinus rhythm. So over a period of close to 36 months, you could see the number of patients who are able to keep in sinus rhythm is much higher when you are using catheter ablation as a strategy. So when you look at a large data, here again you could see the percentage of AF progression increases over a time when you increase the follow-up. In general, in all the population studies, but remains flat in AF ablation studies. So when you are going to see an AF patient, you just follow them up, you could see a significant increase in progression. In the same time, you go back and follow these patients who have been ablated from ablation-based studies, you could see a significantly flat. You can see a flat curve, which hardly any progression, while you look at the general population where they are just treated for an atrial fibrillation, they have a significant progression. So, not only that, I started the presentation by saying picking up a disease in early is very important. This is why. If you are able to see a patient very early into atrial fibrillation, your success rates are much better. If you see the baseline prevalence of proximal atrial fibrillation was similar in all the group. When you look at earlier ablation, the earlier ablation significantly improved AF-free survival at 3 years compared to the later ablation. Even in the group which is referred for ablation, when you refer the patient early, if you see the patient has been referred pretty early, your success rates are very high. Your risk of atrial fibrillation, death and heart failure are increased when you postpone your referrals up to 1 year. So when you have a patient with atrial fibrillation, paroxysmal, who is indicated for atrial fibrillation ablation, you keep them at 1 year rather than referring them early. There is a higher chance of the patient developing a heart failure, hospitalization, AF or death. So if you look at AF progression, so whenever you look at any study, whenever the patient is seen with earlier group, you can see less than 15 months and more than 15 months, whenever a patient is treated early, you always see a better results and better success rate in AF ablation whenever your patient is seen early. So you see here, this is looking at the fire and ice studies where they looked at radiofrequency ablation with cryo. So they looked at around 750 patients with symptomatic proximal AF who are refractory to class 1 and 3 agents, and they looked at cryoablation or radiofrequency ablation as a strategy to ablate. So whenever there is an each additional year between the AF diagnosis and ablation, the procedure was with a 3% increase risk of repeat ablation. So the moment you postpone more and more, the possibility of a success comes down and the possibility of getting a second ablation also increases. So whenever you are looking at AF ablation or AF management as a strategy, there are few things you have to remember. You have to treat them in a proximal form. You have to keep them in proximal form. Keeping in sinus rhythm is very important. When you see a patient with proximal atrial fibrillation who is eligible for ablation, has to be ablated early so that you can achieve the best results possible. To summarize, AF is a progressive disease, and progression of AF increases the risk of stroke, heart failure and cardiovascular events and hospitalization. These outcomes definitely contribute to a worse quality of life, I think, as the AF progresses. Rhythm control drugs are more effective than rate control drugs for prevention of atrial fibrillation progression. We should always remember, nowadays, we have drugs much beyond amiodarone as a drug. We have flecainide and propafenone freely available in India. These two drugs, when in an eligible patient who does not have a contraindication to these drugs, they do extremely well with a very lesser side effects. And catheter ablation is more effective than pharmacological rhythm control therapy for prevention of AF progression, and earlier ablation for AF after diagnosis and antiarrhythmic therapy is associated with the improved long-term outcomes, including AF recurrence, repeat ablation and death. So to summarize, pick up AF early, be aggressive in early part of treatment. If you have a patient with atrial fibrillation who has a chance of keeping in sinus rhythm, try to achieve the sinus rhythm with antiarrhythmic drugs. You have drugs like flecainide, propafenone and beta blockers which can keep your patient in sinus rhythm if they want a medical management. If any of your antiarrhythmic drugs fails, be more proactive in referring these patients for ablation, because availability of ablation modality like cryoablation have made ablation of atrial fibrillation much more simpler, and in PFA, pulse field ablation is in pipeline, which can reduce the collateral damage in a much bigger way than the cryo or radiofrequency ablation. So radiofrequency ablation or a cryoablation or a PFA can become much safer procedure, and in an eligible patient, early ablation has the best results for managing patients with atrial fibrillation, stopping the progression of atrial fibrillation. With this, I will close my talk. Let us have discussion for both the talks together. Thank you.
Thank you, sir, for this elaborate presentation on catheter ablation in AF. Next, I call upon Dr. Arun Gopi, sir.
Discussion. We'll finish the discussion for this talk and then we'll move.
Wonderful talk, Dr. Lawrence and Vidyaka. I just have one query. What are the predictors to tell you that this guy, if you ablate, there is a high chance of recurrence, apart from the duration? Number one. Number two, to pick up early AF, do you advise Master Health or Apple Watch?
The first question, I think AF is like progressive disease. The duration nearly matches the problem what you are happening inside the heart. What all things you can look at is left atrial size. So I think one primary thing which decides your success of AF ablation is one is what part of AF they are in and what is the LA size. The patients who have young and LA is less than 45 millimeter, they do extremely well. Fortunately, whenever we get a referral for AF ablation, at present scenario, we get most of the patients who are young. I think like any other disease in India, AF in India is also affects very young people. These people really do well. I think we had a close to around 40 plus cryo so far in our center. I think recurrence rate is maybe around 3 of them had a second recurrence after the procedure. I think it's close to 2.5 years follow-up now. And these patients are also doing well with drugs. So these are the patients who are being referred because they had a AF recurrence in spite of drugs. Most of them were on amiodarone. We ablated them. Close to 37 patients are in sinus rhythm for close to around 2 years now. The people who had recurred, the 3 also are doing really well with antiarrhythmic drugs. So if you pick up early, the picking up early is primarily by duration and LA size. I don't ablate more than 50 millimeter right now. I think across globe they will ablate in spite of the size, but I usually pick up patients who are having a lesser LA size because in the early days I want to give a better results. So any patient who has a less than 45 millimeter of LA, they do really well with ablation. Second question, how to pick up asymptomatic atrial fibrillation. I think rather than asymptomatic atrial fibrillation, very short sustained episodes of atrial fibrillation is well picked up by Apple Watch. I think other modes are not very effective. Maybe a Holter, long-term Holters, it's very difficult to pick up. Because these patients in the early days, they will have an episode last for a few minutes to seconds once in 6 months or 1 year. So I have close to around 3 to 4 patients in the last maybe 6 months who picked up their atrial fibrillation by an Apple Watch. So, and diagnosis is pretty good. You have to see the EGM electrogram, which looks pretty good. The single lead system, the atrial fibrillation can be easily picked up. Now they have programmed in such a way that it gives a alarm for atrial fibrillation. So if the patient has a documented episode which is the atrial fibrillation, it's picked up by the Apple Watch in a much better way.
That's a good talk. I have a couple of questions. How long do you anticoagulate post-ablation, AF ablation? And when do you, the next question is, when does the atrial function resumes post-ablation?
See, fortunately, second question first. Fortunately, we ablate mostly in the antrum of pulmonary veins. We don't hit the left atrium much. So you don't hamper the function of the left atrium. The left atrial dysfunction happens when you do a lot of ablation in the left atrium, and that's a very dangerous thing to happen. So we don't do that. We do an antral ablation, so your left atrial function is not affected. So you have a left atrial function to start with. Anticoagulation is according to the CHAT score. First 3 months, we give anticoagulation after an ablation irrespective of CHAT score. At 3rd month after an ablation, we look at the CHAT score. If CHAT score demands anticoagulation, anticoagulation is continued irrespective of patient being in sinus rhythm. Except few, if the patient and you discuss and understand the risk of stroke and still patient does not want an anticoagulation because he is in sinus rhythm, we can stop. Otherwise, all the patients are having an anticoagulation after 3 months according to the CHAT score.
And evaluation of a possible arrhythmia following a transient ischemic attack, when you think of it doesn't manifest during the presentation, you want to have the patient on a monitor, how long we should be monitoring to pick up?
See, right now the recommendation for a stroke is 3 days, but it's very difficult to pick up even in 3 days. The longer you follow, the higher the chances. If you feel like this could be a AF related stroke, 2 things one can do. One is, if you are very strongly believing, I would rather put him on an anticoagulation rather than antiplatelet. Second, I can go for a prolonged monitoring, which is available. Maybe most of the patches can be extended close to a month. Now we have patches which can go up to a month. So if you longer you follow, better you pick up. So for 3 days is a recommendation. I think you have to do at least 3 days. You know very well, not many patients with stroke get even a 3 days monitoring also. Most of the patients with stroke go home. You get a call as a cardiologist maybe after a second stroke to see if there is any reason for recurrent stroke. Otherwise, most of these patients go on an antiplatelet, and I have seen patients with stroke having an atrial fibrillation managed with antiplatelets alone for a longer period of time until they get a second stroke, because the dependence on antiplatelets is very high. And these patients, you know very well, antiplatelets are not going to work. Only where anticoagulation is going to work. So these patients has to be picked up pretty early, and at least 3 days is must.
How do you manage atrial fibrillation of pregnant ladies, one? And to Dr. Vidyakar, asymptomatic W12 syndrome, how do you proceed?
I think because it's a medical management, both Vidyakar can take. Mike.
You have to risk stratify each and every patient with asymptomatic pre-excitation. It is asymptomatic till that time. It can be symptomatic later. So younger patients always do an invasive EP study. Older patients start with a non-invasive. If the pre-excitation disappears even before the peak heart rate is reached, or there is no exercise-induced tachyarrhythmias, you can follow him up medically, that means without drugs. Still, the risk of arrhythmia or cardiac arrest is 0.1%. So, older patients, you can tell them, you can convince them for an EP study. Younger patients definitely requires an invasive EP study because that is more specific. And if you find high risk features, better do catheter ablation rather than putting on some drugs which might precipitate arrhythmias like VF. In pregnant patients, usually AF is very less in our country. You can manage with drugs. Cardioversion only if there is a hemodynamic compromise. No need for anticoagulation because they are younger age. SADVA score is mostly will be 0 or 1, so less than 1. So anticoagulation is not required. Only if they have a structural heart disease or a congenital heart disease where there is a challenge, you can consider short-term antiarrhythmic drugs. If there is no LV dysfunction, you can consider dofetilide and ibutylide. Dofetilide is not available in our country. Ibutylide can be considered. Beta blocker can be considered. Rate control is a strategy. Fluoroless catheter ablation in a pregnant patient is an option. Most of the times, rheumatic heart disease, even drugs and catheter ablation may not be 100% effective. Rate control is the best strategy. Try to treat the valve. If there is an obstruction, like most common is rheumatic mitral valve disease with severe mitral stenosis. So open the valve, patients will become less symptomatic. You give drugs to control the rate. You don't need to rhythm control in such patients because rhythm control in rheumatic heart disease, especially rheumatic AF, is very, very difficult, and most of the times it has not shown benefit over rate control. Finally, one day she might require a valve replacement. At that time, you can consider doing a catheter ablation for AF.
So patients newly diagnosed with atrial fibrillation, an elderly patient, suppose like a trochanteric fracture, planning for a surgery by an orthopedician, your recommendations?
Sir, it's like managing any anticoagulation. I think you go for a injectable low molecular heparin during that period, and once your surgeon is happy, you can bring back to anticoagulation as usual. I think this patient has to be anticoagulated. That's very important. Because elderly, the moment you look at the elderly patient with an atrial fibrillation, you are looking at a very high risk for stroke. Most of the people, because of comorbidities, will end up having a CHAT score more than 3. So these patients should not be left unprotected. It is like any of your valve patients or anyone who is on anticoagulation, how you plan for a surgery. You can give them close to maybe 12 to 24 hours break of anticoagulation for your surgeon. And once your surgeon is happy about hemostasis, you can go back to your anticoagulation. Lot of time, unfractured heparins, most of the surgeons are okay. They will allow you to start maybe evening of the procedure. If the patient develops any signs of bleed or anything, then you may have to hold back. I think most of the patients can be managed. Only thing is, your threshold for anticoagulation should be there. You should not feel like it's not a valve. It's not a valve, so you don't have to be so aggressive about your anticoagulation. These patients can develop a devastating stroke during this period. I think in Rocket AF, whenever there is a period when anticoagulation was stopped, the risk for stroke was very high. Whenever there is an interruption or is a break from anticoagulation, the stroke incidence significantly rises. Even the patient who has not been started on anticoagulation, compare them with a patient who has started on anticoagulation, there is a break. They have a higher incidence of stroke. So you have to be very careful about these patients. They have to be anticoagulated. If you have both options, you have a unfractured heparin or a low molecular heparin. According to the surgeon's wish, you can use. I use most of the time a low molecular heparin to start with because you have to break for 2 to 3 days depending on the patient's renal function. During that time, use a low molecular heparin, give them a 24 hours break for a surgery. Once the surgery is done, start unfractionated heparin maybe by the evening. Once surgeon is comfortable, sometimes surgeon is not very comfortable until a week or 10 days. You continue with low molecular heparin or unfractionated heparin. Once they are fine, you restart your anticoagulation.
Thank you, sir.
So if there are no more questions, let us move on to the next session. Let me invite Dr. Shivarasam sir to felicitate our panel. Let me invite, in the meantime, Dr. Arun Kopi to take over for the next session, which is going to be on cryoablation. He's going to talk about his personal experience.
So, a warm good afternoon to all. I think Lawrence has already...
So let me invite the panel for the next talk. Dr. Adeep sir, Dr. Prem Krishna, Dr. Ramasamy sir, Dr. Jagdishwari madam, Dr. Ramakrishnan sir and Dr. Bivin.
So with the permission of chair, so a warm good afternoon to all. So once I think Lawrence has set the stage of how to manage AF, now we see the approach which you would prefer, the way you want to manage AFib, the way you want to ablate, which would be a preferred strategy. So that would be my talk on AF ablation, my personal experience and my approach towards ablating AFib in the lab. So this would be my flow of talk. So let's start off with a typical case scenario that you all would see in clinical practice. 68-year-old hypertensive, recurrent hospitalization with this arrhythmia, which has been discussed and debated about in the last session, that is irregular rhythm with no clearly discernible P wave, which is atrial fibrillation. Echo essentially normal, that's what we typically see. LA normal size 39 mm. History of neurovascular ischemia, one history of TIA. Initially start on beta blocker, as Vidyadhar earlier told, would be start on beta blocker, later on start on amiodarone. The physician uptitrates these patients to maximum dose of these drugs, gets NOAC for stroke prevention AF, which is very important as Lawrence alluded to. But what we see in clinical practice also is that a lot of patients don't tolerate amiodarone. They develop all forms of side effects with amiodarone, and amiodarone is a nasty drug. So they withdraw amiodarone, and the moment you withdraw amiodarone, that's what patient comes back with repeated paroxysms of AF, perspirating heart failure. Till now he was already having palpitations. Now AF comes back with vengeance, and there comes AF with heart failure. It's a very common clinical scenario, as was been discussed. It's a most common sustained clinical arrhythmia in practice. Rising prevalence with age. In next 30 years, you are going to see the prevalence double up. Why we are interested? A 5-fold increase in stroke, a 3-fold increase in heart failure. Numerous treatment options which has been discussed well in the last 2 talks. Rate versus rhythm was never a debate, to be frank. It was what Lawrence alluded to. Trials might show it to be equivalent, but the way they achieved rhythm was the problem. They achieved rhythm with very toxic antiarrhythmic drugs, and that's what offset and made rhythm equivalent to rate. So now guidelines are very clear that in any person with symptomatic paroxysmal AF, be it any guideline across globe, be it the Heart Rhythm Society, be it the European guidelines, be it any guidelines, they are very clear. There is a class 1 recommendation, as he said, it's the strongest evidence that we have for all patients with symptomatic paroxysmal AFib who is refractory or intolerant to at least one class 1 or class 3 antiarrhythmic drug needs to be subjected to catheter ablation. We have a lot of drugs available which has been discussed, but you need to see the list of drugs that are available. You see only amiodarone in all the list. And amiodarone has terrible side effects. You put them on amiodarone for short term, it's okay, but long term they come with thyroid disease issues, they come with pulmonary fibrosis, they come with hepatic issues, and majority are irreversible. So amiodarone is not a safe drug on the long term, so we need better solutions for maintaining sinus rhythm in patients with AF, and the way forward is AFib ablation. But unfortunately, the uptake of this therapy is dismal. If you see in our world as well as any part of the world, only 10% of patients who really need this therapy get the therapy. That's the bottleneck of where we are struggling to deliver this therapy to the patients, because only 10% of indicated patients actually come to the EP person and finally get it done. It's obviously, as the understanding of the disease progresses, it's more or less a cardiometabolic disease now. You need to control your risk factors. You don't see a patient with AF and take him directly to the lab. There are a lot of homework which needs to be done. You need to cut down on his weight. A 10% reduction in weight has shown to have significant reduction of AFib. You need to take a look at his comorbidities. Obstructive sleep apnea is an elephant in the room, which is obviously neglected. If you treat OSA, majority of the time you would be able to take care of the AFib. But if nothing of these things work, catheter ablation is the way forward. And this is what all the guidelines embark on. As Lauren said, 2023, this is the latest guidelines that we have from the American College of Cardiology, which gives a class 1 recommendation for catheter ablation for all patients in whom drugs are ineffective, contraindicated, not tolerated, or not preferred. Complications, when you look at AFib ablation, which is the area of concern, why it was withheld for a lot of patients, if you look at the numbers, you look at the numbers worldwide, this is from real world experience, numbers are less than 1%. The maximum complications happen at local vascular issues, which can be easily dealt with. So it is relatively a safe procedure. Your inertia of referring just because of worry of complications should go down, because this is what the real world data also shows. Now, AFib with heart failure. When a person with heart failure comes in AFib, you think of chicken and egg story, what came first, AFib came first or heart failure came first. Just stop thinking of that, treat AF, and that's what has been shown in trials. There's a class 1 recommendation for ablating AFib when the patient has heart failure, because once you ablate AFib, you take care of the tachycardiomyopathy, you reduce his hospitalization with heart failure, you improve his quality of life. And the way we ablate this, we all should thank this person, this group from Bordeaux, which is Hazagre and colleagues. What they did is, for all patients with AF, they just cardioverted these patients, took them into the lab, put in catheters in different parts of the heart, and what they found is it all starts from these 4 veins. So what they found is, when AFib patients were cardioverted and they were monitored, it's the pulmonary ectopy that triggers this AFib. So that stemmed the idea about 2 decades back in 1998, and they published it in the New England Journal, which showed that it is the pulmonary vein ectopy that triggers AFib, and that's what our focus of ablation target also is, where now what we do is we go around the antrum, as it was alluded to earlier. We go around the antrum, don't go into the pulmonary vein, we go around the antrum of the pulmonary vein. We do a wide antral circumferential isolation, which is said as Walker. We do a wide antral circumferential isolation, electrical isolation of these pulmonary veins to ablate AFib. And how do you want to do it? You can do it either as radiofrequency ablation or cryoablation, and the new pulse field is in the pipeline. We don't have it in our part of the world, but it's probably going to hit India as well in the next 2 or 3 years. Now, anything beyond pulmonary vein isolation has been well studied. Anything beyond pulmonary vein isolation does not have benefit. So if you want to isolate posterior wall, if you want to go and burn in the posterior wall, if you want to go and burn these fractionated electrograms that you have, if you want to do an MRI guided ablation, nothing has shown to have added benefit over pulmonary vein isolation. And anticoagulation was discussed earlier. You always need to maintain your INRs between 2 and 3. It has to be given 3 months after the procedure, and after that it's, as said earlier, based on the CHAD score. Now, the topic of discussion is whether you want to do a point-by-point burn around, you want to do a point-by-point burn, or you want to take in a balloon to the pulmonary vein ostium and then freeze it. So I would prefer to do it as cryoablation, because radiofrequency ablation, if you want to do a point, this is a typical scenario where you take the patients to the EP lab, we put in these catheters inside the heart, take a transeptal axis, we go around this pulmonary vein. So these are the pulmonary veins. So you have to go take this ablation catheter with a sheath in and go point by point, burn each of these points and get a full circle to get a full pulmonary vein isolation. That's what typically happens in a radiofrequency ablation lab. But on the other hand, cryo, it's much more simpler. We have almost a dedicated system from Medtronic for this. We take in a transeptal puncture. This is an animation of what happens with cryoablation. We take in a transeptal puncture, get into the left atrium. So this is the pulmonary vein. We take in this mapping catheter into the pulmonary vein, take in this balloon here. So this is an endoscopic view of what happens inside. So we give liquid nitrogen inside this balloon. It freezes. And with freeze it comes adhesion to the pulmonary vein antrum. It stays adhered there. It forms ice. You just need to keep it there for 3 to 4 minutes. And it would electrically isolate the pulmonary vein, but at the same time mechanically keep allowing the mechanical functions to follow. And everything of this thing is monitored. The temperature, the esophageal temperature, the time duration for which is given, the temperature drop, the thawing time, everything is monitored. So you are safe, and this is the way we do it now. And does this have evidence? So if you look at drugs versus ablation, it's a no-brainer. You have a 7% maintenance of sinus rhythm with drugs, you have a 70% maintenance of sinus rhythm with ablation. So you don't have to think whether you want to give a person lifelong drugs or ablation. Ablation is a clear winner when you look at trials. Now the benefits, as was alluded to, 1/3 reduction of stroke, 50% reduction of mortality. Earlier ablation always benefits, as Lawrence was always heading on in his talk. AF begets AF, hit early, and that's what all the studies show. The earlier you refer for AFib ablation, the person has maximum benefit, because you are preventing the conversion from a paroxysmal stage to persistent stage to permanent stage. So if you hit early, you are going to have long-term benefits. Now cryo versus RF, you want to freeze or burn point by point. When you look at our concept of ablation, it all starts from Hippocrates' oath, primum non nocere, first do no harm. Your purpose is to do no harm, improve symptoms and functional capacity of the patient, reduce stroke and morbidity, reduce mortality. This is what you want to do, and the best way to do this is to use freeze. You do a direct cellular injury with hypothermia, you do ice formation, you have apoptosis and necrosis, rather than causing coagulative, conductive heat and resistive heat. And when we say that cryoablation is superior to RF ablation, it is not my own personal thoughts. You look at what the evidence say. This is the largest multi-center head-to-head AFib ablation trial to date. It clearly shows efficacy-wise, cryoablation is non-inferior to RF ablation. But what is more important to your patient? If you look at our cryoablation, it leads on to a 34% reduced hospitalization, a 33% requirement for repeat ablation. So that is most important for our patients, because these are the two important things. Need for re-interventions, need for re-hospitalization. There's a 1/3 reduction with cryoablation compared to AFib, compared to your RF ablation, and that's what primarily your patients are looking forward to. The next important aspect from the patient's perspective is safety of the procedure. You look at the complications. With cryo, there's hardly any much complications except for phrenic nerve injury. And if you look at the phrenic nerve injury, it's 2.7% during the procedure, which in almost majority of time recovers only 0.3% at the end of 1 year. So it's almost a very safe procedure. So it's non-inferior as per the Fire and Ice trial, a very favorable safety profile, very less fluoroscopic times, less LA dwell times, lesser required for repeat ablations. Now you would say that you have better technologies available. Now this is the best care for RF ablation. That is what is called a contact force RF ablation versus the cryoablation. Again, with the best RF protocol as well, cryo was slightly superior. There was a 99% reduction in AFib burden with the shorter cryo protocol, and that is why cryoablation would be the way forward. So other things are, as I said, it's a very safe procedure, it is very effective, it's versatile, it has consistent efficacy, it is more reproducible. So when you're thinking of AFib ablation, you are getting into these thin structures, and you're going to burn around there. If you want to go within this catheter, beat point by point, you are definitely going to have higher collateral damage. You're going to have thrombus formation. You're not going to have catheter stability with a moving heart like this, and that's why RF clearly fails. But with cryo, if you look with cryoablation, the beauty of this therapy is it is reversible. What you're causing is hypothermia. And if you find that this is not what you wanted to do, if you have done a freeze and you find that you've done a freeze in a wrong place, what you just want to do is just stop the freeze. The moment you stop the freeze, the loss of electrical function that happened would be transient. It would recover as soon as the blood comes into the place and warms up. But with RF ablation, it is permanent. You have damaged the phrenic nerve permanently, you cannot recover it. But with cryo, if you are causing a phrenic nerve damage, you just have to stop the freeze, the phrenic nerve function comes back. That's why the beauty of this is it is reversible. And what happens with this therapy? You look at what happens on the histopathology specimens with the cryo and RF. So if you want to look at the left atrium of patients after RF, this is how it looks like. whole of the borders are damaged, there's a lot of fibrosis, there's a lot of thrombus. On the other hand, this is what the cryo lesions happen. There's no thrombus, the endocardium is not altered, there's a very smooth lesion that happens with cryoablation. There's less risk of thrombus formation, very homogeneous, well demarcated lesion. So we want our patients to have this kind of smooth lesions because you don't want to have embolic strokes after a procedure. It is safe, it is well proven without doubt. I'm not going to talk on trials to discount, but definitely all these trials, if you call it cryo first, you call it stop AF first, early AF trial, all trials have shown it to be safe. Very less incidence of complications, not much issue. Only issue that we are looking at is vascular access issues and phrenic nerve issues, which majority of time recover. Now, how about its efficacy? When you say about efficacy, you are looking at the single procedure success rate of cryoablation. So this is what is shown across trials. 80 to 90% of patients across centers maintain sinus rhythm after a single procedure. And if you say that this is at 1 year, you see on follow-up, at follow-up of 2 years, you have almost 75% maintaining sinus rhythm with your advanced cryoballoon technology. And if you look at reconnections, so that's what we call durability of lesion. Whether your procedure that you do now is going to keep the patient in sinus rhythm on follow-up, you have a 70% durability of these lesions on follow-up. On the other hand, with RF, it's only 35% durability. So there's no comparison between this, it's almost like there's a whole lot of difference between these two kind of therapies. And it is not seen in one trial across, you see across trials. So I'm not going to talk on trials and to a non-EP community, but if you look at any of the trials, be it stop AF, stop persistent AFib, early AF, cryo first, all these trials show that with drugs, there is no brainer. Drugs versus ablation, there's a whole lot difference in the graphs. Even between the cryo and RF, cryo is definitely having more safer and more efficacious procedure. Now, only issue earlier what told with cryo was you will have to stick on to the pulmonary veins. You can't go beyond pulmonary veins. Now we can actually get to cryo and freeze in the left atrial body. You can freeze the posterior wall. You can go beyond the pulmonary vein as well. Now, what about the efficacy? So whether it is consistent across the operator. So if you look at these two pictures, so this is what an RF does. With a beating heart, you're going to beat point by point. On the other hand, you have a balloon which on freezing gets adhered to the tissue and is going to remain stable there. So it's a no-brainer that which is going to have a reproducible result. So that's why if you look at the comparison times between the cryo and RF, the mean time for cryo is 84 minutes, very predictable. With RF, it's really dependent upon the operator's experience. And that's what is shown in across trials for any person. So depending upon the operator's experience, cryo results don't differ. For a very seasoned experienced operator also, and for a very novel operator also, after the initial set of cases, there's not going to be much difference. So there's a shorter learning curve, higher reproducibility, less operator dependent. And what the patient and staff want is a very predictable procedure. You look at any quality of life indices, after cryo, there's significant improvement in the quality of life. As I said, lesser cardioversions, lesser repeat ablation, lesser hospitalization, better quality of work. For efficient workflows where we want to do more procedures in a short period of time, cryo is clearly predictable. I know when I get into the lab, my procedure is going to get over in 40 minutes, so I can schedule the next procedures. Just requires moderate sedation, even allows for a same-day discharge. And there's a lot of newer things coming in the pipeline which is going to ease these things further with the innovations coming in like the nitron console and all. So these are going to make these procedures simple. So coming back to the index case that I described, a person troubled by paroxysms of AFib, having issues with amiodarone, coming with AFib with heart failure, we took the patient to the lab. What we just require is single femoral venous access. So we take a single groin access, have two catheters in. This had a jugular access for the decapolar catheter in CS. We puncture the intraradial septal. This is an intraradial septal puncture. We see it with eyes, and so this is the intracardiac image which shows where you're puncturing. And once you get into the left atrium, we take a shoot to understand where the pulmonary vein is, and just inflate the balloon at the os of the pulmonary vein. You have this mapping catheter. So this mapping catheter gives you live what is happening. So you have this. These are the signals from the mapping catheter. There's a sharp potential here, which is called the pulmonary vein potential. As you start freezing, the pulmonary potential goes away from the atrial potential, and you have electrical isolation of the pulmonary veins. So this person, this was in fact the first procedure of cryoablation in our state. It happened about 3 years back, and this patient is doing absolutely good for the last 3 years follow-up and has remained in sinus after that. Second case I'll allude to is a doctor. He's a 54-year-old doctor. Repeated hospitalization with AFib requiring parenteral amiodarone. He had all sorts of side effects with amiodarone, stopped amiodarone, put him on flecainide and metoprolol, maximum tolerated doses. His echo is normal, LA is normal sized. But unfortunately, he being a surgeon, he gets paroxysms while he's operating. He had to almost quit his job because he was repeatedly troubled by paroxysms of AFib. He couldn't concentrate on his surgery. He went for RF ablation. He went for RF ablation at 2 premium institutions in the country, still had failure, repeated hospitalization. Not only hospitalization, it has very poor quality of life. He could not do what his job was because he would start a surgery, he would get AFib, he had to stop the surgery, call in a friend to complete the surgery. So in fact, he left his job, and that's when he came to us with daily symptoms with very poor quality of life. So that's important for patient's perspective. It's not death that is most important, it's a quality of life. We again take him to the lab, conscious sedation. It's not even under GA, conscious sedation. We put in an esophageal temperature probe. This is the esophageal temperature probe. We puncture the intracranial septum. This is the intracardiac echo. So you have an echo probe inside. You are seeing what you're doing. You are clearly seeing where the intracranial septum is. You can see the tending and you're puncturing there. We get in the left atrium, find where the electrical signals are. We go around each of the pulmonary veins. So we go on, this is the left superior, left inferior, right superior, and right inferior. All these veins are isolated. You just require about 4 minutes of freeze. The fluoro time, that is the X-ray time, is just about 15 minutes. The whole procedure time is about 50 minutes. The LA dwell time, which is the most important predictor of stroke, is 28 minutes. So this person goes home on second day, absolutely no symptoms after work, symptoms after this procedure, gets back to work. He has good quality of life. In fact, he's the he's actually in fact our biggest preacher for cryoablation, because he goes around telling everybody that this has changed his life, and that's why we are doing this therapy. So now if you think of complex anatomy, this is next case, 48-year-old paroxysmal AFib, 7 episodes in the last 1 year, CHAT score 0. He's not troubled with stroke, but he's repeatedly getting AFib. Last time, the physician didn't refer him first, but the last time when he came to the physician, he tried even repeated cardioversions, he didn't convert. So when he had a failed cardioversion, that's when the physician thought that it's not beyond him. That's when he referred him to us. What we did a facilitated cardioversion, the ibutylite. He got into sinus. We took him to the lab. So what we see before that is we do a CT, and he has a congenital anomaly of an absent right-sided SVC. So there's no right-sided SVC at all. Everything is draining from the left-sided SVC. So this is a challenge in anatomy for an AFib ablation, because for transeptal you need to drag down, you need to capture phrenic from there. So we take him to the lab. He's again in incessant AFib. In the lab, we do a double sequential defibrillation. That is almost 4 pads on, anteroposterior, typical location, 2 shocks simultaneous. Even then, we are not able to convert him to sinus rhythm. We do every procedure. Throughout the procedure is in AFib. You can see the transeptal puncture is done in AFib. We take him, we go to the left superior. All the time patient is in AFib. We go to the left superior pulmonary vein. The superior pulmonary vein is just firing. You can see a lot of firing here. As we start freezing, you can see the number of signals coming down. So we are getting the pulmonary vein silent. We go to the left inferior pulmonary vein, totally firing. As we freeze, you can see all the electric. This is the green is the signals from the pulmonary vein. All the signals silencing down. So this is all just about 3 to 4 minutes of freezing into the vein. It's not a long duration procedure. For phrenic, actually, we go all the way. We go into the coronary sinus, get to the LSVC, come all around to the left, to the right brachiocephalic, and then start doing a phrenic pacing, because phrenic nerve is one thing which we want to be careful about when you're doing right side ablation. And again, we start freezing on right superior and inferior. As you start freezing, all the veins start silencing down, and he converts to sinus. So what a double sequential defibrillation could not do, a pulmonary vein isolation would cryo. For a person with incessant AFib, he converts to sinus. So these are the times duration, what you say, it's 240 seconds, 27 seconds, 180 seconds. These are the time duration for which we freeze, and he comes back to sinus. And that's a beauty of procedure. So now the next step, what we are looking at is getting into the lab without lead aprons. That what we call as zero-fluoro, what was earlier said about in pregnancy, that we want to do that, but we don't want to take it only for pregnant patients. We are trying to get in the lab without lead aprons. You can reduce, because earlier a lot of inertia for taking up electrophysiology was people thought it's a long procedure. You have to stay with the lead apron for 1 hour in the lab. Now it's no longer required, because all you require is actually intracardiac echo. So once you have intracardiac echo, you can see where the intracranial septum is. You can puncture the intracranial septum, take your catheter into the left atrium. So we get into the left atrium. We have all the electrical signals from the 3D electroanatomic mapping. You get the anatomy from the 3D electroanatomic mapping, and this catheter is going to show you the potentials where you are. You go a sequential way, left superior, left inferior, and right superior, all veins sequentially. And to look for occlusion, again, you don't require contrast. You just need to look where, take your cath data from the earlier side, how you would get a wedge pressure. So when you have occlusion, you have these the A waves going off and only the V waves coming up, which means that you have good occlusion of the pulmonary vein. You can also do phrenic monitoring with what is called CMAP. You just have a ECG which corresponds to the phrenic nerve capture, and you can actually monitor the phrenic nerve capture with a CMAP. So the entire procedure can be done without having a lead apron on, with very minimal fluoro, and that's what we have been embarking on in the recent times. So our personal experience at Metro Cardiac Center with AFib is, So we have done, since last 3 years, we have done about 60 cases. This is actually because of the inertia of referral. We have done about 60 cases, which is still almost the third largest volume in the country. We have done 60 cases of AFib ablation in the last 3 years, 49 for paroxysmal, 11 for persistent AFib. The mean age of patients is 54. So we are more focusing on younger subset because these are the patients who get benefited with procedure more. The procedural success during the procedure is almost 100%. During the procedure, we are seeing 100% of patients converting to sinus rhythm. Documented clinical recurrence, we have seen in three patients out of 60, which is 5%, which is quite good compared to the RF ablation data we had prior to that. The RF ablation dismally, unfortunately, had about more than 30% recurrence rate, but with cryo, we have almost only 5% recurrence rate. Yeah, major complication rates are almost nil. We didn't have any major complication during the procedure. Transient phrenic palsy was there in 1%. Hemoptysis was there in 1%, which most of the time settled. You look at the fluoro times. You don't have any cine. You have just fluoro time of 25 minutes. Average procedure time is 60 minutes. So at one time, people were hesitant to do AFib ablation because it took about 3 to 4 hours in the lab. Now with cryo on, it is just about 60 minutes. And as the learning curve comes down, now we are able to come in and out of lab, skin to skin by about 40 minutes. We use intracardiac echo in 100% of cases. That enormously improves our safety. Ultrasound is used for vascular access in 100% of patients. 3D mapping we use in about 80% of patients. And if you look at the average LA diameter, it's about 39. So we are at the higher border of margin. We have had about 5 patients who had LA more than 45, which would be an exclusion criteria in the West. The largest person was LA of 67 in HCM. So by God's grace, all these patients have been doing reasonably well. None of them had a major complication. Only 5% had recurrence. And these are the patients, the gratifying result that we see them on their follow-up. That's what actually embarks us on this journey of cryoablation. And this is what the entire world has also been doing. There's almost 1 million of patients being treated across the globe with this therapy. So ladies and gentlemen, to conclude, why cryoablation for AFib? So why cryo? But just because it is very safe, absolutely less collateral damage. It's extremely effective. It is versatile. You can cater to the anatomy that you are dealing with. As I said, any complex anatomy, you can do it. It is consistent. There's a shorter learning curve. It is efficient. As I said, almost only 5% recurrence rate, very reproducible results. So as I said, we are third largest volume in the whole of the country, and still we have almost results that are equivalent to the West. We have improved overall procedure success rates, very fast procedure because shortened procedure times, lesser post-procedure complications, better patient satisfaction scores, lesser recurrence. And we are able to do this with almost minimal or zero fluoro, and that is why this forms our first line of therapy for paroxysmal and persistent AFib. So to conclude, AFib ablation is a class 1 recommendation for all paroxysmal AFib patients who have failed or intolerant to medical therapy, but also a first line therapy for patients who do not want to take medicines and who have heart failure. Our point of approach towards AFib ablation is doing a cryo, which is a simple alternative to point-by-point RF ablation, and it allows for pulmonary vein isolation with a single application. There's improved procedural success rate, shortened procedure times, reduced post-procedure complications, better patient satisfaction scores, lesser recurrence, and zero contrast and zero fluoro is the way we are targeting to do AFib ablation in our time, using this trio of intracardiac echo, 3D electroanalytic mapping, and online pressure monitoring. And our experience is building over time, and we would express our gratitude. I would express my gratitude to my sister who actually pioneered this therapy in our part of the world, and we are happy to see that we are being able to deliver this, and we are able to deliver this effectively, safely, and in a consistent manner over the last 3 years. So, thank you.
Thank you, Dr. Gopi. It was a nice talk. And we understand more and more procedures of cryoablation of pulmonary isolation are done with good success. We are already running short of time. I don't know whether we can permit 1 or 2 short questions. Yeah.
Excellent presentation, sir.
Yeah.
That basically what all complications we were thinking that can happen, you have covered all, radiation, everything. Ultrasound wise, the puncture, it is intravascular ultrasound.
It's intracardiac echo. So vascular access is ultrasound guided.
Right.
The septal puncture is intracardiac echo guided.
Intracardiac echo guided.
Intracardiac echo guided. So we just need one more venous puncture.
Okay.
We have an echo probe going inside. It stays in the right atrium. It sees where the septum is. So you can clearly see where you're puncturing the moment it gets into the left atrium. Right. And the whole procedure of pulmonary vein isolation, whether you're antrum or not, whether you're not going deep into the pulmonary vein, everything is intracardiac echo guided. So you have a live monitoring of what is happening. You don't need to press fluoro on. And you can see live complications like pericardial effusion developing, thrombus formation, everything on a live ultrasound that is continuously being seen throughout the procedure. So that improves your safety a lot.
The phrenic vein nerve, this thing, how does that, where is the probe kept for that?
So the phrenic nerve actually, especially for the right-sided vein, the right phrenic nerve actually runs in front of the right-sided pulmonary veins, more towards the right superior and towards the right inferior.
Right.
So what we do is we take in a catheter to the right subclavian internal jugular junction.
Right.
We start pacing there.
Right.
So with the pacing, you stimulate the phrenic there. The phrenic goes from there. You stimulate the phrenic. You look at diaphragmatic contraction. So you can manually palpate the diaphragmatic contraction, or you can apply electrodes, what we call as CMAP recording, where you can actually see the diaphragmatic contraction on the ECG monitor itself. And throughout the freeze, you are monitoring manually as well as on your CMAP the diaphragmatic contraction. The moment you see your diaphragmatic contraction going down, you just do a double tap or immediately stop. So the moment you stop, because of cryo, it's reversible, you will actually have the phrenic nerve coming back. You are not burning and damaging the nerve and then realizing later. You are continuously monitoring. The moment you are seeing, you can immediately stop, and with the stoppage of cryo, blood comes in, it warms up the area and the nerve recovers.
Excellent.
Thank you, sir. Regarding paroxysmal AF, as you said, it's very clear. We have a couple of patients who are on persistent AF patients. Typically, the elderly people with biatrial enlargement, RCM has been ruled out. They are quite symptomatic even when they are in sinus rhythm. Two patients are like that. The other patient is a heart failure patient post-CAD, PCA to LAD, and anterior wall is completely scarred. For the first patient who's a non-ischemic, LA is around 50. The second patient who's in a post-CAD patient, the LA is around 40, 42. Both of them are in AF and they are around 70s. So now how you manage these subset of patients, whether you still recommend them for the pulmonary vein isolation and then you manage failure, or you want to do the AV node ablation and followed by CRT for the second set of patients?
Yeah, so wonderful question. So this is one clinical dilemma that we face. So clearly these patients have missed the bus in the initial run. So that's why they are in a stage where your LA has dilated. For us, the single most important predictor of success is the LA size. If your LA size is less than 45, we would still counsel them and go aggressive and do a pulmonary vein isolation. But if you look at our data as well, we have taken up LA of 67 as well, because we still feel at this point of time, instead of putting a device, if the person is having still a chronic persistent AFib, it's always better to try a rhythm conversion with a cryoablation for a pulmonary vein isolation. Because what we have seen is this LA size might be a component of atrial myopathy. Once you get back the patient to sinus rhythm, the LA size has come down. And these patients with a cryo, whatever benefit it gives. So what we have seen and what the West says is, for paroxysmal AFib, the success rate is 90%. For persistent AFib, your success rate is between 60 to 70%. But even that improves a lot on the quality of life. For this patient, these patients like RCM, they are very much dependent on the atrial kick. So the longer the time you can maintain them in sinus rhythm, they are going to get benefited. So we would give always these patients one shot of cryo. If they continue to be symptomatic despite cryo, that's only time when we would knock off the node and put in a CRT or a left bundle pacing.
Thank you, sir.
Nice presentation, sir. Only one thing, the rate of pulmonary vein stenosis and the infection.
Yeah. So again, wonderful things actually. I'm happy that you're thinking on it and embarking on. When cryoablation initially came, there was this issue of pulmonary vein stenosis. So they looked at it. What happens is, if you go deep into the pulmonary vein, that's when the pulmonary vein stenosis happens. So that is why, if you look at now, we are doing it antrum. We are doing it in the left atrium. We are not longer getting into the pulmonary vein. It is the antrum, which is actually the junction between the pulmonary vein and left atrium. That's where we are freezing. And if you see the balloon is not going to go deep into the vein at all. We are using intracardiac echo also for this, because on intracardiac echo, you can clearly see that only one part of the vein is inside. You can see the bulge of the balloon into the left atrium, and that ensures you are antrum. You are away from the pulmonary vein. And if you are staying on the LA side, your chance of pulmonary vein stenosis is negligible, almost negligible. So that takes care of the pulmonary vein stenosis. It happened earlier when we were deeper into the pulmonary vein. There are case reports of where people have required pulmonary vein stenting, but after cryo, when we have stayed antrum, the incidence is less than 1%. The next issue of infection, but again, all these intracardiac procedures, you need to follow the sterile precautions. The beauty is we are leaving no implant behind. So if you have done a sterile procedure, your chance of infection is just like any of the other ablative procedures.
Thank you, sir. Thank you.
Sir, my question, pulmonary vein isolation versus pulmonary vein isolation plus linear ablation plus ethanol infusion of the vein of Marshall for persistent AF, like sir's cases. What's your take on it?
Yeah, perfect. So what he's asking is what beyond PVA? So what has been, this has been a debate and been a point of research in the West. So what they have done is, they have isolated pulmonary vein. For all patients with persistent AFib, they wanted to do more than pulmonary veins. So they looked at the substrate of AFib, they looked at rotor mapping, they looked at complex fraction atrial electrograms, they looked at getting behind the vein of Marshall, doing an ethanol ablation inside the vein of Marshall, doing a posterior vein isolation. But what has been seen over time is anything beyond pulmonary vein isolation does not add to any clinical benefit. Rather, they become more pro-arrhythmic because you don't do it properly. You burn here and there, you create more collateral damage. The issue happens because the collateral damage actually takes over and the pro-arrhythmic risk, because you draw a line in the posterior wall, get into the vein of Marshall, do an ethanol ablation there, create a substrate there, you are creating a more pro-arrhythmic environment, and LA is not so forgiving. So all these patients whom they did anything beyond pulmonary isolation, they were actually having a bad time managing their pro-arrhythmia because they come back with refractory atrial flutters which require multiple procedures. So in fact, it actually turns down on the other way. They have poor quality of life after that, and that's why the dictum now is stick to the pulmonary vein isolation, rest manage with medical therapy.
If no more questions, I think we're running out of time. We can close this session. We can move on to the next session.
Thank you, sir, for your sharing valuable insights. I call upon Dr. Ravindran, sir, to felicitate Dr. Arun Gopi, sir. Next, I call upon Dr. Jayagopal, sir, to talk on
close to my heart, that's heart failure. So, we know the heart failure journey for a patient is not very pleasing one and an encouraging one. In fact, what happens, over a period of time, if you start looking at the natural history of progression of heart failure, the 1-year mortality is close to about 20% when somebody has an acute heart failure. And then over a period of time, over 5 years, 50% of them, they succumb to the illness, or close to about 90% have a problem of recurrent hospitalization. So that is when somebody has an onset and then relatively stable phase, provided they are on the classical drugs. Today, when we talk about heart failure, we know that this is worse than some forms of cancer like prostate or breast cancer. And the only way to probably protect them is by putting them on the standard guideline-directed medical therapy, which are 4 in number. This is typically for a heart failure, which is a reduced ejection fraction when you have a left ventricular function, ejection fraction less than 40%. But then despite this, you find that over a period of time, they start deteriorating. They start getting into the recurrent hospitalization phase, and then finally end up in a stage which is what's called a pump failure. And then at some point of time, either they need a destination therapy or they succumb to the illness. Now, it's also important to understand that if you don't treat them well, these patients come to your hospital with recurrent hospitalization. And as the number of hospitalization keeps on rising, you see that first hospitalization, the second, third and the fourth, the cumulative mortality keeps on increasing. So much so, this really actually ends up in a vicious cycle, and the outcome becomes even more dismal for these patients. So that's why these days we talk about the pillars of heart failure therapy, and this is in the current era, whether you look into the European Society guidelines or the American Heart Association or the American College of Cardiology guidelines, We know that there are mainly 4 therapies. One is the renin-angiotensin inhibitors, and today we have no longer talk about the ACE inhibitors or ARB, but then focus on a newer drug, which is not really new because it's really come out of patent these days, the angiotensin receptor or neprisin inhibitor, which is what I'm going to speak about. Of course, the beta blockers are very important. The mineral receptor antagonists like the aldactone and the eplerenone again is one of the pillars. And finally, the newer drug, the SGLT inhibitors, which is like the statin of the decade. This actually has really changed the way we look at heart failure. It's not just a reduced ejection fraction, but even the preserved ejection fraction where it has got a role. Finally, none of us should really be not looking at the congestion for a patient, because loop diuretics are also an integral part of heart failure therapy. Now, it's just not initiating. The problem is that when we looked into the registry, because I was fortunate enough to conduct a large registry in the country, close to about 10,000 patients, what we found that even in acute heart failure hospitalization, even in the tertiary care centers, only 25% of our patients receive all these 4 guideline-directed therapy. And it's not just initiation. Patients not on GDMT, what we call the guideline-directed medical therapy, when you follow them patients, 29% of them have an increased risk of mortality compared to patients who are not on the GDMT. And not only that, when these 4 pillars of therapy came in, this is actually a seminal article by Dr. Vadaganathan, who showed that if these patients are on these 4 drugs, the importance is that if they are on these drugs, the mean survival time, for example, you look at a 55-year-old individual, the mean, he has an additional survival of 6.3 years. So what I was trying to tell you is that today, when you talk about cancer, you talk about remission. If you look at a 5-year survival rate, somebody survives, you call it as a cure. Likewise, if you are on a 55-year-old man is on these medicines, the chance is that he has a 6.3 years of extra life. Likewise, if you look at just the hospitalization part of it, the projected difference is about 8.3 years. So that's the kind of difference that a guideline-directed therapy makes to a patient. So that's where the role of ARNI, the angiotensin receptor blocker, comes in. And the heart failure trajectories, if you were to look at the group of patients, we talk about ejection fraction as one of the ways to differentiate. You have somebody who has a reduced ejection fraction, typically with an EF less than 40, or somebody more than 40 has got a preserved ejection fraction. Because if you had look at why this is happening, in fact, you look at on the left-hand side, reduced ejection fraction of more of coronary artery disease, cardiomyopathies, following myocarditis, drugs, or let's say the cancer chemotherapy, all these things, they would lead to a progressive myocardial deterioration, volume pressure overload. That's what happens. And in the other end, with preserved ejection fraction is a different entity where you have more of a impaired, you have more of a stiff ventricle, which has got a filling abnormality, and increased cardiomyocyte stiffness, which in turn leads to all the problems. So I think the difference is important, because if you understand this, that's where the role of sacubitril valsartan really comes in. Now this in heart failure has been a sort of a game changer, because when this was introduced about 10 years ago, none of us believed that this could impact the therapy so much. This has 2 components. One is the angiotensin receptor blocker, which we all know works on the AT1 receptor and actually prevents the vasoconstriction, where the blood pressure, the sympathetic tone, aldosterone, fibrosis, everything is targeted. Whereas it's also got an effect on the vasoactive peptide system, where it actually acts through the bradykinin. In fact, I was mentioning to some of our own colleagues here, the only problem that you have is that the bradykinin levels come up. So much so, when these patients are on a very high dosage of these drugs, some can have the distressing cough that you see with ACE inhibitors. So this is actually a combination molecule which has got a vasodilator effect on one side and prevention of vasoconstriction at the other end. That's how it works. So the trial, this therapy, which brought in this therapy, is a paradigm heart failure trial, where this was compared to the enalapril and showed that there was a 20% risk reduction when these patients were put on, the chronic heart failure patients were put on this newer drug. And it's not just 20% reduction in the primary event, but also in terms of the cardiovascular death and also recurrent hospitalization. When you talk about heart failure, not just a mortality. In fact, Dr. Arun Gobi was stressing on the quality of life. Today, for heart failure patients, what is more important is they can independently look after themselves and the quality of life. And that's where the recurrence of heart failure hospitalization prevention also becomes an important entity. So what did this paradigm heart failure trial show? 4.6% absolute risk reduction, primary outcome, and the number needed to produce this benefit is 1 in 27. And not only that, more importantly, just like the AICD or the cardiac defibrillator, this therapy also reduced a 20% decrease in sudden cardiac death. And the only problem which came out along with this therapy, because these are potent agents like the angiotensin receptor blockers, plus a combination of the bradykinin and stimulator, the problem was symptomatic hypotension in about 14.7%. But then the important thing was that despite this hypotension, there was no worsening in renal function. I'll come to it a little later on. So the proof of the concept actually came with some other trials also. When could you start this? They started looking into, for example, today, when somebody has chest pain, all of us know that we look for a troponin to see whether there is a myocardial infarction or some myocardial necrosis. Likewise, in heart failure, the biomarker of choice is the NT-proBNP, particularly when the patient is on ARNI. This is a marker of myocardial stretch. You also look at the troponins, which can also go out, and the ST2, which is a biomarker. And when patients are on this combination of sacubitril valsartan, all these things start coming down. More so is the effect on NT-proBNP, which was shown by this pioneer heart failure trial. So when these patients, during their hospitalization, when they had the NT-proBNP, and they were started on this therapy, sacubitril valsartan, compared to enalapril, which was the standard of care earlier, they found that there was significant reduction in the NT-proBNP, as you can see from the graph, telling us that this is effective right from the day of an acute heart failure hospitalization. So this is a very important change in the terms of management of heart failure, because today when you talk about heart failure, just like what was mentioned earlier, any therapy, at least in the cardiovascular disease spectrum, the earlier you start the therapy, the better. And this concept actually was brought in by the pioneer heart failure, which showed that a reduction of NT-proBNP starts right from the day of hospitalization. So if you are able to start a therapy like ACE inhibitor, you look at the time in days here, the estimation of time point of favorable efficacy is 14 days for an ACE. If it's a beta blocker within the first 28 days, MRI again, first 30 days. There is no point starting an MRI beyond 30 days. Likewise, the RNA also benefit comes, all these accrue much earlier, SGL2 again 28. So I think if you look at the therapy of heart failure, most of these agents should be on board at least within 1 month of diagnosis of heart failure. So much of literature came in, the consensus pathway, they actually, major takeaway which came out of this is that ARNI is a first line without the need for a pre-treatment. So when this drug was initially introduced, it was thought that this could substitute an ACE inhibitor like an enalapril, ramipril, but then you needed a gap of about 2 days for the ACE to be washed out and then to start this therapy. But then today we know that with all the kind of data that is available, ARNI could be introduced as a first line even before you start these patients on an ACE inhibitor, ARB. And of course, the second thing which came out is also, which I am not focusing here, is the SGLT inhibitor as one of the foundation pillars of heart failure therapy. And what is important is that for a physician, it is clear, it has to be clearly understood that all this works synergistically. There is no point just adding a beta blocker or an ARNI. You need all the 4 drugs, the MRA, the SGLT inhibitor, all these 4, and the low dose of all 4 drugs actually act the same way. In fact, people have gone further, one step further, by trying to introduce all these 4 medicines together when the patient has relieved of congestion, and then to hike up the dosage of drugs within the first 2 weeks, which came, the proof of concept which came in from the strong heart failure trial, which showed that these patients really did much better than those patients who did not receive this therapy. And why am I stressing on this ARNI today? Because you start looking at the conventional agents like the ACE inhibitor, all of them for sure, if somebody cannot afford this drug, these drugs are effective. The reduction of mortality is close to about 15%. But then when you use an angiotensin receptor blocker, which is a combination of both these agents, you find that there is an added advantage in terms of decrease in mortality, is what is very clearly seen from this figure here. So that is why this has really become the cornerstone of therapy in heart failure. And not only that, this is one of my favorite slides, because there has been no drug which has been known to reverse the ventricular function. For example, you look at this data, which showed that if you follow these patients over, this is called the Prove It trial, you follow these patients on ARNI for a year, and you look at the baseline left ventricular ejection fraction. Over a period of 1 year, close to about 10% improvement with the left ventricular ejection fraction has been, and this has been the pattern that we have also been seen. In fact, some of the cases that I share here, some of them have been listed for transplant with an EF of 20, and some of them have near normal LV function. That's a kind of difference that you get to see. But on an average, you would see, even in a patient who has got some amount of damage to the left ventricle, about 10% is what you see, and some of these cases even have had a 13% in this particular trial. So the 12 months therapy has been very effective, and this really calls for an early initiation of ARNI. And but what is more important also from baseline, in fact, when you have an ejection fraction less than 35% today, and then somebody has particularly a ventricular arrhythmia along with that, these are candidates for ICD, because this is one therapy which can prevent them from sudden cardiac death due to ventricular tachycardia. But then patients of this kind with a low ejection fraction, once they have been initiated in ARNI, the substantial improvement in the ejection fraction has actually had an impact on this ICD therapy. They no longer become candidates for ICD. So this drug actually has prevented a lot of patients going on for ICD therapy as well. So I have mentioned about the reduction in mortality, the reduction in the ventricular arrhythmias. More importantly, we talk about the quality of life, that's what the reduction of hospitalization. There's been a significant reduction of hospitalization, 40% reduction, and over a period of time when patients are initiated on ARNI. The proof of the concept has clearly to be understood what happens if you withdraw this drug. In fact, there's a small trial. In fact, the other day I was talking to one of the big names, Bernard Gersh, on this particular therapy, the TRED heart failure. What they did was, suppose somebody has improved so much, why don't you de-escalate this therapy? Today we talk about, somebody is on 2 antiplatelet agents. At the end of 1 year post-PCI, the aspirin can create a GA bleed. Why not a single drug? Today we know monotherapy is effective. Likewise, people started thinking, once the LV function improves, why not stop one of these drugs and see? And that was this trial. When these patients on therapy doing well, when they were taken off this, they found that these patients started deteriorating, worse outcomes, following withdrawal of drug therapy. And then, not only that, once these patients deteriorate to that situation and then you try to reintroduce the drug, it may not work. So I think this has to be very clearly understood. Once you initiate these patients on this drug, this has to be continued on an indefinite basis. So it's very clear, evaluate trial showed that there is an improvement of LV function, which I again want to stress, and there has been no better drug for this therapy. Today it is accepted that you can use this for a de novo heart failure. Even on patients who are A's and ARB naive, you don't have to put them on this and then put them on later. Even on patients with low NT-proBNP levels, one must understand heart failure is a clinical diagnosis. In fact, you don't need an echo for diagnosis. Professor McMurray says that you have a patient with heart failure, breathlessness clinically, the next step that you do is to confirm that by an NT-proBNP. If the NT-proBNP is high, you're fairly certain it's a heart failure. Whether you have a look at the LV ejection fraction, whether it's preserved or low, the drug of choice is an SGLT inhibitor because it's been proven all these kinds. So, yeah, low NT-proBNP, again, it's a clinical diagnosis. You could still use this. Even low doses, it is recommended you start with 50 milligram BID and then go up to 200. But even low doses have been found to be effective from a sub-analysis of the paradigm heart failure. The problem that physician encounters, it's not just a physician inertia, the problems are really there. For example, 3 things which physicians are bothered about. One is hypotension, low blood pressure, which I showed you initially. Second is, when you have a worsening renal function, people are scared to write ACE or ARB. Same thing with an ARNI. And the third important thing is the potassium levels. So what are the tips to optimizing this therapy? Initiate these patients when they are in the hospital, because you can easily follow their electrical parameters, you look at the blood pressures, but be sure that you start this when these patients are off IV diuretics. And this was what was shown in the Pioneer trial. Always start with a low dose when you're worried about the blood pressure. Make sure these patients are not dehydrated, because that will really help you to keep this going. And the third thing, when you have a borderline blood pressure, see, you must understand that there is something called a symptomatic hypotension and an asymptomatic hypotension. Don't be worried when a patient is not symptomatic. If there is a borderline blood pressure, the first drug that you would reduce is the diuretics. And then titration of GDMT at home. Once you are this, you can send them home. This is what is shown in the transition trial. This will really help you to. And direct to ARNI approach, you don't need an ACE or ARB. Start early, and then that will really prevent LV remodeling. So the uptitration of sacubitril valsartan in outpatient, people are generally scared to go up on the dosage. In fact, the question asked by the patient is also, do I need this higher dosage of medication? But then for them to get the desired result, it's important to understand that you need to titrate from, and it's possible. 61% of the patients, if you are really Heart failure patients are the only patients who really would need the physician's attention little more. And this cannot be done by cardiology. In fact, the number of heart failure, it's about 1% of our population. Within a 140 crore population, this is a huge number. And a 10,000 or 12,000 qualified cardiologists alone cannot manage this. So it's important to understand that when you have a heart failure patient, spend some time with them, look at the pulse and blood pressure, the body weight. You keep escalating the dosage to the guideline director. 61% of these patients post-discharge, they could achieve, provided you are caring for them. And secondly, if you put them on these patients, sacubitril valsartan, simultaneous GDMT optimization is also possible, as has been shown by many trials. So the safety topics is what I thought I should really focus on. 3 in number. One is hypotension, systolic blood pressure less than 100. Well, it's seen in a good percentage, about 15%. Potassium levels, well, more than 5.5 is 17.8. More than 6 is very small, it's 3.1. That is what you really need to be scared about. Deterioration, renal function. It's always possible that in heart failure, you use a lot of diuretics, you lose multiple drugs, the serum creatinine might actually go up. In fact, when you use SGLT2 inhibitor, it's also important to understand that the GFR deteriorates, the renal function deteriorates a bit. In fact, in the Western countries, it's become a standard practice when you start them on SGLT2 inhibitors, you don't even look at the renal function. There will be a temporary decline in renal function which will become normal little later on. Well, that is there. These are the major things that people are worried about. And in the Western population, fortunately, we don't get to see this angioedema. So many of our patients are on ACE inhibitor. None of them really. Same thing with the bradykinin. Some patients can develop angioedema. This is not seen very much in our country. It's more of the white population. So the frequent barriers are 3 in number. But then when you start looking at it, it's not just ACE, ARB, or the beta blockers. The RNA, all these drugs, again, are very important. Amongst the reasons given, hypertension was perhaps the most common. So that is what I was trying to tell you again. Lower blood pressure RAS inhibitors, when the patients have a heightened activated neurohumoral system, the blood pressure is on the higher side. This is vasoconstriction. And when you have this RAS inhibition, the efficacy is actually about the blood pressure comes down. Antagonize these effects and reduce afterload, and this can lead to lower day. The data in the literature suggests that the lower BP is actually a marker that your treatment is being effective. So if your blood pressure is really becoming normal, then you know it is not an efficacy of the drug. But then understanding the concept of hypotension, the main limiting factor is not hypotension, but the lack of understanding the concept. For the diagnosis, I think if somebody is symptomatic and has got a blood pressure less than 90 is a different kind of an entity than somebody just having a blood pressure of 90 and not being symptomatic. Therefore, any change in the therapy, symptoms of hypotension need to be present. That's important to understand. And again, as I had mentioned, what you need to do is reduce the dosage of diuretic, then reduce combinations like nitrate, which are often prescribed. These are unwanted. I see a lot of prescriptions, isosorbate nitrate plus hydrolysine in the context. But then before that, if you can start these patients on RNA, that would be the way to go about. And the impact of sacubitril valsartan and low blood pressure, it reduces the risk of, even in patients who have low blood pressure, if you look at the literature, it's find the risk of sudden cardiac death and heart failure hospitalization is much reduced, even if the blood pressure is on the lower side. And the risk of death in heart failure reduced after hypotension episode, if you start following them up, significantly lower risk of death with sacubitril valsartan despite hypotension. So the message I'm trying to convey is that don't be scared about hypotension, but then you need to be really following up these patients well and make sure that these patients do not have any renal dysfunction along with hypotension. Now the second important thing is hyperkalemia, which is not okay. All of us know that potassium more than 6 is again dangerous. With growing number of CKD and heart failure patients, again, and not only that, these patients will be on an MRI also. So if they are on hyperkalemia, the first drug that you probably have to withdraw is probably an MRI. And then impaired renal function increases the risk of hyperkalemia. Today, the recommendation guideline-directed therapy, if somebody has hyperkalemia, is to use one of those modern drugs like patrimer to actually counter the hyperkalemia. But then in a given patient, sometimes it's difficult, may have to come down on the dosage, and maybe the impact of hyperkalemia is significant. Reduction of ACE inhibitor therapy leads to poor outcome, but then sometimes this is a problem where you may have to probably come down to the dosage. Never combine an aldactone or a torsemide. Probably you can switch over to a furosemide, which probably can mitigate the effects of this hyperkalemia to some extent. So the impact of sacubitril valsartan potassium levels, again, serum potassium levels was persistently lower with sacubitril valsartan. If you were to compare with an ACE inhibitor, definitely we have the data to suggest that sacubitril valsartan has less effect on hyperkalemia. But then this is an area where you cannot deny, you need to be a little more meticulous in the follow-up of these patients. Incidence of hyperkalemia, if you compare with the MRI treated patients, and that is often a matter of concern. And the first thing that you would probably do is probably to either discontinue MRI and then continue the sacubital valsartan. But then the lower incidence of elevated creatinine with sacubital, if you were to compare with enalapril, definitely this goes. Again, this is a problem. You might, in an elderly patient with a borderline renal function, you initiate on this agent, you might find this. So it is again important that you really need to follow up then. But then the discontinuation of treatment due to renal dysfunction is quite low, at least in the trials that we have seen. So the improves. Not only that, you follow up this patient, you find that there is a temporary improvement in the EGFR and real world evidence with CKD. But again, I think a word of caution, because it may not be possible for a physician to really get the electrolyte and the serum creatinine done if you have really the very high index of suspicion of a renal dysfunction, probably the way to go about is to reduce the dosage of drug, but then not to take away the drugs completely. Because we all know it reduces the risk of worsening renal function, 11% reduction, risk reduction, as compared to ASARB in heart failure reduced ejection fraction. So it's also important that you understand, today we don't no longer look at the creatinine levels. I think it should be a good practice to look at the EGFR levels. If the EGFR is more than 60, you don't need a dose requirement adjustment. But if it's between less than 30, between 30 to 60, again, no dose requirement. But then less than 30, you always initiate on a low dose, take your time to really escalate, and then be watchful on the potassium levels. We also know that the empagliflozin has an effect on the pulmonary artery pressure. Similarly, the early reduction in ambulatory blood pressure, this is actually a new thing called the CardioMEMS, which is actually a monitoring system which is in your system. And they find, with this, it has also been found out that the sacubital valsartan has been found to be useful. So I think there are a lot of barriers which I have been trying to address: hypertension, renal dysfunction, hyperkalemia, and these are the ways to go about. But I think finally, it's not just the trials, but I think the real-world registry is what tells you about the efficacy and safety. This is one thing which I picked up from the literature. Sacubital valsartan safety profile, over 2.6 million of post-marketing data. They found that this is to be a very, very useful drug. But again, certain groups need special elderly, those with borderline renal function, patients with MRI. So today, ARNI has become a preferred therapeutic approach in heart failure reduced ejection fraction. And this is just what has just come up. This is called a SARA trial. 3 days back, AHA, this was published, where today we know that one area where we are really worried about is people, the malignancy is on the rise. All the newer drugs are deleterious to the heart. When they are on these cardiotoxic agents, today the recommendation as per the guidelines is to start them on a beta blocker or an ACE inhibitor, ARB. But this is something which has really been exciting. I think ARNI lessens anthracycline cardiotoxicity. This has been studied quite well. And it's found to be, this probably might be a game changer in the cardio oncology practice as well. So I think a lot of new things are coming up. And then I just wanted to show one of my patients also. This is one of his latest, sorry, the order is set back. This is a normal ejection fraction. In fact, this guy was actually, this is an elderly patient who had a concentric LVH and started on acute heart failure, started on this drug, had a very poor LV function. That was the kind of mode that you saw. Of course, this is remarkably improved. And there have been instances where this is, again, another patient of mine, which actually this is a young guy who was posted for listed for a transplant, earlier. And then, but then we found that, sorry, this is a case who had a severe LV dysfunction, inferior wall MI, nothing was happening. Started on, you could see the kind of LV which was dilated and all that. The global longitudinal strain was so low. This patient was initiated on this. And today, when he came for this is in 2021, started an improvement. I saw him last week. His EF is almost near normal. So I think that's the kind of effect that this drug is really has. So I think the take-home message here is heart failure is high mortality, worse than some forms of cancer. I think the moment you see heart failure, that should be a red flag for the physician. This is an eminently treatable condition. 30 years ago, we did not have any therapy. Today, we have 4 guideline-directed therapy, which causes substantial reduction in mortality as well improvement in quality of life. ARNI has been a game changer. The improvement of the quality of life, in LV ejection fraction improvement as I had shown earlier, and not only that, sudden cardiac death prevention. In fact, many patients now don't need an ICD after ARNI has been introduced. But then there are a lot of barriers. I think the physician inertia, when we looked at a study from the Asia Pacific, maximum for the survey came from India. We found that 80% of the patients were not aware of what they were on the medication, and 72% of the physicians did not know what heart failure therapy was. So I think that needs a substantial change, and that's why this therapy is very important. Barriers like low blood pressure, renal dysfunction, hyperkalemia, it can all be managed properly if this is really looked into. Thank you all for the kind attention.
Thank you, sir. I think other topics are on heart failure, so we'll have discussion together. Let me invite Dr. Jayagopal sir to felicitate our panelists. Sir, Ramakrishnan sir. Ateep sir. Dr. Prem. Dr. Ramasamy sir. Dr. Bivin and Dr. Jagadishwari madam. Let me also invite Dr. Jeevan Chandra sir to felicitate our speaker, Dr. Jayagopal sir. We'll move on to the next session. Let me invite the chairperson for the next session, Dr. Rahul, Dr. Saravanan, Dr. Ranganathan, Dr. Balamurli sir, and Dr. Tirumurugan sir. Let me also invite Dr. Jeevan Chandra sir to stay back and chair the session. So let us move on to the next topic of the session, newer approaches in heart failure management with VersiGuard. Let me also invite Dr. Sivaraksam sir, the senior cardiologist from Chennai, to deliver his talk on newer approaches in heart failure management with VersiGuard.
Thank you, Dr. Lawrence, for bringing me here. I've been associated with Lawrence for nearly a decade. I was privileged to open the electrophysiology department for him. And now my talk is going to be short for a few reasons. One is lunch. Second is Dr. Venugopal has made it easier for me. And third is Christmas fast approaching. Lawrence has made me bring like a Christmas father 2 new things, gifts to you, other than what Dr. Venugopal has already talked. I do not know how to. Now, we have already been explained that heart failure is like cancer, and the mortality is worse than a cancer, and therefore in the past 10 years, from 2015, a lot of trials have been conducted and a lot of newer drugs, and finally we are now set with 4 pillars. As he has beautifully told, these 4 pillars should be started simultaneously at the earliest to improve the heart failure, mortality and morbidity. Because 25% of patients discharged following heart failure hospitalization will die or be re-hospitalized within 13 days. It shortens life, impacts quality of life. That's the most important. He was telling most of the patients have improved. It may not be ejection fraction like the photographs that he has showed. Many people come after a month's treatment with all the 4 drugs. You check the EF, it may remain to be the same, but patient will say, ever since I have started taking all the 4 drugs, I am feeling fine. I am able to do my normal day-to-day activity. This is called KCQS, Kansas City Cardiology Questionnaire, Quality of Life. They all score very well in the quality of life, but the risk persists. This is a paper in which one of the main authors is our Dr. Venugopal, in which he says, observations are LVEF less than 40%, you have 70% of patients. In-hospital mortality is 7%, 30-day mortality is 12.35%, and 30-day re-hospitalization is 7.98%. You don't worry about re-hospitalization. When they go from one consultant to another consultant, you can take it, they are not stable. That is almost equivalent to worsening heart failure. What is worsening heart failure and what is acute decompensated heart failure? Are they same? Sometimes yes, many times no. This is what we should understand. The worsening heart failure is one in which the patient has heart failure treatment, all the 4 pillars, suddenly requires an increase in diuretic dose orally or on admission with IV diuretic dose or IV vasodilators or inotropes. This is called the definition of worsening heart failure in a chronic heart failure situation. ADHF is acute decompensated heart failure. It can be a worsening heart failure. It may be de novo for the person to develop for the first time. So latest, we have to understand certain names, that is new onset or de novo heart failure when the patient comes for the first time to the hospital with heart failure symptom. Worsening heart failure, I've already told, because either oral or IV therapy or hospitalization. Improving heart failure, we know it is EF is improving, symptoms are improving. Persistent heart failure and heart failure in remission. One of the latest papers very clearly says, don't say any patient has got stable heart failure, because there is no stability in heart failure. So when you discharge the patient, tell your registrar to say you have optimized the treatment for heart failure, not stabilized the treatment. And despite the use of heart failure medications, patients remain at the risk of cardiovascular death. 1 in 6 heart failure patients will develop worsening heart failure, and chronic worsening of heart failure accounts for about 80% of heart failure cases. Now, residual risk for heart failure remains despite the use of heart failure medication. This is an important slide. This is a paradigm HF trial, which had used ACE inhibitor, beta blocker, and MRA, and above which they have added ARNI. And what has happened? There is a definite reduction of 20% above ACE inhibitor enalapril. Right. But still the risk remains. Take the DAPA-HF. Similarly, when you add the study drug over the regular drugs, dapagliflozin reduced heart failure hospitalization by about 25%. And when you come to Emperor reduce, same thing happened with empagliflozin. They all reduced, but they have not finally taken away the risk of residual risk. And even patients on quadruple therapy, he has been telling us about quadruple therapy. Yes, the number of patients who are getting admitted has come down definitely in all the hospitals due to heart failure hospitalization once you institute all the 4 drugs. But in spite of it, what happens? Even rates according to background heart failure therapy, triple therapy or quadruple therapy, you still have experiencing primary outcome event. Primary outcome event is cardiovascular death or hospitalization for heart failure. So, what is science doing? Every time, in the past 10 years, as he said, previously we never had drugs, now we have 4 drugs. Though, after the 4 drugs, it is either ICD or cardiac transplantation or LVAD. So, people are experimenting and trying to bring more and more newer drugs by acting on more and more newer pathways. As he has beautifully shown in one of his slides, that I don't know what's happening. No, go back. Go back, 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 back. Yeah. But as the number of admissions keep on increasing, the survival becomes much lesser and lesser. The median survival comes down after 2 admissions, 3 admissions, 4 admissions. So what has happened is, so far, we have seen the neuromodulation by beta blockers and RAS system, cardiorenal by SGLT2. Is there any other newer method so that we can improve their survival? The newer method is what is called a nitric oxide, soluble guanine cyclase GMP signaling. That is, with nitric oxide or without nitric oxide, the soluble guanine cyclase will increase the availability of nitric oxide. Now, how does all this atherosclerosis happen and worsening of the disease happens? It is because of endothelial and vascular dysfunction, because of reduction in availability of nitric oxide. And now, if you look at these trials, he has already told, whenever you want to assess a drug, one is symptomatology improvement, second is hospitalization for heart failure should improve, and third, clinically and in the lab, you should have reduction in the NT-proBNP. So Paradigm HF has taken an average 1600, 1400 in DAPA HF, and Emperor it is about 1900. When it came to Victoria trial, That is a new drug that I'm talking about today. This Victoria trial has included people who had an average of 2,816 NT-proBNP. And what they had found is not only the reduction in mortality, there is also a reduction in NT-proBNP. The moment you start, within about 2 to 4 weeks, there is a reduction in mortality. Now, symptomatic chronic heart failure, worsening heart failure, and this is what they have taken in Victoria trial. Recent heart failure decompensation, less than 3 months after a heart failure hospitalization, or 3 to 6 months after heart failure hospitalization. These are all outpatients. They came with decompensation, they came with increase in oral dose. This is 17% is hospitalized patients requiring IV diuretics as the process of worsening heart failure. All these people have been recruited into this trial. And what was the outcome? If you look at it, ARNI and patients on triple therapy, and all these patients, they have been on, if you look at this one, 93% were on beta blocker, 73 on ACE inhibitor, 70% on MRA, and 14.3% on ARNI. Because they were on ACE inhibitor, 73 majority, and because it was a 2020 trial, only 14% were on ARNI, and patients on triple therapy is actually 60%, and patients who are having ICD is about 30%, biventricular pacemaker is about again 15%. All these patients were put on Versigouat. Did you get an improvement? There was a 10% reduction in mortality and cardiovascular death and heart failure hospitalization. So you have one more mode of action for treatment of heart failure, that is improving the nitric oxide through soluble guanylyl cyclase. And what does this show? It shows Versigouat improved both primary and secondary outcome in patients with chronic and worsening heart failure in the Victoria trial. It reduced primary composite outcome, that is cardiovascular death and heart failure hospitalization, and separately it decreased each one of them. Cardiovascular benefit of Versigouat is mediated by an early and sustained reduction in NT-proBNP level. You can see it starts reducing within about first 2 to 3 weeks and it maintains. That means it should also be continued, like he said, like all other drugs. And how much? Versigouat has a favorable safety profile. Is it a safe drug? Because SGLT2 is scoring over the other 3 drugs because there is no hypokalemia and there is no hypotension. Similarly, if you look at it, they have achieved a 10 milligram target dose at the end of 12 months, but the starting dose in the Victoria trial is 2.5 to 5 milligram. I have started most of my patients on 5 milligram because the cost of it is a single 10 milligram tablet, and you can just ask them to take half a tablet, and after 2 weeks, every 2 weeks, you can escalate till you achieve 10 milligram. And the incidence of syncope is that of equivalent to the placebo, and the incidence of adverse effect is also equivalent to or less than the placebo. So side effect profile is very good. Is there an hypotension? There is no hypotension seen with Versigouat use, but there is a minimal hypotension if the patient is already taking ARNI. This is what is it. There is no use of ARNI, there is no hypotension. When the person uses ARNI, we have to be careful if he goes in for minimal hypotension. As has been explained by Professor Venugopal, all that is required is reduce the dosage of diuretic and don't stop the tablet. The prevalence of worsening renal function, there is no renal function worsening, and no clinically significant differences in sodium or potassium. That is why I said it is biochemically neutral. And if you look at this chart, the benefit of Versigouat was observed in irrespective of ARNI use at baseline. If the patient has been using ARNI at randomization, there was a benefit. No ARNI, it looks slightly better. And cardiovascular death, ARNI at randomization, very much improved. So whether the patient has already got ARNI or not, please be free to use the Versigouat. And if you look at this one, this is what I want you to see. The number needed to treat, as when it is lesser and lesser, you get more and more effectiveness of the drug. If you look at Paradigm HF, if you look at that one, SGLT2, number needed is 39. DAPA HF, number needed to treat is 25. Victoria trial, number needed to treat is only 24. You would have, we would be coming across another new drug called the Mecabil, that is galactive HF trial, whereas the number needed to treat, omecamtiv mecabil it is called, but the number needed to treat is 48. So even though the trial was over in 2020, still it has not gained a momentum. So Versugat is consistently recommended for patients with heart failure with reduced ejection fraction following a worsening of heart failure. We have already defined what is worsening of heart failure. And as I have told you, you can start with 2.5 milligram OD, increase it to 5 milligram and then to 10 milligram. Now, a word about this lecture, Eugene Braunwald article in Lancet in 2014. In 2014, he said there are about 38 million patients worldwide with heart failure. Now, the people have started living longer. When you live longer, all these days we were thinking that we were getting only cancer. Now we know in 2022, the number of people with heart failure from 38 million in 10 years, in 8 years, it has increased to 70 million. In 2030, it is projected to be 120 million. And this is the article I was telling you about misperception about stable heart failure. No, there is no heart failure which is stable. And therefore, when a patient comes, not only these 4 pillars, you can even try, if there is worsening event, Versugat as another add-on drug. It increases the survival, reduces hospital admissions, improves symptoms and quality of life. And the last word from Subodh Verma and Eugene Braunwald, clinical trials and drug discovery are only part of the overall solution. The knowledge gain needs to be translated into patient care. So what is necessary is, we should try to put the patients systematically, not sequentially, simultaneously on most of the drugs for heart failure, so that we gain a reduction in NT-proBNP, an improvement in ejection fraction, and improvement in quality of life. I think.
Thank you, sir. Thank you for the wonderful presentation. I think in the short of time, can allow 2 questions on heart failure. Either panel can initiate or a question from audience.
Is being working on the nitric oxide pathway, sir, does it interfere with any other drugs like isosorbide or tadalafil or sildenafil?
Right. In the Victoria trial, none of them were taking any of the nitrates. So as he was telling, if they are having nitrates, with RNA usage itself, it has reduced the blood pressure by a few millimeters. We have to be careful.
Okay, sir. Any other questions from?
Sir, is it can form with the drug or it's all on drug or when it fails?
Pardon, sir? Come again?
Can we start as a first visit itself or when it fails, all the 4 drugs fail?
So far, there is indication only for worsening heart failure. Because what is accepted today by GDMT is first 4 pillars. We cannot straight away start. But clinically, theoretically, it looks wonderful to start straight away. But so far, there is no indication. We are always guided by the guideline. What is your opinion, sir?
No, I think that's a wonderful question because of late, there are patients with heart failure who do not have enough blood pressure to initiate on a guideline-directed therapy. Some of them have already a creatinine of 2 milligram, and so there are a subset of patients who cannot be on, the potassium is high, none of these drugs can be started. So this actually is an area where if they are symptomatic, they can be started on Versugat because this is a profile which will not affect any of this. And then this is what we have seen over a period of time, everything starts improving, you can initiate them on a GDMT, but not for a patient who has a normal renal function, not for somebody who has a good blood pressure, not for somebody who has a normal potassium. So if they have some barriers to initiate GDMT, this could be a choice.
What prevents it starting?
Well, that's what the future is going to be. I am sure over a period of time, there is a lot of research going on in this. In fact, preliminary data is also very encouraging. I won't be surprised if this becomes a 5th pillar.
Actually, it will become a 5th pillar in future, as he says. Because theoretically, pathophysiologically, it's a very good mode of action. And most of our patients have low BP. So I always feel these drugs are like using trimetazidine for coronary artery disease. It's very safe.
Sir, the side effects which you have seen with your usage, what 2 patients have started, some people complain like rigor symptoms. Any side effects like that?
I have started in about more than a dozen patients. I have not seen any side effects. That's why I said it is like trimetazidine. Oh. No side effects.
I think we move on to the next session.
Yes. The second Christmas present is a newer drug.
It was, Sir was very kind enough to take care of the presentation which was, has to be done. It's on dyslipidemia management. We are going to talk about newer drugs and concepts.
Because of the time factor, I will omit most of the drugs, most of the slides. I'll tell you only a few words. As we all know that majority of the dyslipidemia today is high LDL level, low HDL level, and elevated triglyceride level. We are looking for a drug which will reduce the, we will not worry about the incidence and other things. And what is important is, when you want to reduce the LDL, like we say in HbA1c, like we say in BP variability, what is important is the LDL variability is more dangerous. For how many periods of his life, that is how many months or years, his LDL has been high. Because majority of patients, our patients, once their LDL comes down to the goal level, they stop the statin drugs. So what is important is the atheroma and the cardiovascular disease, atherosclerotic cardiovascular disease, is directly proportional to the number of years they are exposed to the high LDL. So what is important is we should try to categorize them to bring it down to majority of the time so that the plaque burden is directly equivalent to cumulative exposure of to LDL-C, and we should try to reduce it. We should impress upon the patient that he should keep it reduced for a prolonged time. And now most of you know the guidelines which say, I will simplify the guideline. Forget about the high risk, low risk, very high risk. If the patient is an younger patient who comes for routine checkup, try to have his LDL cholesterol to around 106. If the patient has already had an atherosclerotic cardiovascular disease or a positive treadmill test or a wall motion abnormality, try to bring it down to 100. If he has had an angioplasty or a bypass surgery, LDL should be brought down to 70. If he has got additional risk factor like diabetes or peripheral vascular disease, try to bring it to 50. And LAI guidelines, Lipid Association of India says, bring it down to below 50, preferably towards 40. And can we achieve it? There have been a lot of trials, but can we achieve it? What is important in this slide is, if early and sustained non-HDL-C results into lowest risk of cardiovascular outcomes. The lowest risk of non-HDL, that is, it includes triglyceride also. So non-HDL, when you talk, it should be kept below. If a patient is at a high risk, it should be kept below 85 milligrams or preferably 70 milligrams, that is 2.2 millimoles per liter. And what happens is, if you use the Swede Heart Registry, it is a registry with 56,000 people, followed up after the first MI without prior history of ASCVD, and what they had found is, if they had achieved an LDL in the first 2 months, lowering of the LDL, and sustained it for 1 year, their MACE is reduced by 20%, all-cause mortality is reduced by 15%, and MI is reduced by 24%. But if you take the scenario 1 and scenario 2, this is the most important slide. That is achieved at 2 months, but not maintaining at 1 year, and not achieved at 2 months, but eventually at the crossing of 1 year is achieved, still the MACE is around 14%. So what is important is, try to achieve LDL reduction at the earliest, and try to maintain it at least for more than a year. This is what 56,000 patients in Swede registry has taught us. Now, what are the lipid lowering therapy? We all know statins. And statin intolerant, or you want to reduce it immediately, you can combine it with maybe 10 milligram or bempedoic acid. And suppose the patient comes with an LDL of more than 179. The ideal thing is to combine these things. All these days we are using ivalacumab. The MAB we were using, that is high intensity statin plus STMIB, as I told you. PCSK9, that is ivalacumab, available in India with a high dose statin, so that we can immediately bring it down. If you use a high intensity statin, you can reduce from the base value 50% of the LDL cholesterol. And if you use it with PCSK9, you can reduce it by 70%. And PCSK9 plus high intensity plus STMIB, it is 85%. But why then there is a new drug? That's the most important. If a person is taking statin, he has to take in a year 365 pills. Maximum tolerated statin, again 365. If it is MAB, theoretically, you should give 26 injections in 52 weeks. In 52 weeks in a year, you have to give him 26 injections. That is every 15 days. Now, the latest one is what is called the highest medication burden is with statins, which could lead to imperfect adherence. That is why patients do not. But if you tell the patient you are going to have one injection now, one at the end of 3 months, and one every 6 months, if you can afford, that is the best one, and that is what is called inclisiran, which is now coming to the market, except for cost factor, easy to administer. You can give the first dose, you can give the second dose at the end of 3 months, and the third dose then on every 6 months. And how does it act? See, we know how does the MAB act, evolocumab, but this acts by what is called small interfering RNA. It changes the concept of cholesterol production itself by simulating and adhering to the DNA and changing its signal. Now we look at it. LDL-C variability, an independent predictor of cardiovascular event. Increase in LDL-C variability, like I was telling about glucose variability and BP variability. If LDL variability increases, there is an increase in death of 23%, stroke by 17%, and therefore we will have to start and try to, in the real world, try to keep it as low as possible. MAB, we have already seen the difference, and this is inclisiran, inhibits translation of PCSK9 mRNA in the liver, leading to reduced PCSK9 synthesis. Whereas MAB is inhibition of PCSK, this is synthesis itself is reduced, administered at a lesser frequency to maintain PCSK9 protein suppression, and as I have told you, the dosage is only initial dose, 3 months later, 6 months later, and once in 6 months. And reduction and side effects, GI intolerance, myopathy with the existing lipid-lowering therapy. With inclisiran, there is only one mild reaction at what is called the injection site reaction. That is also in negligible number of patients. And inclisiran provides effective and sustained LDL-C reduction. And what is the amount of thing it reduces? 50.7% LDL-C reduction, effective LDL reduction at day 510. Sustained LDL reduction from 90 to 510 days, effective LDL reduction at 510. So at any time you take, from the time of starting, if you are following the first 3 months and 6 months, you find a wonderfully maintained without LDL variation. What is important is it maintains the LDL-C level at a particular level so that the patient does not go in for complications. I think these are the data. I would like you to go through that. This is a new drug. If the patient can afford, it's about 1.25 lakhs. Don't get worried. If the company provides it directly, you can get it for 98,000. See, when MAB was introduced, I was one of the largest users of evolocumab. If a person buys in my pharmacy, it is 24,000. But I had never sold single vial. I had sold the maximum number of evolocumab. I asked the company to provide it directly to the patient. From 24,000, it comes to 18,000. Just with 2 injections, they gain about 8 to 10,000. Now, they have reduced it further. Similarly, if you call the inclisiran guys and tell them, they can save nearly 27,000. The patient gets benefited, and that is what is at the end of the day. And he gets a wonderful treatment with just 3 injections. And it is going to be a recommendation in most of the things. I will just see in the next 3 minutes, you can listen to how it acts. And with that we end.
Are there any questions? Can we have?
Elevated low-density lipoprotein cholesterol, or LDL-C, is the most readily modifiable cause of ASCVD from the population health perspective. The liver regulates LDL-C levels by the expression of LDL receptors, which can clear LDL particles from the bloodstream. The number of LDL receptors available on the liver cell surface can be reduced by the production of certain proteins. Production of these proteins can be specifically halted by targeting the messenger RNA encoding for these proteins through a natural mechanism called RNA interference. Therapies called small interfering RNAs, or siRNAs, have been developed to harness the natural pathway of RNA interference. Inclisiran is the first and only LDL-C-lowering siRNA therapy. Inclisiran consists of two strands, low-density the guide strand and the passenger strand. The passenger strand is attached to a molecule. Production of these proteins that allows for targeted delivery by targeting the messenger RNA encoding for these proteins in the cytoplasm through a natural mechanism called RNA interference. Therapies called small interfering RNA or siRNAs have been developed to harness the natural pathway of RNA interference. Inclisiran is the first and only LDL-C-lowering siRNA therapy. Inclisiran consists of two strands, the guide strand and the passenger strand. The passenger strand is attached to a molecule called GalNAc that allows for targeted delivery of inclisiran, specifically to liver cells. In the cytoplasm, inclisiran binds to RNA interference machinery called the RNA-induced silencing complex, or RISC. The RISC detaches the two strands of inclisiran and retains the guide strand. The guide strand directs RISC to its specific target mRNA. Once the complex has found its complementary mRNA, the mRNA gets cleaved, with one RISC complex cleaving multiple copies of its target mRNA, thereby preventing the production of the respective protein. As mentioned previously, the respective proteins reduce the number of LDL receptors available on the liver cell surface, hindering removal of LDL particles.
So once the LDL receptors are made available because of the absence of PCSK9, more and more LDL receptors are available on the surface of the liver to clear the LDL, and it becomes a permanent one because it takes a copy and produces a new mRNA which will not produce PCSK9. So it is almost like a gene editing, almost like that. But every 6 months you will have to be giving the injection, and this will persist so that you will not get, you will get more and more LDL receptors always available to clear the LDL. So this is going to be a new therapy like the previous one for the heart failure. Thank you.
Thank you, sir. I think we can have two questions again on inclisiran. Anything from panel or from the audience?
Sir, of late there much talk about ApoB, sir, rather than LDL. Of late, just about a week back, I just went to an article.
You are right, sir, but
ApoB is more important than LDL.
this happened, you are right. It was, this started when Salim Yusuf did the inter-heart study. There itself he has said ApoB should be less. And the problem why we are not able to follow that all over the world is it's very costly to estimate ApoB.
The non-HDL gives a configuration ideal HDL and LDL and ApoB, sir. These four things combined together forms the non-HDL cholesterol.
Yeah, I think you have a very important point. In fact, it's very expensive to do an ApoB, but
Very
the non-HDL is a clinician's, clinician's direct role to ApoB. So that is why the whole thing is, apart from the LDL, you also must be looking at the non-HDL, and that's why the use of ezetimibe along with this comes into the picture. So it's not just, if you look at our own population in India, in fact, you will be surprised to see that the cholesterols are not too high. Somebody comes with acute coronary syndrome, it's 160 or 170. That is where the non-HDL cholesterol comes in. I think you have a very important point there.
One more point, sir. The LPA pathway.
Yeah, that's a one-time risk of developing. You're right again, but then.
For LPA, sir.
Yeah.
Yes, sir. 5 days back, there is a molecule released, completed phase 2 trial for LPA. If it comes, wonderful, because it's a oral drug. It's called Muvalaplin. And just on 19th of November, it was released. Second phase is over. Once third phase is over, it comes. It will be a boon for all South Asians, especially Indians.
Sir,
Thank you, sir. Thank you for the wonderful presentation. Let me invite Dr. Shivakumar sir to felicitate Dr. Shivakumar sir. Jeevan Chandra sir, your question sir. Next presentation.
Sir, I have one question, sir. Yes. Every this cardiac forums, they discussion only LDL. Nobody discuss about the high triglyceride level. Talk something about high triglyceride level, sir.
High triglyceride, the guideline states, start treating it, even though the labs give 250, start treating it only if it is above 500. That too, the guidelines say for the risk of reducing pancreatitis. But all of us treat, because majority of times our high triglyceride is secondary to uncontrolled or poorly controlled diabetes. So control the primary cause, it comes down. The drugs that are available today are mainly fenofibrate. Fenofibrate with statin, it will reduce. Saroglitazar is a very useful drug, 4 milligram of saroglitazar every day. It acts in two ways. One is majority of the diabetics will also have liver disease. So what is important is it takes care of, it was introduced for triglyceridemia, but today it has found usefulness by US FDA in the treatment of fatty liver. So the ideal drug that I've been using, I see patients with thousands and more of triglycerides. I've been finding it very useful to use saroglitazar 4 milligram tablets daily. But in patients who are less than that, for their sake, because ideally the guideline says don't treat if it is less than 500 or 400. But even then the patient gets worried. So we give fenofibric acid as a treatment of choice for the high triglycerides. It is like curd and ghee, sir. 10 years they will say curd is bad. 10 years they will say curd is good. So first 10 years they said, they did what is called a nurses trial, men and women nurses trial, and they said triglyceride is a risk factor. Next 10 years they said it is not a risk factor. So however it comes, we will treat.
The cause for the high triglycerides, number one is intake of lot of carbohydrates, number one. Number two, you should take alcohol in the night. Next time morning, you go and check your PDL. It will shoot up.
Definitely, sir. That's why triglyceride, whenever estimated, it is said whether it is fasting or postprandial. Postprandial, it is always high.
Thank you, sir. Thank you for the wonderful presentation. We are in the last talk of the day, and it will be a short one. So let me talk about the new concept which is emerging, which is about DAPA care. We know SGL2 being a diabetic drug has more or less become a drug for heart failure. DAPA has shown both preventive and therapeutic effects on cardiorenal syndrome, particularly in patients with diabetes mellitus. And close to 300 publications are there right now on DAPA, and most of them are in a very high impact journals. And we know excellent data which is available across with multiple studies. And right now we have this DAPA Care is an extensive clinical program where we are going to look at multiple studies, extended studies on sub-indications and specific patient types, looking at patients who are on hemodialysis, about long-term nephroprotective role, hypervolemia patients, and patients who are on diuresis, and maybe we look at the role in heart failure and sleep apnea and CKD and renal anemia. These are the areas where we are going to look at DAPA in future. So if we can look at newer renal trials which have come with DAPA. So we all know that DAPA is a one drug where you could see a very early onset of a nephroprotective effect. Not only nephroprotective effect, when you use DAPA as a heart failure drug, among the heart failure drugs, DAPA is a one drug, or SGL2 as a group comes very early. You need to, you may be seeing benefit as early as 2 weeks. If you look at long-term benefits of DAPA and renal outcomes in diabetic patients, you have excellent data there, and you could see that albuminuria has significantly reduced when you have a new users on DAPA, and it remained at a very low levels. If you look at long-term benefits of DAPA on renal outcomes in diabetic patients who are on routine diabetes mellitus care, new users of DAPA had significantly lower rates of new onset CKD and loss of kidney function and a composite renal outcome. If you look at pharmacokinetic properties of DAPA and hemodialysis and peritoneal dialysis patients, they could see in individuals with a kidney failure who are on dialysis, DAPA was reasonably well tolerated, slightly dialysable, and had a non-accumulating favorable pharmacokinetic properties. That means you may be able to use even on a end-stage renal failure where your patient is on dialysis. And another important thing which we are able to see with DAPA is a betterment of anemia in patients with kidney disease. You could see in effect of DAPA and correction and prevention of anemia was consistent in patients with or without diabetes mellitus when you use on these patients. And if you look at SGLT2 inhibitor as a heart failure drug, and you know the diuretic effects of SGLT2 inhibitor is pretty good, and administration of SGLT inhibitors can effectively improve the volume set point of kidneys, allowing volume excretion in the setting of hypervolemia. The patients who are hypervolemic, SGLT2 can give you a lower set points, by that where you can give a patient a better diuretic control with even your pre-existing diuretic drugs. If you look at the benefit and risk ratio of DAPA in patients with heart failure whose GFR is less than 25. We know EMPA is allowed up to 20 and DAPA is used usually a GFR of less than 30. But even on patients with GFR less than 25, you could see that there is a betterment even with worsening renal function. So you could see it definitely improves renal outcomes and retards deterioration. And now data is emerging on DAPA, which improves erythropoiesis and iron metabolism in type 2 patients with renal anemia, particularly renal anemia. They could see that DAPA has changes on hematopoiesis, iron metabolism, and body composition indices in elderly type 2 patients with renal impairment, and it has a beneficial effect on patients with renal anemia. If you look at patients with frail, heart failure patients who are frail, with a spectrum of frailty, they could see that even on patients who are frail with CKD, DAPA had a significant effect. So, if you look at effects of DAPA on stage 4 kidney disease, they looked at DAPA CKD subanalysis with adults with GFR between 25 to 75 and stage 4 CKD. Among patients with stage 4 CKD and albuminuria, the effects of DAPA was consistent with those observed in DAPA CKD trial overall, with no evidence of increased risk. So it puts you in a good spot. The patients with renal disease, even the worsening renal disease, this could be a one drug of heart failure which can be used. Because you know, except for a beta blocker, most of the other drugs of heart failure management will be difficult to use on this subgroup. You have another drug which can be used on this renal subgroup where you have a significant mortality benefit which has been already proven. So if you look at DAPA along with other SGLT inhibitors, you have a significantly improved cardiorenal outcome across different patient subgroups. You have better outcome if you look at heart failure admissions, cardiovascular mortality, and if you look at in patients with reduced ejection fraction, you have a significant improvement. A preserved ejection fraction, you could see that SGLT inhibitors like already EMPA has shown significant improvement even in patients with heart failure with preserved ejection fraction. So with this, I'll close this talk. I think we can all break for lunch. If there is any questions or any queries to be answered, I think we can discuss with the speakers during lunchtime. Thank you all for wonderful listening. Let me invite Dr. Jayagopal sir for felicitating our panel. That's fine. Thank you, sir. Dr. Rahul, Dr. Saravanan. Dr. Balamurli and Dr. Jeevan Chandra sir. So I think it is my pleasure to give vote of thanks to our sponsors and our marketing team. It was a wonderful effort. I think on a Sunday morning we had a wonderful attendance. It's nice to see all our audience staying up to 2 o'clock, 2:15, beating their hunger. My sincere thanks to our marketing team for organizing this meeting. All the sponsors, Medtronic, about CR, about EP, and Boston Scientific, Sun, Cipla, Intas, and Environ. So I think I have mentioned everyone. Your participation was extremely good. A special thanks to our Sun team for keep doing an excellent PR work. I think we need all your effort in future also. Thank you all. Please join us for lunch. Thank you.